I think they want me to go pretty sooner than that. He told me at 8:45. Oh, in 1 minute, he wanted to start the opening ceremony. Nobody's getting it. But they don't use.
We have schedules to follow. With or without.
It's all. It's my content. It's all. It's all about content.
I'm just starting.
I can't realize. They don't. They don't have to see. All they need to see is me. You know what I mean? Like, and then on YouTube, you got people on YouTube.
Yeah, YouTube.
Yes. No, we'll be on YouTube and
Oh wow.
the conference.
Is that the first time?
I think so. They had it live to you.
All right.
So what is it?
Oh my God. Are you speaking about?
No, I just want a picture.
Okay, check it. Oh, this is okay, Instagram. So maybe don't want to do more. Maybe okay. Yeah. I know. I have to go for it. You want this? Otherwise,
The whole screen, yeah.
it's okay.
Yeah, it's a,
They just go up there and start talking and they pick. Or wait on. Okay.
Okay.
Microphone check.
We'll get pictures together.
let's go.
You want to take a picture? Let me get it.
Okay, look, that's.
Down
Yeah. I see it.
together.
Oh, yeah. Okay, I see. Okay.
You want here? Up here?
Yeah.
Better.
Because it's a big sign.
Yeah.
And then one here.
Here. You can oh, is it okay? Is everything? Are you from Japan? No, I'm sorry. Oh, no, what about you? Yeah. That is silent. Oh, that's so bad. She's sorry. Yes, yes. Yes, that is. Yeah, sure. So much for actually the one. This is my other one that I'm working myself. I will send it to you shortly. This is good, you know.
Oh, I saw this option. So instead of asking them, did you please me? Then I just over on. Were you wearing the glove? Oh, you let me speak. Come on. Push the button on the right, hold it down. This is a button here. I want you to hold it. Just here. Okay, take your hand off of it. So it's recorded. So all I want you to do is you can look at it. Okay. Okay. So it won't let you film there.
Yeah.
Okay. Okay, sorry. Okay. Oh,
You're so high tech.
I don't know anything about it. Yeah, it's okay. I'll see if I'm following it.
Well, you know what? Yeah, this is when you're speaking. When you're speaking, give me a
Okay. I think I'm scared. What I'm scared of is let me delete some stuff. I don't think I have room. I'm gonna go with my deleted. I'm gonna delete some stuff probably. But I'll try that and get as much as I can.
Yeah.
Ready? Maybe it's some German words.
Preparation for great marketing stars. Yeah.
What? Next. We talked to this making video clips. You could do your career. Photography. All the physical and there is a good experience. Somebody could have asked you a little bit of a thing. You might say that I need to call him. Okay. When I put one again, yes, I will get asked something, maybe ask the gentleman there. So there's a people are doing smart things. But I gotta stick on the girl. You think? It's new progress. Hello, everyone. Welcome, welcome, welcome. We're getting ready to start, if you guys don't mind. Hello, hello. A very good morning to all. On behalf of the organizing committee, it is my great honor to welcome you all to the joint gathering of the 16th International Healthcare Hospital Management, Nursing and Patient Safety Conference, and the 4th International UCG Congress on Advanced Dentistry, Dental Science, and Oral Health Conference. It gives me immense pleasure to see such a distinguished assembly of healthcare leaders, dental experts, nursing professionals, hospital managers, clinicians,
researchers, and patient safety advocates who have come together with one common mission to share knowledge, exchange ideas, and drive innovations that will shape the future of healthcare and oral health worldwide. Today marks the beginning of an exciting journey of scientific discovery and professional collaboration. We have an exceptional lineup of speakers who will cover a broad range of vital topics, from advancement to dentistry, oral health, and digital innovation, to healthcare management, nursing excellence, and patient safety practices. Together, these two parallel forms create a powerful platform for multiple disciplinary learning, collaboration, and global impact. Let us look forward to a meaningful and inspiring day ahead. I'm Miss Sharonda Brown Spence, and I look forward to an inspiring and productive day together at UCG conferences. Utilitarian Conferencing Gathering is proud to lead in organizing professional meetings, conferences, workshops, and symposiums, specializing in medical, clinical, healthcare, life sciences, and pharmaceutical fields. UCG bridges academia and industry with innovation and excellence. With 24/7 support, global reach, and a dedicated organizing team, UCG ensures every event is impactful and tailored to the needs of its participants. On behalf of UCG, I extend a heartfelt gratitude to the organizing committee, our distinguished speakers, and every participant who made this gathering possible. Together, we are shaping the future of healthcare. All right. So it's time to start with our first speaker. Yes, let's announce our first speaker. Ladies and gentlemen, our first speaker is first let me back up and I need to introduce our keynote speakers, I believe. So today we're gonna have some keynote speakers and our keynote speakers, and please forgive me if I do not pronounce the name right. I'm doing the best I can and I will make the best effort. Please come up here and correct your name if I spell it wrong. Your name is really important to me, okay? So Dr. Mahida Shavistava, a neuroscientist. We have Mr. Omar Ali, visiting lecturer and former government advisor to NICE UK. We have Mrs. Sharonda Brown Spence, CEO and executive nurse leader from the United States. That's where I'm from. And then we have Dr. Rama Walaki, pharmacist supervisor from the UAE. Now, I would like to introduce our first speaker. Ladies and gentlemen, our first speaker is Mrs. Maria Sheila Zarsadias from the United States of America. She's affiliated with Pure Heart, an organization committed to advancing holistic and integrative health practices. Today, she will present her insight talk on mechanism of efficacies of heat and cold therapies. Please join me in welcoming Ms. Maria Sheila Zara Sadez. Thank her. Thank you. I got it.
You show me like that.
Here it is.
Because I want to make sure that my expression is not showing up. See how it's showing up. Can you help me? So I want to make sure it's showing my notes. Okay.
So that's another with it. Oh, how come I don't see my notes? I need to see my notes. Yeah. There. We wanna hide the notes. Do you know how to we wanna hide the notes. It's showing up in the present and the
Just full screen.
notes. This last year was fine. Right. I don't want to show my notes in front of them.
Full screen.
It's not coming.
And then it's it's not yeah, but the notes are showing. You don't want to show the notes.
When you do full screen, it doesn't show. Right there?
It's not showing.
Huh?
It's not showing. It's not showing.
Huh?
It's not showing now. You can see.
Right, but I need to see it.
It's clear.
In order for me
But I
to
don't think so.
well, that's not gonna work for me because I don't memorize in this speech. They did it last year. It was fine. Cheryl. Cheryl.
I could have checked it previous.
We can't do full screen because I need to see my notes. Do you know how to do it?
No, you can hit, like right now, if you.
Yeah, I need to see my notes here. Because I don't know. Nobody memorizes the presentation. Okay. Oh my God. I never had this session to do. Huh?
No, it's impossible.
No, I'm talking. Oh. We gotta keep going. You know what?
You have any other?
I have,
separate
I do.
phone?
I do.
Oh,
I can
just
get
open
my.
it. Yeah.
Uh,
Your phone.
let me get my. Can you grab my laptop?
You can open the phone here.
No, it's not my. It's not on the phone. You can't see the notes on the phone.
Is it in my laptop or iPad?
It's in my laptop.
It's fine. You
So
can
I'll
click
just
here.
yeah. Let's move this here, and
No,
then
we
I'll
can't
put my
remove
notes
it.
here.
We can keep it here. We can use the clicker to change this link in your laptop. Just use the clicker so that I can present.
But it's so low. Like how much? Okay, where do I? Which one has? Which one do I? Which one? Which one? I don't know. Okay.
You're fine?
Yes.
Okay. Right?
Yeah. We can't put this. Yes. Can we put the two laptops together here?
Well,
Otherwise, it's like I'm looking down. I don't know. Okay. There you go.
accelerating for
Okay. Right. And then this one is I just do it. I have to do it myself, right?
you can change from clicker. This way.
Okay. Yeah. All right. Mahalo. Kifano. Good morning to all of you. Did you like the music? It was like really like a hopefully a digital caffeine or kind of like a brain energizer for all of us. But looks like we have many folks here from different different walks of life. So let me start by saying marhaban kaifa haluk tasharafna ani Maria Sheila. Your language is beautiful. It's truly an honor to be here and feels surreal to be standing and facing all of you. And I'm super excited to be part of this community. Your role will never ending dedication that you bring to your profession every day and the hard work you put into keeping our community safe. Your intelligence, bravery, and compassion are really the saving grace of this nation. And I hope that you welcome Pure Heart with your open heart in your industry. Pure Heart is a company that I'm immensely proud of. We are a company with integrity and determination to make a difference in this world by helping others heal. Pure Heart was founded in 2022 in San Francisco, California, USA. And our mission is to restore individuals' purity and innocence by healing the body and spirit, rekindle individuals' original light, give individuals hope to achieve their full strength and beauty. We develop and manufacture and distribute high quality, sustainable, comfortable gel packs. We are the only company in the world who focus on gel packs alone, backed with intense research and development. Our research team consulted with various existing studies, abstracts, and also with well-known plastic surgeons in California. We are also partnered with Operation Smile that has 72 locations worldwide, including the locations in Abu Dhabi. Operation Smile provides surgery at no cost, especially for children with cleft lip palate condition. We're also partnered in Anhuna, a children's rehab place in Amman, Jordan, GICS, Global International Children's Surgery in San Francisco, California, and GCI, Global Clubfoot Initiative in Manchester, UK. And we also adopted an ancient Egyptian mythology. And it's all about because of the heart is the essence of being. And that is why our company is called Pure Heart. Now, Pure Heart is honored to share with you the mechanism and efficacy of heat and cool therapies. And to remind ourselves that these kind of therapies are just one of the keys to fast healing, not just for our patients at the clinic or hospitals, but each individual human being. In the summary of my content in my presentations, I'll be talking about ice making, the Asian Arabs way, UAE occupational accident trends, the UAE most frequent injuries accident type, the injuries related to the MSK, global health trends issues, mechanism of actions and benefits of heat and cold therapy, Pure Heart's contributions, and Pure Heart's innovative products. Now, does anyone know how Asian Arabs made ice in the desert? Well, long before electricity and refrigerators came, people used to make an ice in the desert, and this was even stated in the Bible. The creation of yakshals is a Persian word yak, meaning ice, and shal meaning pit. A structure which worked as a cooler allowed the freezing of water to take place. Yak shells were large above ground structures built with heat insulating materials which served as the coolers during the hotter months of the year. The structure had a deep hole in the center of it, which led to the underground storage space. Yak shells were often used to store ice, which naturally formed during winter, as well as storing food. However, these structures were also able to freeze water even in the desert. And now, as I was doing my research for this presentation, I became curious on what composition of accident types in terms of economic sector here in UAE. Perhaps this information we can consider this as a leeway to prepare and better understand the subsequent slides on how Pure Heart can deeply connect to it. It was mentioned that UAE ranked 9th of all countries worldwide and the only Arab country who has managed to maintain its rank in the top 10 competitive countries for 4 years in a row. According to the Institute of Management Development, World Competitiveness Yearbook of 2020. Now, your country has mastered to diversify positive strategies, and many of your industries underwent a huge bloom in terms of growth. This period of growth has led prosperity to various industries and positive contributions to your economy. But at the same time, it faces many challenges that are mostly related to the high volume of accidents and injuries within the industry. Accidents are really accidents, despite of efforts that the government has regulated and issued. It shows here that 30-35% for the constructions and maintenance is the highest due to their high hazard field by many international bodies of occupational health and safety. 18% is who are being struck by the moving and falling objects. Significant construction focus is electrocution and electric shock. 10-15% is from slips, trips, and falls. 25% of injuries, MSDs, are from ergonomic repetitive strain. And heat stress exhaustion is not quantified, but it's totally noteworthy. Now, here are the reasons for the different accident types that's happening here in your country. There's the construction sector, manufacturing logistics, outdoor summer exposed labor, office and healthcare services. Now, let's examine the global health trends issues. We would like to present this information to you to provide you a more constructive analysis of where Pure Heart can play a big role to this. Now, we've been hearing about AI, artificial intelligence, which can automate a large portion of the manual work to speed up the process. For example, an AI to easily spot breast cancer, a biomarker that is used to identify presence of a disease as early as possible. I mean, they have this pill that you swallow and can detect and read possible disease. But at the latest one is an AI-led primary care appointments. There's possibly a machine that driven taking the vitals, a machine conducting reviews, and so forth. Patients in the United States accept it, but do not prefer it because they would rather see a human medical professional when there's a need to prescribe pain medications, to decide when to go to ER and other services. Healthcare costs will grow 7% next year, where providers are expected to seek rate increases from payers as they already struggle with labor costs, while health plans will face pressure from increased pharmaceutical expenses. Now, telehealth is one of the select few industries that's seen benefits from coronavirus pandemic. There's also support development of the devices for use in non-clinical settings, rising costs of medical certifications under new MDR in EU, and the nursing shortages in USA. The list of injuries mentioned in the bullets are basically what we have witnessed from the pie graph of composition of accident types here in UAE. What are the effects of hot and cold therapy? The cold therapy causes the blood vessels to contract and reduce circulation, therefore decreasing the pain. Removing the cold causes the veins to expand, increasing circulation. Now, heat therapy can be applied to assist circulation and the incoming flow of nutrients that can heal the injured tissues. Heat treatment promotes blood flow and helps muscles relax. Used for chronic pain. There was randomized clinical study of single-blinded parallel group, and the objective was to compare the effects of cryotherapy, or what they have used here specifically, NCS, neurocryostimulation, with those of traditional ice application or unfunctional recovery, pain, edema, and ankle dorsiflexion, range of motion, in individuals receiving physiotherapy treatments for acute lateral ankle sprains, or LAS. Now, the background of that is we all know that the ankle sprain is a very common injury, and its management is often costly, with the important short and long-term impacts on individuals and society. As new methods of therapy, using cold or cryotherapy, are emerging for the treatment of musculoskeletal conditions. Little evidence exists to support their use. NCS, which provokes a rapid cooling of the skin with the liberation of pressured CO2, is a method believed to accelerate the resorption of edema and the recovery in the case of traumatic injuries. Now, in this diagram, it shows the functional level is higher, meaning the participant who received the traditional method was able to function faster than the ones who received cryotherapy. The pain at rest score in red is for the traditional ice method, shows significant lower of pain level. The pain during usual activities, scores in red, for the traditional ice method shows significant lower of pain level. Now, pure heart gel packs are anything but standard. It is high time for this innovative idea to come to the surface. Our gel packs are built with high quality, safe food-based ingredients, direct applications, no freeze burn or no heat burn. But most of all, why put a block of ice bag and wrap it around using a tape? Why wrap it with a towel? Look, we can get all creative, but if we're in pain in bed, we want that relief to come easily, right? And as simply as possible, and that's what Pure Heart strives to do. It's leak-free, sweat-free, no sweating from the plastic, unlike regular plastic bags. Sit down.
No, I can't.
What's going on? It's not showing.
Yeah.
I'm the guinea pig.
It's coming. This.
Anyhow, it's sweat-free. There's no sweating from the plastics, unlike regular plastic bags. It's BPA-free. The material is eco-friendly and recyclable. It's flexible, contoured to the body, and it's FDA compliant, meaning it is exempt under Class 1 general controls. Okay, let me show you. Do you know how many post-op surgery?
Just be careful. If it will be like flexible, then it will disconnect. There is like Bluetooth. It is working through Bluetooth. So just be careful with this.
Oh. No, do you know how many post-op surgery instructions documents that we have read where frozen peas bags was mentioned? Well, it was almost 100%. Like I said, who wants to put a frozen vegetable bag in your body? Or I will need a duct tape to wrap this gel packs around my head, hand, or knees, and so forth. So, or perhaps the doctor may suggest order an Amazon Prime. Well, guess what? Time is the essence. And by the time you order from Amazon, even with Prime, you already lost 72 hours of immediate time for healing. Okay, so remember the global trends and issues that I have mentioned earlier? Well, PureHeart is here to contribute to mitigate that, perhaps in a smaller or bigger way, but we all have one common goal here, which is about patient safety. PureHeart is gel packs, is just one of the cryotherapy modalities. But what is very unique about our products is that how we contour to fit and hug each of the body perfectly. We conducted a very intense research and development with a total of 125 unique products to ensure that we cover from the most common conditions of minimal procedures up to the most critical intensive procedures. Now, these gel packs that I'm about to show you, that I'm showing you, are patients with condition type with a hand wrist carpal tunnel, ankle for ankle replacement surgery, arthroscopy, joint fusion surgery, Achilles tendon repair. And then my most favorite one is herniated disc surgery for the spine osteotomy. I don't know how to pronounce this. Spine osteotomy, vertebroplasty, bone marrow aspirations, and etc. So this is the very first one in the middle. And it's a medical tape. And it's basically, it's like a patch that you can patch on and you don't have to, you can walk around with it basically. And this is also for thigh lift. I know we're getting very creative nowadays when it comes to aesthetics. And we have built many products. And this one right here is also for orthodontic, for dental, oral. And this is what we have a lot of stuff that we provide for the operations panel as well. Some kids and infants with suffering and with cleft and lip palate conditions. Now, Pure Heart, we service common injuries in ER, oncology department, orthopedic, reconstructive sports medicine or ophthalmology, hair transplant, oral, and any type of customizations that doctor wants us to develop. Now, the rest of the world is experiencing high temperature and it's on the rise, especially here in your country. And that is why you have a strict heat regulations, mandatory midday break by MOHAP. And keep in mind that post-exposure cooling is really what supports the physiological recovery and pain relief. Pure Art is here because we want to be part of your healthcare best practices. We want to connect with you. And we hope that you welcome Pure Heart with an open heart and embrace this new innovation. And after all, we have all one common goal, and that is the safety of our patients within the healthcare realm, our families and our children at home, school, and at work. Thank you so much.
Thank you, thank you. Thank you, thank you, thank you. That was a wonderful speech. Thank you for your time. We truly apologize for the technical difficulties. When you guys come up, just know that it's very sensitive up here, so be careful. At this time, we want to know if you guys have any questions. Any questions about the presentation you just heard? No questions? Oh, come on. Did anybody learn anything? Was it interesting to you? No questions. We good? All right. Okay, good stuff. Let me give you a microphone. Thank you for your question.
Thank you, Maria, for your presentation. We enjoyed it a lot. Question to you is that what should the say that you market very quickly as if I'm a mouse?
Yes, so we believe that the heart is the essence of being, and that is part of the Egyptian mythology. And it's basically where the heart is lighter than the feather. So in the Egyptian mythology, they said that if you did a good deed in your past life, then you're able to move on to the afterlife if you pass the judgment. And so that means your heart is pure and your heart is lighter than a feather. And if you think about it, left feather is usually there, the lightest, of the light thing.
So coming to pure heart, so mainly the gel is a gel that where you place in the freezer. So what is it different from other types of gels? Because I've seen such kind of patches. But the interesting part of your patches as they are customized. You can put it in a certain area, you can move with them, they are very flexible. So how do you position it? How do you make it different? Because you said we are the only one in the world that is.
That's right.
Yeah.
Yes, because first of all, our gel packs are developed with bell curves. So you can just wrap it around your body anywhere. And because what you see in the hospital right now are just square. And how do you wrap, or how do you even focus on, let's say, a back of your, where it's rounded. So our gel packs, we have basically 12 different categories. We have things for hair transplant. We have one for the arms where you can just wrap around. And it's a lot cost effective because what you see in Amazon are fairly expensive because of the fabric that comes with. And this is something that a lot of our doctors, the cost of it as well. And it's food-based ingredients, very organic, and we make sure that it's safely being these of some stuff. Thank you.
Are there any more questions? Okay, thank you so much. Let's give her another round of applause. Thank you so much. That was a wonderful speech. Our next distinguished speaker is Dr. Rina Eva Dean from the United Arab Emirates, representing Painless Dentistry. Painless Dentistry. Let me say that again. Painless Dentistry. Did you hear what I said? I just want to make, have you heard of painless dentistry? Have you had tooth pain before? Do you know what that feels like? So this is why this presentation is very important to me. I am very excited to hear what this means for me in my future. I have had that dental pain. I have had a baby as well. And when I compare the two, I'm gonna give dental pain the worst pain. And that's that. And I know everybody can't speak on that, but I definitely can. She is an innovative leader who has advanced the concept of painless and patient-centered dental care, reshaping how our oral health is perceived and delivered. Her keynote session will highlight the topic, painless dentistry, the new standard, not a luxury. Let us extend a warm welcome to Dr. Rina Eva Dean. Let's get you up. See your presentation. They move presentations.
It was on the desktop.
They move.
I saw it on the desktop.
They went on desktop. There you go.
You ready through the slides with this clicker?
Let's get it up. Let's put you on 4, and then once we get you on 4, you can use the clicker. Yes, it should be. Clicker. Lock it up.
Look it up, maybe.
Thank you so much, lovely. Brilliant. Thank you very much for having me today. It's a pleasure to be here and talk to you all today. So, as you can see, the lecture is called Painless Dentistry, and you may be wondering, my goodness, is that even possible? And I'm here to tell you that absolutely it is. And I'm going to go through some points here. Before I do that, I would like you all to just take a moment and take a little look at the mobile phone that you might have, possibly holding it in your hand right now. I want you to imagine for a moment with me that you're looking down at your mobile phone, okay? And as you're looking, suddenly it begins to ring. And when it rings, you know that that phone call, should you answer it, will change the course of your life. Why, you might ask? Because as you look at that number ringing on your phone, suddenly you're filled with dread. You see, that phone call is the phone call that you hoped you never ever receive in your entire life. That phone call is involving a loved one. It might be a parent, a child, a spouse. And as you look down and you look at your phone, you feel absolutely sick. You feel your heart start pounding. You feel the throat closing up. And you think, oh my goodness, if I answer this, this is not the call I want to receive. I want you to feel all the tension in your stomach. You might even feel like you literally want to cry or be sick. Now I want you to imagine somebody coming to you and saying, hi, please follow me, have a seat in the chair. The dentist will be with you right in a moment. And they lie you back and tell you to open your mouth. I want you to imagine every single one of our patients feeling this way before they enter our room, while they're sitting in our waiting room. You felt that, didn't you? The heart pounding, the sickness, the tension. This is what our patients feel almost every single time they come. Even if it's just a checkup, we're not even going to do anything. So first and foremost, put yourself in that patient's position before they enter our dental chair. It's very important. Let's carry on with the chat. So why do patients avoid coming to see us, the dentist? Can you guess what the main reason would be? Yeah. 75% said. Points for everyone win. Pain. Pain. Amazing. Pain. First and foremost is that we're causing pain on a daily basis. So this is why 75% of patients avoid coming to us. Now, 75% of the population is not coming to us. How are we going to do our treatment? How are we going to see patients and help them? 50% said pain. Was the other top one? Fear. Fear, anxiety, phobias, all the feelings you just felt right now earlier on. Sorry, I'm not touching you. I didn't do nothing. I don't do it. 35% is a previous negative experience. Now, if you think about it, that previous negative experience could have been avoided possibly because we're the ones who are creating these experiences, correct? Now, let's flip it the other way. What makes patients feel happy to come see us? What makes them enjoy coming to see us? Well, 90% said it's the skill of the dentist. They feel comfortable with them, which is amazing because that means that power lies with us. First and foremost, if the dentist is a good communicator, is kind, empathetic, giving the patient a good experience, then they're probably likely to come back. So sometimes you might be working in an environment or a clinic and you think, oh, no, this is not for me, I want to be somewhere different. Well, remember that the power lies with you. You are first and foremost the person who can change that patient's experience. 85% said clear communication.
The great thing about communication is it's a skill. And what do we know about skills? It can be learned. And then 75% said calming ambiance and a nice dental office. Again, if you're an owner, you have control of that. If you're an associate, again, go back to 90% of the reason why patients are happy to come to see you is because of you. So you have power to change many things. Let's understand the fear pain cycle for a moment. Remember that when you're in fear, you're in flight or fight mode. So immediately you feel tension building up in your legs, your pelvic floor, your abdomen, and then very importantly, your jaw. So sometimes when you're telling the patient, open wider, remember that if they can't, it's a physiological response. It's not just because they don't want to be cooperative or they don't want to be here. This is their body with high cortisol levels, adrenaline pumping. They literally physically cannot do some of the instructions that you're asking them to do. It's magically little period. So you're tapping this. The other thing with the increased blood flow is it's going to hinder our efficacy of local anesthetic. So you're there drilling a tube, cortisol level is through the roof, and then the patient feels pain. Well, maybe it's not just because they're worried, maybe it's the efficacy of your anesthetic. The physiological response is pumping and getting rid of that anesthetic very, very quickly. And that will only reinforce the fear. So how do we break this cycle? It's not one solution fits all or one magic trick that I'm going to give you today. It's a comprehensive approach. So first of all, I'll try and remember my slide. Empathetic communication. Empathy is absolutely key to our profession. I know many different people enter the profession for different reasons, but really at the heart of it, we're here to help people. And you need to feel empathy. You need to feel kindness and empathy and try and walk in these patients' shoes to really have the maximum impact. You want to build trust and rapport through good communication. Okay. I'll try and you'll just have to look at my pretty face then as I go along. So psychological support. We can often do things like, if you really want to go the whole hog, you can do things like CBT, cognitive behavioral therapy, clinical hypnosis. There's lots of many things that you can really go for. And NLP makes a massive difference. That really, really helps. The words you use are so powerful. And then finally, advanced clinical techniques. We have so many amazing clinical innovations at our disposal. In fact, when I qualified, I remember thinking this is such an exciting time to be a dentist because there are so many amazing, wonderful technologies and experiences happening that we can take advantage of. And I'm going to go through some of those today. So first impression, this is a very pretty picture. I'd love you guys to see.
This one.
Okay. First and foremost, clinical environment. We want a warm, welcoming ambience. You want soft lighting. I'll tell you a story about when I was building my clinic. Halfway through, the developers decided that they weren't allowed to do any renovation work during the day because it was too noisy. Halfway through my building, imagine. So they could only do it at night time. So I'd be there during the day working and then having to rush to the clinic at night time to make sure that they were working properly. So we had a plan of each stage of the development of the work, you know, lighting, electricals, etc. One morning I went and they hadn't told me that they fitted out the entire lighting. And I walked in and they were so happy. They were like, look, Doc, we've done the lighting, isn't it amazing? And I looked around and I was absolutely horrified. And I said, what have you done? And they were like, what? We've done the lighting, it's great. I said, it looks terrible. You know what they've done? They put 7 Kelvin wattage in the clinic. Everything looked so white. It was like a hospital. No offense to anyone in hospital, but it was so white, so clinical. And I just said, no, this is a disaster. This is exactly what I was not going for. They said, but will you every time this way? This is how we do all of them. And I said, yes. And that's the problem. Because we do everything this way, this is how I don't want to do it. I don't want patients walking in feeling this glaring bright white light that's not welcoming. So this is actually a little image of our clinic. So we catch it. So what I like about that picture, somebody said to me, "Oh, it looks like an airport lounge." So I didn't think of it like that. What do we associate with airports? Holiday, having fun. So try and, when you're thinking, any business owners are building your clinic, think of it in a really a very different way. Think of it in a way of how to bring some light, joy, calm, peace into that space. Obviously, yes, we are a clinic, we are a dental environment, but you need to make patients feel welcome into that space. So lighting is very, very important. Background music and soft lighting. Now, I do know some dentists who like playing the radio on while they're doing treatment, which is not very well. But do you think you want in the background while you're doing dental treatment? I don't think that's very conducive to relaxation. So maybe have a think about some relaxing piano music, some classical, some calm spa-like things. So I know one of my receptionists attempted to put on some engaging upbeat music one time, but again, you have to think about the patient. It's not what we like to hear, it's what's conducive to calm relaxation. And empathetic staff, again, your team are your business and they are who you are. So if you do not have people who are kind and caring and follow your dream and your vision, you've really got to think about whether they belong in your team. I'm very fortunate I have one of my manager here today and I have an amazing, phenomenal team and I really cannot thank them enough for building and sharing the dream and mission I was trying to create. Sensory comfort. I'm a very tactile person. I'm a very visual learner, and so you want to think about engaging all the senses of a patient when they walk in. As soon as they walk in, we talked about vision. How does it look? But smell. Did you know that smell is your strongest sense of recollection? Sometimes, if you smell a particular perfume, it takes you back. Oh, I remember that memory. It's your strongest sense of recollection of a memory. So one of the things, if I told you that dental smell, eugenol dental smell, that immediately transports you back to dental clinic. And that's one thing that our clinic does not smell of is eugenol. That's very, very important. And yeah, have some, nice artworks and digital displays. Again, you see some of the spaces. Of course, clean private space is very important. Communication excellence. Like we said, communication is a skill and we can learn it. And with practice comes perfection, that we heard. Empathetic dialogue. Like I said, the key is empathy. If you do not care about people and if you're not putting them first and thinking about how they feel, then you're really going to struggle. So just tap into that first. Everything else I tell you is the cherry on top. But if you seek to understand somebody with an open heart, then you will absolutely be successful. And all of these other things will just help you along the way. Active listening. If you're going to take an hour to do a dental filling, should you be booking an hour dental appointment? That's my question to you. No, because if it's going to take you 60 minutes to do a filling, where's your time for communication? Where's your time for talking, asking them their history, allowing them to tell their story? I used to have one patient where I would book the length of time for treatment, 60 minutes, and I kid you not, I would make sure that the receptionist would book me an hour for the chit chat beforehand. It was an elderly lady, I think she's a bit known, and she liked to come and chat and listen. She had lots of medical history and often it was repeated. But that one lady, I kid you not, I just did it out of kindness, but she sent me so many referrals and so many patients, and she tells everybody about me, which is so kind and so sweet, but generally that space to just be able to offload. Remember, they're going to lie back in your dental chair. That's a very scary, vulnerable position to be in. They're going to open up their airway to you. Again, you can live for only 2 minutes without breathing. So your airway is a very vulnerable space. And you expect to just get them into your chair, rush them in, lie them back, and then start treatment on them. Take that time to build that connection, build that trust, have a chat with them beforehand. Allow them to tell us what is going on. Clear explanation. Please do not tell patients we are doing an RCT on your UR6 today. It means nothing to them. It is a root canal treatment. What is that? Explain. Most of them don't know. We just take it for granted sometimes what we know and what patients don't know. We have to just go back many, many steps before we even became a dentist and stop using jargon. Really break it down for patients and no question is a silly one. Really take that time to explain it. And also when you take the time and explain it, they will be more willing and more open to having that treatment because now they understand it. If they don't understand something, it's very unlikely they won't come. But they might not tell you that. They'll just not turn up to their next appointment. And then you wonder why the cancellations are high. So that's one thing to take note of. Shared decision making. Again, it's very, very easy as dentists to go, I know what the correct treatment is for you, this is what we're going to do. Remember, this is their body, their choice. I don't ever force or tell somebody what to do. I merely lay out the treatments, what I feel the advantages, disadvantages are, and allow them to make those choices. It's very easy to fall into that. You know, this is your treatment plan, this is what you should do. And it's really, really important at that point when you say to the patient, treatment, and then if they turn to you and say, well, what would you do? That is the biggest compliment I can ever receive because that really means that they truly trust me. Sometimes I often say to them, it's not what I would do, I'll tell you what I think is best for you. Because I have I'm different gender, race, culture, everything, but I can try and guess at what you would like. So remember, sometimes it's not even what we do on ourselves, it's actually what we think that they should do for themselves. Sometimes we can gauge that, and with that good connection and getting to know them, you can actually help them make those really good decisions. I'll give you an example. I personally would never have fixed braces. However, if I'm talking to a patient and they're a public speaker, and they're not a public speaker, and they're, keep losing their handbags and they're going to things, would I recommend Invisalign to them? No, because that relies on them having to remember to take it in and out. So I'm like, I know I wouldn't do it, but that's not what's right for you. So again, taking that time to understand the patient, then you can give them really good communicating excellent, as I say, pre-procedural discussion, make sure you tell them what you're going to do. When I used to work, often patients would come in, sit down at the desk chair and go, so what are we doing today? And it was the most common question I ever got, so what are we doing today? You're coming for my appointment, you have no idea what procedure we're going to do today. So training your staff is super important to make sure that you tell the patient what they're going to do before they even get in my chair. Actually, nowadays, I get in the chair and the patient goes, oh yes, so we're doing this side, yeah? Yeah, we're doing this side today. I'm like, yeah. Because it's really important to actually tell them beforehand. Let them know that you're going to make sure that they are in control before, not during when they're panicking and freaking out. You tell them beforehand. If you need me to stop, raise your hand. As you go through the procedure, tell them. This is what if they feel the buzzing sensation, warn them. This is a buzzing sensation. This is what it means. This is a good thing. Then they won't worry because if you haven't pre-warned them that they're going to feel a buzzing, they're going to think something's wrong. But if you've pre-warned them and said you're going to feel this buzzing, and that's normal and that's okay, they can then relax. And then afterwards, you say to them, you did a great job, positive reinforcement throughout, you did brilliantly, everything looks really good. Often as I'm working, I notice I'm saying things like, that's really great, this is really good. Or to my nurse, I say, this is perfect, excellent. Reinforcing to your team, that collaboration really, really reinforces that confidence with patients. And generally, most of the time it's going fine. Most of the time it's going okay, but the patients won't know that. So just keep reinforcing that throughout the procedure. And then you can really go full on. This is a little background, I don't know if you can see clearly of our screen. So we have a beautiful, the name of it now, bearing ceiling on our roof. I actually got the idea 12 years ago when I had to have an MRI for my back, and I was lying there and I thought, this would be amazing in a dental clinic. Because normally you're just looking at a sprinkler and some chipped paint and a crack in the ceiling, and it's not very pleasant to look at. So give your patients something nice to look at. So we have a beautiful bearing ceiling, and we also have TVs on the ceiling that we mount that they can watch Netflix or for the children cartoons or anything else. I'm showing my age now, cartoons, animations or whatever they call it. So visual distraction, TVs can reduce by up to 23% cortisol. All digital techniques, we have some nice fluffy, warm, called headphones, wireless ones that they connect to. Who wants to hear the high-pitched wearing of a drill? So we help patients with that. We actually also have the red ring drills, which reduce pitch of the screech much more, which is much more comfortable, more avoided now. And then breathing protocols. There's many good breathing techniques. Breath work is so important. It can really help to relax and guide the patient down. And it's so often when they start gagging that they've held their breath without realizing. You've got two things that cause gag reflex. One is that little voice in their head going, I can't breathe, quick, quick, get out, get out, get out, which you have to actively catch and help the patient talk to. And the second thing is the guided breathing. Many times what sets off the gag reflex is that they've held their breath and they don't realize it. And then the brain starts going, there's no oxygen, there must be something in the airway, quick, gag, 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 get it out. So just going to the really, and it's better rather than going to inhale, release and breathe out first. The depth of the exhale will determine the depth of the inhale. So get them to breathe out first. That releases energy, then slowly guide them and count them in and keep counting them. Often I'll start counting and my nurse is trained, she'll count with me. And then because I'll get busy, doing the procedure, she'll keep counting and I've trained her to keep going, keep counting, to really be that internal voice for that patient. It's a pretty action. Reduce pain by up to 45%. I didn't mean to say actually also with pain that when you're scared, you will 100% physiologically feel more pain. That is completely linked, that's 100%. I've got to wrap up. So again, you can really go the whole hog, do neurolinguistic programming, clinical hypnosis, CBT, you could really go as far as what this. We do topical anesthesia, you want to use lidocaine, try the area thoroughly. The key with topical anesthesia is you give it for 3 minutes. I see so many people rush it. They put it on 20 seconds later, 1 minute. Really give it that full 3 minutes. When you get full 3 minutes work, amazing. You want to use 27 short gauge needles, slow injection rate. The distension of the tissues is a lot that causes pain. Warm the anesthetic. Surprisingly, the coldness really causes some more pain. And then obviously aspiration. We have in our clinic every single chair is fitted with quickly, but I am a KOL for it. Intraosseous painless dental injection. Yes, you heard that right. Painless dental injection. Imagine going to the dentist.
1 minute left.
Imagine going to the dentist and getting pain injection. So quick sleep that is amazing. I really advocate for that. It's a computer anesthetic, so you don't have your old fashioned blood anymore. It's very, very helpful. And it's an amazing pain injection. So key takeaways are patient-centered environment, make sure you control your lighting, the ambience, the sounds at your dental clinic, advanced pain management, make sure you try and use innovative techniques, painless injection, psychological support and distraction, give them that time, be empathetic, connect with them, and then finally integrate technology. I hope you enjoyed this one. Thank you very much.
Wasn't that wonderful? Thank you, thank you, thank you. Hey guys, what stood out to me the most about this presentation is that it was patient-centered. Everything she said and did was patient-centered. The environment, patient-centered. Communication, patient-centered. So question and answer time. Do you have any questions for our presenter? Thank you, so that's the biggest compliment. That's very compliment. Any questions?
That was a wonderful speech. Thank you so much. And I had a question about the intercultural, about the different nationalities you're treating. Yeah. Do you feel any difference between people from the US or coming from the Europe or coming from all around the world or from the region here? Any difference? And maybe you would like elaborate on that a little bit.
Yes, of course I know. So as we all know, Dubai is literally the complete melting pot of different cultures and people, which I absolutely love. Myself, I'm half Iraqi, half English, so I love being mixed race. That's a useful thing. I think first and foremost, honestly, a person is a person at the end of the day, really. We all have the same fears, we all have the same anxieties, we all have the same worries. And if you genuinely don't look at the differences in that way, you can really treat patients so kindly and so empathetically. That's number one. The second thing is with cultural barriers and things, main thing I find the difficulties may be language if there's a different language, but nowadays Google Translate, it's amazing. I had a Russian patient who barely spoke any Russian, and I just sat there both on mobile phones and conducted the whole treatment in Russian, back and forwards, and that's the internet. And the second thing is, yes, there are cultural differences. I find particularly with oral health. America is very, very good at education, general population with oral health. I generally find they have better oral health. Whereas other nationalities, I find maybe the culture, maybe they think teeth are not important, or particularly baby teeth, I should say. And so again, education, empowerment, talking to patients, that's one thing I find really important. And again, sensitivity, like I mentioned before, there's that thing, we used to say in dentistry, oh, if it was my daughter, what would I do? It's always the lecturers going, oh, do what you would do to your family, or you would do to yourself. And I would actually say, no, I wouldn't actually do what I would do to me or to my family, because I have completely different values, ideas, ethics. I would do what I think is best for you as much as I can, and I'll try and get to know you, try and help you make that best decision.
Great question, great answer. Thank you for your time. Thank you for your time. Patient safety initiatives. Communication is key. Your environment is key. I run emergency departments for a living, and she talked about the environments and the ambiance. And we have a lot of balance in emergency departments. When I go in, I look at the colors. I see red, I already know what your statistics are. So ambiance matter. Communication is key. Active listening is how you take care of individuals, and especially with different backgrounds. Which takes me to our next speaker, the topic is very exciting for me. It is my pleasure to introduce Dr. May Nabia Hussain from the United Arab Emirates, a certified professional in healthcare quality from the Arab land. She has dedicated her work to strengthening patient safety initiatives and empowering healthcare systems through evidence-based strategies. Her talk today, guys, is strengthening patient engagement. That's how you get answers. You strengthen patient engagement. Please help me welcome Dr. May Nabel Hussain.
Thank you. She spoke a lot about strengthening patient engagement. But let me first introduce myself. My name is Dr. May Nabil Hassan. I'm a certified professional in healthcare quality. I've been born and raised up in the United Arab Emirates, especially in Dubai. So I know Dubai from scratch. When Sheikh Zayed Road, the main road in Dubai I've seen is only a desert, and it's a two-side road. I've been living over here in Dubai, and then I completed my studies in Jordan, where I come from. I'm a pharmacist, and I hold a bachelor degree in pharmacy, master degree in international business, and a professional diploma in total quality management. And I am a proud mother. For the past 15 years in my experience in the healthcare, I've implemented quality improvement projects. I've led quality accreditations, and I've been running a business for the past 18 years in an ambulatory care. I'm proud that my ambulatory care center was JCI accredited 4 times, and where we have implemented quality standards. The reason I chose this topic is because I'm passionate to train. And I'm working today with you guys is as a freelance trainer to train healthcare professionals and healthcare administrative executives on how to communicate with patients. I believe that strengthening patient engagement is a key in modern healthcare, especially due to technologies, AI, the availability of data for all patients. So I guess this is a a vital pillar in the modern healthcare. So, I would like to thank Dr. Ren because she has done a great job. I'm really happy because she's a good example of. She has mentioned a lot of things. I'm proud that you, Dr. Ren, and that you have these such wonderful soft skills in dealing with your patients, because it's all about patients and patient-centered and patient safety. So, let me start. Imagine for a moment with me. You are in a hospital room, scared, and holding to a diagnosis that you never know what is it about. And then a doctor comes in, looks at you, just speaks in a medical jargon way, makes a decision, and leaves the room. How do you feel? Powerless, isn't it? So now let's imagine it in another room. You're inside the room, waiting for your doctor. Doctor knocks down, visits you, welcomes you by the name, smiles into your face, and tells you, welcome. What's the matter today? How can I help you? Of course, this thing really makes a difference for the patient. Why? Because patients, at the end of the day, they are human beings and they should be engaged, valued, and empowered. So this is the difference that patient engagement makes. And today, I want to show you how we can strengthen it. Patient engagement is not just a trend. It's not a trend. It is one of the most vital pillars in the modern healthcare. You will be hearing about it in every conferences, in every patient engagement, talking about patient safety, hospital management. It is one of the most vital pillars nowadays, especially due to competition, due to different types of cultures and doctors. So why is it that so? Because it improves adherence. It reduces hospitals' readmissions, and of course, it saves costs, and this is the main thing. So, and above all that, it restores the difference between, it restores, the trust between the patient and the providers. What do they say? They say that engaged patients live longer, healthier lives. They feel respected, and healthcare systems who are practicing patient engagement are more sustainable. Yet, in many situations, we still hear some patients say, I don't feel myself unheard. So they still feel themselves as spectators rather than partners in their healthcare journey. So, what's this course all about? Sorry, before going to that. What do you think the challenges that we're facing in healthcare? What is letting us, it's a bit, what's letting patient engagement giving us a struggle? The main struggle is that there's no time with the doctor. Most of the time, doctors face time pressure, especially if they have a busy schedule. They don't have time. And here was Dr. Rana just mentioned that she usually trained her receptionists to take extra time for the conversation with the doctor, with the patient, for doing the procedure. So time, miscommunication between the doctor and the patient, cultural barriers, and low patient involvement. Technology is another role that is playing nowadays in patient engagement, but it's missing the human touch. So, too often patients tell us, I don't feel heard. That statement really nowadays, it's more dangerous than the disease itself. Because when trust breaks, care fails. So my vision is to empower healthcare professionals to strengthen the patient relationships through communication and improve outcomes. So I brought up this course and I called it a practical toolkit. I don't want to make it as, oh, I'm going to take a training and all about it. No, I made it in a way, in a very practical way, a toolkit covering communication, covering trust building, shared decision making, cultural competence, and digital technologies, where every healthcare professional or healthcare executives takes them back to their clinic and they can use it with their communities, in their environment, in their hospitals. First, introduction. What is patient involvement all about? True engagement means moving from what's the matter with you to what matters to you. Patients are passive recipients. They are co-designers of the healthcare journey. They're not only just a number coming to your clinic. So what are the benefits of that? They improve adherence, they reduces readmissions and build trust and satisfaction. Okay, what about it? Dr. Renna mentioned in her past presentation communication skills. Yes, these are not only soft skills. No, they can be learned, practiced, trained about it. And why? Because words can heal or hurt. So using a plain language, listening actively to your patient, encouraging questions, these are not soft skills. No, they are life-saving skills sometimes. And one empathetic sentence can change the entire care plan. So here are just 6 practical tips of effective communication skills: plain language, visual aids, active listening, encourage questions, not verbal cues, and written information. And we have seen that sometimes in a couple of hospitals and organizations, and they started using this. And this is where we are encouraging it a lot. I would like to go through this dialogue, but I'll keep it at the last of my presentation. Coming to the second module, which is building trust and rapport with patients. Of course, trust is built in healthcare in moments. You either make it or break it from the first time. So how do that? Smile, remembering the patient's name, and then asking permission before you touch them. These moments are not small moments. No, they sometimes be everything for the patient. So trust is improved treatment adherence, satisfaction, and the most important thing, it is a positive long-term care outcomes. And here are the 5 best practices to help healthcare providers how to do so. Strong welcome, connect as humans, two-way conversation, mindful non-verbal cues, and empathy and authenticity. What's the impact of building trust? Again, you can maintain a stronger relationship with your patients, lower their anxiety, and better outcomes. And of course, every patient who builds a trust with a healthcare professional will be your marketing tool, walking all around and saying, yes, you need to visit this doctor. The third module will be talking about motivational interviewing and shared decision making. When patients faces ambivalence about, for example, quitting smoking or treatment choices, it's our role to guide them and not to dictate them in that point. We just show them options, as what Dr. Rana has mentioned before, and then let the choice for them. So engage them in these choices they are doing. So motivational, they take them to, because if they are engaged, moving towards a positive change in their healthcare journey is much more better. And there are some principles of motivational interviewing, such as empathy, develop discrepancy, avoid arguments, dance with discord, support, and self-efficacy. And there are some frameworks we can use for motivation giving skills, like ORS that helps you build the skills. And simply ORS means open-ended questions, affirmations, reflective listening, and summaries. What about shared decision-making? Shared decision-making is a collaborative process between the healthcare and the patient to make the best decisions to your patient and improve patient satisfaction, and again, builds trust. That's an interesting thing. So again, ORS. Yeah. Open-ended question, affirmation, reflective listening, and summaries. So share approach is seek participation, help explore, assess the values and the preferences of your patient, reach to a decision, and then evaluate the outcomes. I will be also discussing cultural competency and patient-centered care. Living in Dubai for the past year, just to avoid telling you with my age. Dubai has more than 46 different nationalities. So you can imagine there's a lot of cultural differences, especially when it comes to healthcare. So culture shapes how patients think about illness and healing. There are different cultures, different people. For example, there are certain cultures, they don't like blood transfer, for example. There are certain cultures that they have a certain way of healing. There are certain cultures, they don't believe in a normal traditional medicine. They believe, for example, in other conventional or traditional ways of healing. So really, cultures, respecting the beliefs, the language, the values, and are not optional anymore. It is a foundation where you can build trust with your patients. So respecting culture diversity strengthens the engagement and outcomes. And it is essential in patient engagement because when you understand the culture from where your patient is coming from, you can enhance trust and communication. You can improve the health outcomes, reduce these health disparities, and ensure legal and ethical responsibility. And here what comes where patient-centered cares come. We are shifting the focus from what's the matter with the patient to what matters to the patient. Last but not least, technology. Yes, digital tools is powerful. The global healthcare IT market valued at 663 billion in 2023 and is projected to grow by 15.8% compounded annual rate from 2024 to 2030, which means tech-driven patients engagement tools not only improve outcomes and efficiency, no, they play a great role in the coming future of healthcare. And these tools are telemedicine, patient portals, wearables, health apps, and predictive analytics. But technology must never replace compassion. I believe that the best healthcare systems is when data and humanity move hand by hand. One more thing that you should consider when integrating technology to enhance patient engagement is the ethical consideration. We need to balance between the innovation and privacy, security, and the human connection when it comes to technology. And we have seen that in a lot nowadays in AI, where artificial intelligence is playing a key role in healthcare, but everybody's worried about the privacy of the information, security, and sometimes we're losing the human touch. So, patient engagement is not an accessory, it is the future of healthcare. And here's the good news, engagement is not a mystery anymore. It can be taught, practiced, and strengthened. That's why I developed the Strengthening Patient Engagement course. It's a toolkit that I've been designed for healthcare professionals seeking to improve quality and their patient interactions and outcomes. And it is a course that goes beyond only theory. It is a practice with role plays, case studies, and it's a real world strategies that you can leave back into your clinics, hospitals, and communities. What do you expect from that? Higher patient satisfaction, improved adherence, better efficacy, and stronger patient trust in the place. I will leave you with this. Every patient you meet is not just looking for your prescription. No, they are looking for connections, dignity, and hope. So we can strengthen patient engagement. We are not just improving outcomes. No, we are healing humanity itself. Thank you for listening. Any questions?
Any questions? Anybody have any questions for that wonderful speech? Wonderful talk? Yeah? Patient engagement? How important is that? Important. Thank y'all so. No questions for our speaker. I think what I love the most about it for me, and I think it's important, I think you can see, and if you don't know, I'm a Black American, but as a Black American, trust is everything. We don't trust the healthcare system, factual. And so building that trust and looking at those key components meant everything to me. And so I thank you. I thank you about building trust. We have a question. Let me find it.
And I had a question about data points or how to measure the outcomes. Maybe you could speak a few sentences about measuring or
Measuring
new data points you can have, and especially
outcomes need the full lecture, but let me start with it. We measure when we're doing quality improvement initiatives. We do a lot of things that is called KPIs. One of the KPIs where you can measure outcomes from, let me make it in a very plain language, is patient satisfaction surveys. Nowadays, in every hospital or healthcare organization, what we encourage patients to do is to answer the patient satisfaction survey. And the surveys over time, I've seen it with my experience, the more the survey is simple, short in question, the more patients will answer it more openly, and they will just not just a paper fill it. I just want to do this because they asked me to do that. No, this is one of them. There are different kinds of KPIs you can actually do, but one of the major things if you want to measure is patient satisfaction. And other KPIs is when you measure your improvement projects you're doing exactly into your organization. And when it's coming to that, you have to move through standards. There's a couple of standards in the hospitals, there are a couple of standards in the ambulatory care centers, but Dubai, trust me, has done all these standards and they're putting it. So you cannot, maybe Dr. Renan has seen that when she's established her, established her clinic, that there are certain standards where you should follow in order to achieve quality. So yes, one of the simple one I can go to, which everybody can over here can know about it, it is patient surveys.
Okay, thank you so much. Hey guys, we have to give certificates out. And so we'll do that after the next presentation, okay? Thank you.
All right, introducing our next speaker. Our next speaker is Mrs. Sharu Hassan Abu Jabbar. Why y'all clapping because I said that right? Or no? Welcome. Okay, from the Kingdom of Saudi Arabia, affiliated with the King Abdullah bin Abdulaziz University Hospital. Her research focuses on psychological health and family-centered care, particularly addressing the challenges parents face in neonatal intensive care units. She will share her important findings in a session titled Exploring Stress Management Among Parents with Neonates in Neonatal Intensive Care Unit, a qualitative study. Please welcome Ms. Sharu Hassan Abu Jabbar. Yay! Next presentation.
Good morning, everyone. My name is Shrouk. I'm an advanced nurse practitioner working at King Abdullah University Hospital in Saudi Arabia. So my subject is exploring stress management among parents with neonates in the neonatal intensive care unit. So we will go through introduction, methodology, findings, and summary for all the findings. So with the background of that study, yes.
Switch mics with me, we can hear.
This one's working?
Yeah, okay.
So perinatal anxiety associated with the NICU admission is significant global concern. Annually, more than 15% of newborn worldwide are admitted to the NICU, which places parents under intense stress as hospitalization disrupts the parent-infant bond. So this study seeks to explore how parents of NICU infants manage stress and the factors that influence their coping strategies. So the statement of the problem, this study aims to answer the following question. What stress management strategies do parents of neonates in NICU employ? What recommendation can be made for healthcare professionals for better support parents in managing stress during their neonate stays in NICU? What key factor influence parents' choice and the effectiveness of stress management strategies during their neonates NICU stay? So the significance of the study. We found that parents with neonates admitted to the NICU to employ effective stress management strategies during NICU hospitalization. And healthcare professionals such as nurses, doctors, counselors, so to guide supporting parents and improving care practice. Policymaker and hospital administrators to offer evidence to develop policies or programs that reduce parental stress in NICU. So the scope and limitation. We employ the study focused only on the parents with neonates admitted in NICU for more than 3 days. And we exclude that parents with NICU stayed less than 3 days. So the methodology, the research design is qualitative research. This study employed a descriptive research design using semi-structured, open-ended interview question to collect data on exploring the lived experience and stress management strategies. So the respondents and samplings, our population are parents with neonates admitted to the NICU for more than 3 days in King Abdullah University Hospital. Sampling method, we use proposive sampling, a non-probability sampling technique. Research instrument. These are the semi-structured, open-ended interview questions. The questions are, what stress management did you use during your infant hospitalization? How do the healthcare staff positively impact reducing stress level? And can you give an example? Have certain strategies work better for you than others? And why do you think that is? Are there specific activities that help you manage your stress while your baby is in the NICU? For data collection procedure, we took a permission obtained from the Hospital of Administration. Then we interview the selected respondent. Then collection and analysis of respondent. Finding and discussion. So the key finding, identification of stress management strategies. Parents in the NICU various coping mechanisms such as spiritually, communication with healthcare provider, and information seeking to manage stress. Impact on parent-infant bond. Effective stress management improve the bond between parents and their neonate, positively influence parent neonatal health outcomes. So for role of healthcare team, clear communication, emotional support, and structured care plan from the NICU staff help reduce parental stress and enhance involvement in infant care. Challenges and facilitators. Parents face obstacles in coping with stress, but factors such as sufficient information, emotional support, and supportive NICU environment facilitate better stress management. For the interpretation, effective stress management strategies emphasize the critical role of the NICU environment and healthcare team in supporting parents by providing clear communication, emotional support, and attention to religious and spiritual needs. Will empower parents to cope better and remain actively involved in their infant care. So for the summary, so emotional support and communication. Emotional support and clear communication from healthcare professionals are essential in managing parental stress, providing parents with timely, accurate updates about their infant condition and treatment plan will reduce anxiety and promote reassurance. Family-centered care. Family-centered care emphasizes involving parents as active partners in their infant's NICU journey by recognizing family preference, fostering collaboration, and engaging parents in decision-making and caregiving. This approach enhances parental well-being and reduces stress during hospitalization. Mindfulness-based intervention. Mindfulness-based intervention reduction include meditation, breathing exercise, and counseling, has been shown to reduce stress, anxiety, and depression among NICU parents. So for conclusion, parents of neonate often experience high level of stress and anxiety, which can disturb parent-infant bonding and affect health outcomes. Providing education, clear communication, emotional support, and involvement in infant care helps reduce parental stress and strengthen the parent-infant relationship. NICU healthcare team should be prepared to offer psychological, spiritual support to help parents to cope effectively. So my recommendation, improve communication between healthcare providers and parents to ensure clarity and understanding through standardized communication protocol in the NICU, and conduct interventional studies to evaluate specific stress reduction program, such as mindfulness counseling and family-centered care to assess their effectiveness in enhancing parental well-being and empowering infant outcomes. Conducting psychological support service include counseling and stress management intervention can address the psychological challenges faced by parents. Explore the long-term impact of parental stress in the NICU on infant development, parent-infant bonding, and parental mental health after discharge. That's all. Interesting.
Wonderful, wonderful speech. Thank you, thank you, thank you. Any questions from the audience? Come on, you know we got. Okay, we have one over here.
Very much. Great talk. I wanted to ask, you mentioned that of the patients who gave the feedback, you said a proportion of them were then taken for further interview. What was the selection criteria for those parents that you explored and did further interviews for?
The parents who their infant stayed more than 3 days in NICU. And more likely, we are going through the critical cases that stay for months and months. So we have the interview, like full interview with them.
Criteria was more the more poorly and unhealthy babies were
Yes.
selected.
Yes.
The impact was greater
Yes,
there.
and we make it more broader. We selected also more than 3 days. We exclude the less than 3 days because their cases are like bilirubin level, venous delivery, and etc.
My second question is of the strategies that were implemented, for example, you gave mindfulness, spiritual health, psychological support. Do you have any results of which of those had the most impact, or which one impacted the most or affected most? Do you have any data on that? Just out of curiosity.
No, we didn't do any further investigation, but we found out that the parents use these strategies which help them better to cope. But we didn't do further investigation. That's my recommendation. Yes.
Thank you very much.
Thank you.
I have a question.
We have another question? Yes.
Ms. Sharuk, it was fantastic presentation and it's required to have it, especially for the NICU parents who undergo a lot of stress and definitely impact the bonding between the parents and the kids. I just want to know from you, as you have said that there is a lot of interventions, mindfulness, deep breathing. How did you on ground, how did you implement this? Like we understood the selection criteria. Fantastic, yes. But on ground, how did you implement all those things? Like, do you have any experts coming into it? So I want you to throw a light on this.
We didn't like this is my recommendations. We found the mindfulness, family-centered care. This is the most recommended stuff.
So how did you implement on ground?
We should have a counselor. Actually, we have someone in our hospital, but yet we still need to study it. We didn't implement it yet. We have someone who's expert in mindfulness, wellness, so to implement this strategy. Thanks so much. I just wanted to implement.
Can I please present you with your certificate? For the ones that we did not give certificates earlier, we'll make sure you get your certificate right before break and get your picture taken, okay, with your certificate. Thank you.
One more question.
Oh, sorry, and we have another question. Good speak, you see? One moment.
No, because the topic's interesting. I had twins, and they stayed in the neonatal intensive care for one twin stayed for 10 days and the other one stayed for 14 days. So I can imagine how stress management for parents is very important at that stage. But mind me of asking you, how did you collect the data? Was it by a survey, by certain questions, and these questions were in Arabic or in English? Because there are a lot of questions to be asked for the parents in how to manage their stress, especially when it comes to neonates. So this is what, because remembering my situation, I can imagine what questions did you ask the parents?
We ask them what kind of coping mechanism you are using. What makes you feel more comfortable? What's the issue that you are facing in NICU? Is it beauty of how some of them parents' reaction? But about the question, it's an interview.
So it's all about interviewing.
Yeah.
It's not any data question patterns that you have done.
We have the question, but it's like
Open questions.
yeah, open question. And we let them sample what they are using, then and see which one is work better for them and how they can improve. Next step.
But you didn't do any kinds of categorization of the data and how to score the data, which is much more important because I've seen your recommendation. Something very nice. But I just want to see what is the most stress management plan that you came up with.
Mindfulness, like meditation, they have a counselor, psychiatric, they have in the NICU team, they should be psychiatric in the NICU team. Family centered care, they should be involved with the patient care. Sometimes they are not giving any option for the parents to be involved with the care. Yeah. like
The problem so important.
no.
True.
Not-
True.
خلاص, we'll make you feel okay.
Yeah, true. This is when it comes to engagement. Yes. Thank you very much, Julia.
Thank you, thank you, thank you. Can you guys hear me? All right. What about now? Y'all can hear me now? Yes. Our next poster presenter is Dr. Aparna Saraf from India, specializing in prosthodontics and crown and bridge. Her scholarly contributions focus on biologically driven approaches to restorative dentistry, ensuring both aesthetics and function. She will showcase her presentation titled Biological Oriented Tooth Preparation Technique. Please welcome our next presenter. Thank you. Where's this one? Wait a minute. It's this too.
Good morning, everyone.
how many dentists here? Because I saw many other professionals, because this is going to be purely clinical. So I don't think others will enjoy it. So myself, Dr. Aparna, I am specialist prosthodontics. I am from India. So today I'll be talking about biologically oriented tooth preparation technique. So we do tooth preparation every day in our clinics, right? So this is something which is respecting the biology of the periodontial. So we all know that dentistry is all about restorations, but at the same time, conservation is also something that we should keep in mind. Okay, and one of the major problems that we face in dentistry is the same thing, which is maintaining the aesthetics at the same time preserving the biology. So this is something related to it. So usually for tooth preparation, we rely on three major techniques. The finish lines can be subgingival, supragingival, and equigingival. So let me focus about the disadvantages of these three preparations. So one is subgingival, definitely violating the biological width. So it is disrupting the periodontial. Coming to equigingival, definitely because of the finish line, it can affect, it can cause inflammation and followed by the recession. And coming to supragingival, the best in case of hygiene, but the most important problem is it causes unnecessary. Most of the issues, so which I said BOPT. So this is a kind of preparation which will not disturb the biology, yet will give you good aesthetics. So how it is, in a short way, I can say that the preparation is done intracircularly, a vertical preparation without giving any finish line. Okay. So let me just take you to one of my case. This is a patient who came to clinic. As you can see, there is a lot of discoloration, recession, so many issues. So patient wanted complete crowns for the upper tooth only. So I discuss, most important is before we start the procedure, we need to have provisionals, because immediately post preparation will give the patient crowns, temporary crowns, provisionalization. So I explained the patient, let's do some another technique. Yes, it will take time. Unlike the other routine technique, immediately we cannot give you the finals. There is a lot of procedure, and fortunately the patient was okay with it. So discussed everything. With the consent, we started. You can see the recession. I have calculated, there's a lot of recession on the patient's mouth. Patient was concerned about the aesthetics, but we made him understand the importance of biology. And so this is the tooth preparation we did on the patient's mouth. So as you can see, there is a vertical preparation, and the preparation was without finish lines. This is a graphical representation of gingitage. I hope you understand what is gingitage is. I hope you understand. Intracircularly, we are creating a width, so that since there is no finish line, there is an increased width which will help the crown to fit in. So this is how the provisionals are made. The provisionals were relined and placed immediately post the tooth preparations. So this is how the provisionals were given to the patient, followed by the relining. So this is the procedure. The provisionals were relined with self-cure acrylic resin. Yes. Relined with self-cure acrylic resin and were placed immediately. So this is how the finishing and polishing is done. These are all pictures from the internet. And the provisionals were placed in the patient's mouth. Of course, there was a little bit of bleeding, which was controlled. Finishing, polishing, all done. The provisionals were given. This is actually the image taken post 1 week. So you can see there is a slight change in the gum level. And this is the image after 4 weeks. So you can see there is a little bit of healing happening. And this is the image we took after 6 weeks. So the patient came back. We took the impression, of course, by placing a cord. And then it was sent to the laboratory for the final restoration. So this is the final crowns for the tooth. So you can see this, how beautiful the aesthetics is, respecting the biology. This is post 1 year. After 1 year, this is how the patient's gums and the aesthetics, everything looks, and the biology was excellent. So the advantages of three most important advantages. One is preserving the stability of the gums, respecting the biology, which means there is no violation of connective tissue, junctional epithelium, nothing. So the biology is well preserved. And most important for the patient, aesthetics. Aesthetics was well managed. And the only disadvantage when it comes to BOPT is definitely the provisionalization. It takes a little time. And of course, the time period. The time period, like regularly we give the patient within 1 week. But in this case, that was not possible. We had patient wait for about 6 weeks for the final. Definitely we gave him provisionals, but 6-week time period was given for the final rest. So this was the only disadvantage, which is not really a disadvantages. So coming to the conclusion, yes, I said there are different disadvantages, but thinking about the advantages, it's a little higher. I feel prosthodontics and periodontics. BOPT will act as a bridge, by preserving the biology, not violating the biological width, maintaining the aesthetics and increasing the stability. So I would request the dentist, I know it's a little time-taking procedure, but at least when the patient is willing, once in a while, give a try, because after 1 year, when you see, you'll be so proud of it. That's it. Thank you.
Wonderful, wonderful speech. Any questions? Anybody have any questions? One moment.
A very nice presentation, by the way, and I'm a periodontist. So anything that will respect the gingiva and the bone, I'm the happiest person in the room, because most of the times the patients who come to me with normal crown preparations are always there is a particle with that's violated, and there's a lot of problems. So immediately when the crown is put on, everything is fine, the patient is extremely happy, and the problems will start probably a week or 2 weeks into the food lodgement and a lot of things. So I'm really happy that I got to know about this. Can you just tell me a little about the Okay, there is no finish line. So where does the preparation end? I just want to know.
Yeah, of course, this is a vertical preparation without any stop. So what we did was we used the width. There is no width, we know that. So instead of the normal width we have, we increase the width by removing a small layer of epithelium around the sulcus. So which is created, and immediately we give a provisional with realignment. So that space is immediately.
So that the gums will follow that.
Yes,
space.
that's why we gave a time period of you come back after 4 weeks, come back after 6 weeks. So that is, heat is according to the new provisionals. So
And the procedure can be done with lasers or
yes, but I didn't see any articles.
scan.
Yeah, it's very technique sensitive and not yet.
So you can do it with a scan.
Yes.
Any measurement or anything?
Usually. 1.1.
Okay, that's unclear.
Yes.
Thank you so much, Robin.
So
Wonderful presentation.
Thank you.
Thank you very much. I find that was really great. I just want to expand a little bit more on that, if you don't mind, just to clarify, because I think as a periodontist, we're used to cutting gingiva and scalpel. So actually, the curettage is not made with a laser or whatever. The curettage is actually made with the burr itself. So as the burr is cracking, that will naturally strip the epithelium and create it. And what it is you're not creating the restoration from the crown margin, you're creating the restoration according to the gingival. So the gingiva dictates, and that's why a doctor's waiting 6 weeks, because the lab, it's very important the lab, because you have to find a lab that will understand this, because the lab will go, where's the margin, where am I supposed to put it? And you have to instruct the lab, you need to follow my gingival margin and put it equidistant or just slightly subgingival. It depends how, and the restoration has to come out. It can't be the traditional where it's chamfered into the gingiva, because the gingiva will collapse. You actually need to make your restoration come out and support the gingiva. So it's the margin is according to the gingiva, and restoration has to come out. They can't do otherwise that will cause recession. The only thing with this technique is if the restoration, goes as they would do normally in the lab. They love to trim it and make it, then the gingiva will collapse.
Yes, thank you, thank you, thank you. The ticket.
Yeah.
You can hold. Okay. I think you want this one. Yeah, I can hold. Oh, hold it.
Yeah, we got this.
You want to get that?
Yes.
Yeah, so we're gonna, take the microphone again. So we're gonna take a quick break, but before we go to break, we need to take our pictures for the presentations. You guys can go to break, but the people that did their presentation, we need to take our pictures and give you your certificate, okay? All right, so we'll take our coffee break right now. Meet us back in the room in 10 minutes, please. Thank you, and we'll be ready for our next presentation. And we'll also take a group picture outside, okay? So go on and get freshened up. Inside and outside, okay? All right, so let's see. We got your presentation. Hey, Dr. May? I think I lost my camera man. Interesting. Oh, even the certificate? The certificate? Okay, you wanna do the group photo first? Group photo first, and then we're gonna get your picture. We do respect it after the we'll go out and we'll get your stuff again. We okay? Trying to keep it. I just didn't know. Like I'm looking at the prototype. Yeah, I need to not say that.
Yeah.
Hello. Meet you. We never met before every day.
No, we haven't.
I like that name.
Yeah, but I'm basically.
Invite me. Oh. That was easy. Come on, invite me.
I think I can. Hi, I'm Lee.
Yeah.
And so, yeah, I'm here since like.
Okay. Group picture. Oh, got it. Okay.
Which you really from the
Microphone. Oh. Okay.
Oh, I was. Yeah. Well, I was just doing. So we now have a visitor. And we did everything. Yeah.
Yeah.
I know who I'm in contact.
Uh, so it's you.
Yeah, I know the user. Yes,
Like, and you can log out.
yes.
This is my energy is like I said. Went to this on my internet.
So can you come? This one, right?
Yes, exactly. Try to open it so to make sure.
Well, you want to tell us this way this time? Okay, here, took that down.
Should we get down from here?
Oh, they have to move.
Okay, 1
We
minute.
either wanted the logo up or we take it here. You want the logo up?
Yes, fix it out.
Okay.
Yes, you come here.
Now tell me, where you from again here?
Yeah. Thank you.
I got a camera person question. Cause see, why do you do that? You put it for me. And then you go to her, then you snap. What are you doing?
We're gonna take the photos.
Checking the phone.
Yeah.
Okay. Okay, did we get me and Dr. Rana? These two. Oh, Doctor, he's just getting you, so not yet.
I'm you.
It's somebody else though. It's more. It's just Rana. That's
I have already arranged certificates in sequence.
Oh. Hey, we gonna have this in the next two. We gonna, yeah, it's a little time together. Spend a little time together.
Yes.
Thank you. Okay.
So I'll just.
So when we come back,
Yeah, we'll come back.
it's Dr.
Hamid. It's there.
Picture time.
Yeah.
I like. That's his style. Yeah. That's oh,
I can take it off.
Yeah, it all work.
It worked, okay.
Make it exciting. You hold it.
Logo, right?
You want to go? Logos. Foundational. Yes. Oh, we have the door. Sure. I'm not gonna win.
Yeah.
San Francisco.
Yes.
Great on my stage. Yeah, let me see what you're talking about.
Yeah, it's always really tasty.
Yeah. I mean, that's things. Yes. I'm like next to last. Let's see, Doc. Last long was fancy. Without my Lord, work hard. Here you go. Wait, let's sit. Oh, where's gonna be last? So these are my Ray-Bans. These just take pictures and, you know. I'm recording that.
So they over there somewhere, I just took some almost. But it says, he's from Iraq. And it's, huh? Yeah. It says here, right? Look. Wrong person, that's not you. Thank you for letting me know. You are on the last page, on this page, you're on, okay. Dr. Harnedy Kassim,
Yes.
that's how you pronounce it? Kassim? Kassim. Hamid like Kassim. Hamid Kassim. All right, there we go, we got it right. Okay, a math science and orthodontic, and an expert in innovative orthodontic procedures. You'll be presenting vital orthodontic approach, the enhanced precision and clinical outcomes. Ooh, this is what I need to know how to speak. Total art. Total art is elevation. Using infrared zygomatic. Infrared zygomatic. Total art is stimulation using zygomatic. Infrared zygomatic. Alright, infrared zygomatic. Why you do that to me today? Why you do this to me today? Why you do this to me today? Lord, you are challenging my ignorance. Thank you. I'll be grateful. And then we'll take your picture of time. And you link your certificate. Right? Yes.
I'll pick her pictures, but I don't have any.
They take everybody to music, then you start just tagging the girls, make sure you can picture him, and then they're gonna give photos. So you have that professional.
Yeah, it's not kind of on the kind of one, so.
Sure, somebody, I can't, somebody can help you. I'll take it in a picture. Okay, yeah. Okay. Okay. And then we'll start with. Yeah, got it. Okay. You see what class is. Oh, there it goes. All right, it's time. It's time. The ball is going up. Very comfortable outside. You have to go. That's exactly. Lunch is. Yeah. Okay, I got you. Yeah, the next president. Dr. Mami. Yeah. Mine is before lunch. Barsha.
What's it called?
It's an extra nursing redesigning care. Nursing redesigning. I'm going to have a case presentation.
Yeah.
I'll do that.
Okay. We're getting started in 1 minute so that we can get back on schedule. We're asking everybody to come in so that we can get started.
No shoes, other than. Then you can add.
Something different happening. What's happening? That's not what I wanted. Leave them to the meeting. All right, it's time to get started. Before we get started on this presentation, with this presenter, we need someone to hold his cell phone. Anybody, you have a cell phone? Okay, you already got some. Oh. Okay, everyone, thank you for returning back from lunch on time and respecting each and every speaker. So now we have the honor of welcoming Dr. Hamid Ghassemi from Iran, a Master of Science in Orthodontics and an expert in innovative orthodontic procedures. He will be presenting on a vital orthodontic approach that enhances precision in clinical outcomes. The title of this talk is Total Art Distillation Using Infrazygomatic Screw. Please join me in welcoming Dr. Hamid Ghassemi. Thank you.
Thank you so much for the cute pronunciations of the title. Hello, good morning to everyone. First of all, I want to thank the committee for inviting me here, and it's just such a pleasure to be among you. The title that I choose for my presentation today is Total Arch Distalization Using Infrazygomatic Screws. And the reason that I choose this topic is that nowadays among the patients, there are more demanding toward non-extraction orthodontic treatment. And since there are a huge number of class 2 patients which needs upper arch distalizations, well, with the advanced techniques and advanced devices, if you could do it in a way that to prevent extraction of premolars, it would be a very practical way of treating class 2 cases. And now I can confidently say it's been like 8 years that I haven't been extracting premolars from treating my class 2 cases, almost for more than 90% of my patients. First of all, go through a very short introduction of screws. Basically, we have 2 categories of screws according to the location that we place them. The old category was the intraradicular screws, which we used to place the screws between the roots of the teeth. That's why we call it intraradicular. And the newer version of the screws are the extraradicular screws. Why we call it extraradicular? Because we are placing the screws far away from the roots or from the intraradicular space. The shapes wise, we can see the larger diameter and longer screws when we are dealing with extraradicular screws. And the main difference is between the screws are the collar non-thread head of the extraradicular screws. If you see from the neck of the screws, do we have to point again?
Yeah.
Well, if you take a look for the neck of the screws, we have a non-thread collar head, which makes it very convenient in the areas of the mucus or the gingiva to prevent any mucosal or gingival irritations, particularly in the upper arch in the infrazygomatic areas. Well, there are list of advantages when we're using IZS. IZS stands for the infrazygomatic screws. There will be reduced possibility of unintentional root injury since the screws are locating far away from the radicular space. There will be always more available with the higher bone density in the areas like zygomatic crest, or when it comes to the lower arch in the buccal shelf area of the mandible. There will be, of course, no obstruction of tooth or set of teeth when we are dealing with mesiodistal movement of the dentition. And of course, there will be more reliable anchorage for different challenging biomechanics. There will be also significantly lower failure rate for the screws when we are placing far from the roots. And the last is that we always require fewer screws to tackle different problems. Unlike the intraradical screws, for cases we might need many number of screws to deal with the like distalization, intrusion, and etc. But with extraradicular, we have more chances of having less screws to dealing with different problems. But one of the issues with the orthodontists in regards to the infrazygomatic screws is that the challenge in placing the screws. That's why most orthodontists refer the patients for placing the screws to the surgeon. But believe me, it's a very, very easy job to do it by yourself. First of all, we have to know the best location for placing the IZS. If you take a look to the area that the zygomatic arch starts, below the zygomatic arch, at this boundary, we have this area for placing the IZS, starting from mesial of the first molar to the distal of the second molar. And we divided these two region to IZC6 and IZC7, which means the zygomatic area above the first molar and the zygomatic area above the second molar. Let's go to the CBCT to see which area having more available bone for placing the IZs. From the axial view, which is taken note from the deeper cuts, we can observe that we have more available bone at the second molar area. And when it comes to the coronal view, we still can see more available bone at the second molar area. But when we compare the mesial of the second molar and distal of second molar, there will be still more available bone at the mesial of the second molar. So let's say the best place or the best point for insertion of this infrazygomatic screws would be between the first and second molars. But there are exceptions, especially when we are dealing with growing patients. In growing patients, the area would move, the more available bone area would move forward, especially like, let's say at 15 years old, teenage, the area will be at the mesial of the first molars. But there will be limitations for placing the IZC And of course, the most limitation will be the maxillary tuberosity. The maxillary tuberosity serves as the distant area that we can apply distalization. And it starts from distal of the upper second molar to the inner cortex of the maxillary tuberosity, which will be somewhere here. This this length would determine how much distalization we could have for the upper arch. And the quality of distalization matters here. We could have pure bodily movement of the teeth. We could have teeping. The things that determine this issue is the architecture of the bone and the sinus at this area, and the available bone here at the cemento-enamel junction area. There was this study which was published in the Korean Journal of Orthodontics in 2024, which they studied the factors that would affect the distalization of upper arch. First of all, they determined three factors that might affect this the quality of this distalization. The first was the coronal zone. They found out that if the coronal zone, which is from the cemento-enamel junction to the crestal bone level here, if this distance would be increased, there will be teeping while we are distalizing the upper arch. And they also found that in the cases that we have fully erupted third molars, this area would be in a perfect way. And the other factor was the tuberosity width, which determined, again, the amount of distalization that we could have for the upper arch. And the third factor was the apical zone, which is determined by the architecture of the floor of the sinus. They measured from the most apical part of the maxillary tuberosity to the sinus floor. And if this architecture will be having will be increased, there will be obstruction while distalizing the upper teeth, and there will be a still teeping instead of bodily movement. And of course, there will be also the danger of root resorption. So we have to consider these three factors while we are selecting the patients for upper arch distalizations. And let's say again, if we have fully erupted third molars, those factors are in the best condition. Like this case, which I attempted fully arch distalization. There will be this in the other slides at the end. I will be showing you. But here, in this case, since we had the fully erupted third molars after extraction of third molars, we could have like a full cast distalization in upper arch because those factors which I mentioned were in the best condition. And in the cases that we have unerupted third molars, we have a good chance of total arch distalization if the third molars are above the crestal bone level. And we can have distalization, and later on at the end of the treatment, when the third molars are in the better condition for extraction, you can attempting for the extraction of third molars. When we are placing the screws, the size of the screws, the length of the screws matters. If If still, if we use the 8 millimeters length of screws, we could reach the 4 level, which is the screw part. About 1.5 to 2 millimeters should be outside. Then the attached gingiva, the cortical bone, and the non-cortical bone with the 8 millimeter. If we increase the length to the 12 millimeter, still we have the same for the screw part, for the attached gingiva and the cortical bone. But the non-cortical bone would be having more available bone to secure the screws, and hence having the better retention for the screws. So for me, in my practice, the shortest screw length that I use is 12 millimeter, and sometimes it's exceed to like 16 or 17 millimeters. For placing the screws, I always place the screw like 2 millimeter above the attached gingiva with the 90-degree insertion. I'll go like 1 to 2 millimeter insertion, and then I withdraw like halfway, and then changing the direction to the 55 to 70, and then go all the way. And while you are placing the screws, at the end you might feel extra retention, which means you are already reaching the cortical of the sinus floor, and that would be giving a bicortical retention, which is a good sign. Do not panic if you are having if you feel like at the end of the screw insertion you feel a very tough retention. It means that you are inserting to the sinus floor, and up to 2 millimeters there is no issue, there's no worries about that. And I highly recommend, if you feel that in a way the screw insertion, the path of insertion are through the roots of the teeth, or in the path of movement of the teeth, there will be possibility of the root injury. For sure, order for the CBCT and check it. If you see in the panoramic view, you could see both screws outside of the intraradical space. But after taking the CBCT, you see on the left side, the screws are passing in the path of tooth movement. Okay, here as I prepared this video, which is showing on the skull for the insertion of the screw. As you see, I draw the line to distinguish the IZ6 from the IZ7, and as I mentioned, the best area for the adult patient is somewhere between the first and second molar for the insertion of the screws. And let's say if that horizontal line is the 2 millimeter above the gingival level, so the attached gingival level, so the point there would be the appropriate point for the insertion of the screw. At the first, we screw about 2 millimeter with the 90 direction. And then we draw. And change the direction to the almost 70 degree. And the reason that the first beam, screw with the 90% direction is to make the ledge so that the screw will not slide while you placing the screw. And here is another video showing placing the screw on the actual patient. When it comes to the actual patient, you cannot withdraw the lines to distinguish the area of IZC with the IZ7. The best technique is to locate the point of insertion by palpations. When you palpate the area, you could easily find out where will be the most available bone in that area. So here again, it's almost 2 millimeters above the attached gingiva with the 980.
Oh, yes. Negative minutes.
Oh, okay. So
We'll see. Yeah, reckon, please, we are behind on, and I truly apologize.
okay, okay. How many more minutes can I have?
It's honestly, we had 20 and we're moving into 30.
Okay. So should I finish it?
As much as you can, as quick as you can.
Okay. Let's go to the biomechanics. There are three way of distalizing upper arch with using of the IZS. The first one is the direct force application to the canine, and then second one would be direct force application to the hook attached to the wires, and the last would be using the distal jig. With the first technique, when we are applying the force from the screws to the canine, it's effective way, but there will be side effect, which would be deepening of the bite. It might be beneficial in the cases of long face cases, which we need extrusion of the front teeth. And if we want to control that rotation of the anterior segment, we could use the extra intraradicular screws at the front to control the vertical component here. As you see in this case, I almost distalize upper arch for a full cusp, but here at the front, I use the screws to control the vertical component. And another issue with this technique is that since the force are applying to the canine, there will be rotation of canines while distalizing. In order to prevent that, I always use a very tight open coil spring between the brackets of the canine and the first premolar to prevent the rotation. The second technique is to application of force to the hooks attached to the wires. With this technique, the height of the hooks and the location of the hooks determines the vertical component. Like in this case, I had no issue with the vertical component. I placed the hooks between the canine and the first premolar. But like in this case, which I needed extrusion of the front teeth while distalizing, I moved the screws to the front with the shorter screws so that I could have rotation at the front teeth.
Thank you, thank you, thank you. The end it counts.
Thank you so much.
Now I'm down to a question. Or you want to go take it again?
Yes.
Okay, go ahead with your question and answers. for like 1 minute, and then we'll pull up the next one. Sorry. Any questions? Any questions? I know you guys were really interested. Any questions? No? Okay, we're moving on. Thank you. Oh, no, I didn't make. We'll wait till you come up. All right. Sorry. I truly apologize, but guys.
So we'll have to. Okay. At 2 minutes, is that? On the 2 minute, so you'll know wrap it up. It's our next one. We are honored to welcome Ms. Bahina Fernandez da Costa from the Kingdom of Saudi Arabia, representing King Abdullah bin Abdullah University Hospital. Her work emphasizes nursing workforce development, particularly addressing nurse retention with academic hospital settings. She will present her study on Saudi nurses retention in a university hospital, a cross-sectional study. Join me in welcoming Ms. Fabiana Fernandez da Costa.
You did, yes, you did. So, let me bring that. Amazing. Okay, good morning, everyone. I'm delighted to be here. My name is Fabiana. I'm a healthcare leader and I've been in nursing for the past 13 years. And today I'm going to talk to you about a topic that is really close to my heart and is about nursing retention and what strategies can we use to keep our nurses. So before we dive into the research that we have done at King bin Abdulaziz Hospital, I wanted to bring this topic a little bit closer to you. So I want to talk to you about a nurse's story. I want to talk to you about Aisha's story. So if you see the image on the presentation, I want you to picture Nurse Aisha. So she has always dreamed about being a nurse. Everything started when she was a child, looking after her grandfather. And she saw how nurses looked after him so compassionate and with so much kindness. And she promised herself that one day she will do the same thing to others. So when she finally finished nurse school, so she got her first job and she signed up for every single trainee. She mastered every procedure. She signed up for every committee. She was the nurse that always stayed late, always helped her colleagues. She dedicated her whole heart and her soul to her patients and her team. Years later, Aisha started to see that her dedication didn't bring any fruits. So she started to not feel recognized, not feel seen. So the light that shone in her eyes before when she thought about nursing started to fade. So now she's thinking about leaving nurse altogether. She's starting to maybe think about going to another hospital. Maybe if she goes to another team, then her hope will be reinstated. This is not just one story. This is the story of thousands of nurses all across the globe. And I want to dive into this research because I want to give you an idea on how we can change this for them. After COVID-19, the retention, if you look at the graph, this shows exactly the percentage of nurses per 10,000 population. So I really want you to have a look at that and see our situation worldwide. So the map illustrates it all, makes it clear that we have deep inequalities all across the globe. So the World Health Organization today projected a shortfall of 5.9 million nurses
By 2030, that number will rise to 10.6 million. Nearly 90% of this shortage, as you can see, is concentrated in low to middle income countries. So the pressure is visible everywhere. It's not just in Saudi Arabia. This graph shows the nurse turnover rate by region. So as you can see, worldwide, we have a shortage of about 16% in average. But if we dive deep into the regional differences, Asia currently has the highest turnover rates compared to North America and the US and Europe. However, when you look at North America, if you look in the US statistics, they are reaching 27.1%, which is really, really worrying percentages. So these differences, they reflect not just the workforce demand, but also a cultural context, health resources, and leadership practices. So what is consistent, however, regardless of where you are, is that turnover remains persistently high worldwide, particularly among young nurses. I really want you to look at this image and think about the nurses that you have met before in your life. Think about if you ever been a patient into hospital, if you ever took a family member, a friend to hospital. Think about the nurses that you have seen. So unfortunately, this reality is the reality for many nurses today. Across the world, burnout is driving absence, sick leaves, resignations, and a growing crisis of morale all over the world. In Europe, aging population and chronic diseases stretch our already fragile workforce. And in the US, I want you to really think about this. 1 in 5 nurses have left that work in 2022. If you look at the data for new qualified nurses only on their first 2 years, this number is even worse. We're talking about 1 in 4 nurses have left the profession. In the UK, the stress has caused in the last year 1.6 million sick days in a single year, leaving now the UK with 34,000 vacancies for nursing. In the Gulf, including Saudi Arabia and Abu Dhabi, younger nurses are leaving at the highest rates. So globally, as I said, averages 16%. In the US alone have reached 27% turnover. Each resignation will cost the hospital millions annually, not only in recruitment, but in training those nurses. So what this shows is that across very different health settings, the pressure is the same. The nurses are leaving, and they are leaving because they feel exhausted, they feel unsupported and undervalued. This is not just the workforce statistics, everyone. This is a warning sign of a system across the globe that is under strain, especially for young nurses. So turnover doesn't only affect staffing numbers, it costs hospitals. If you look at the US and the UK data, between $3.6 to $6.5 million annually are spending replacement and training for nurses. In Saudi Arabia, this number goes to 2.6 million SARS annually. This challenge intersects with Saudization policies, making local retention critical for achieving long-term health system resilience. So retention, again, is not about staffing issues. It is a patient safety and an economic imperative. Retention has become one of the most pressing priorities in healthcare today. Beyond the human impact, we're talking about financial burden. In Saudi Arabia, the urgency is even greater. So Saudi population is expected to reach nearly 40 million people in 2030. So with rising rates of non-communicable diseases and with Vision 2030, health transformation and nursing in particular will be central for improving outcomes. Yet, we face a high turnover. So driven by job dissatisfaction, limited career growth, work stress, and insufficient leadership support. This brings me to our own study in Saudi Arabia, because to solve a global challenge, we really need to start by first understanding our local reality. So what makes this study unique is previously, many studies have looked into the retention rate with expat nurses and Saudi nurses. But with Saudiization in vision, we wanted to look at what makes Saudi nurses stay, what makes them happy, what makes them leave. So this is what makes this study particularly important, because it's the first study that looks into only the Saudi nurses. So the purpose of our study was to understand the factors influencing Saudi nurses' retention in a university hospital. So we looked mainly at three things: job satisfaction, leadership, and work environment, with the objective of providing evidence-based recommendations with the Vision 2030. We surveyed 117 nurses in our hospital with 82 responses, which was a very high adherence, 70%. We adapted the Casing Think nurse retention survey for cultural relevance. Most responders were young. We're talking about 95% age between 20 and 30 years old. 95% were female, and nearly 40 already held master's degrees. But more than half, we're talking about 52%, had no experience with leadership. This contrasts a bit with results from the US and the UK, where the average age for a nurse is between 44 to 47 years old, and paints a picture where we have uniquely young, female, and highly educated nurses, although underutilized. So the top reasons why nurses chose to stay included the type of patients they cared for, supportive colleagues, and the intrinsic reward of making a difference. Time off and professional development opportunities also ranked high. They stay for meaning, constructive working relationships, and growth, not just for financial incentives. Conversely, the strongest driver for turnover were the lack of career promotions, inadequate salary, high stress, and unsafe staffing. The lack of leadership support was cited also for a third of the responders. So the strongest push factors for them to leave were career stagnation and pay, but culture and leadership also mattered. So what can we do? What do nurses want? So when we asked them what could improve their retention, what would make them stay, the nurses were very clear. They said better salaries, promotion and mentorship, strong support from their chief nursing officer, and additional benefits like housing and childcare. Recognition and professional development were also emphasized, although not statistically relevant. Retention challenges in the US, they center on early nurses, similar to our young Saudi nurses. In Europe, the problem is not numbers, but stress, burnout, and international migration. So for us, what we have learned is that our Saudi nurses' retention must combine financial, career, and cultural support. So these findings, they tell us that nurse retention in Saudi Arabia is not only about financial incentives. It's about culturally sensitive policies that reconcile professional and family responsibilities, structured by career pathways and leadership that is supported and visible. This aligns directly with Vision 2030, healthcare transformation goals. So investing in retention is economically and strategically vital. So in 2024, we started our research. We applied our survey, and by 2025, we had collected, analyzed, and translated those results into action. The message from our nurses was very clear, and we have heard that. So under new leadership, our hospital has moved quickly to create strategies that directly respond to our workforce told us. We have implemented a career ladder committee to develop the career ladder policy to support professional growth. And we are about to launch a leadership academy to prepare the next generation of leaders, and established a Voice in Action Council where Generation Z nurses sit together with their senior leaders and the chief nursing officers to discuss their concerns. We also turned our Healthy Workforce Environment Committee more effective, targeting the issues that were identified by our research. So perhaps most importantly, we have officially joined the Pathway to Excellence, which is an accreditation by the ANCC, for those who don't know, that support a culture where nurses feel valued, supported, and empowered. This is only the beginning, but it demonstrates that when nurses speak, their voices can and must shape the future of our profession. As I conclude, the evidence is clear. Turnover is not just a local issue, it's a universal challenge. And it's not just about salaries. It is about recognition, visible leadership, career growth, and cultural support that allows women, the majority of our workforce in nursing, to balance family and professional life. Globally, salary, promotion, leadership, and benefits, they remain the strongest drivers. But locally, we must adapt this to our culture context. Retaining Saudi nurses is not only about filling vacancies, it is about building a resilient workforce aligned with Vision 2030. If we invest now in the early stage nurses, we can provide career ladders, listen to their voices. We can ensure that the next generation of nurses, they not only enter nursing, but they stay, they grow, and they lead with pride. This is our opportunity. This is our responsibility to secure the future of nursing. Retention is not about keeping nurses in the jobs. It is about keeping hope alive in healthcare. Thank you.
Nurses, love nurses, great.
Any questions?
Yes, any questions? You keep the mic. Keep the mic. Here we go. Let me grab the other. What do you hand it to him?
Yeah, it's common. I'm originally from South Africa, and even what retention is, we just lost tens of thousands of nurses to the rest of the world after training them, after investing in them, etc., etc. So I don't know. I know the pain. One thing that I'd like to relate to is in the work that you've been doing in Saudi Arabia, have you looked at using AI in terms of retention, in terms of some of the predictive retention models that are out there? And I think some guys are using it very effectively to some points on that.
For raising that. We had some discussions with our IT department. So it's a work in progress, and AI, as you know, AI is very, very new to all of us. So we're trying to implement AI more into patient data than into medicine. But why not? Absolutely. That's something I can take back to. So thank you.
It was, I just want to applaud you for your wonderful presentation. And as you said, it's not a local issue, it's a global issue of nursing education. I have, as you have said rightly, a big percentage of the staff leaves just by having the support from leadership. See, there are a lot of issues that are around us for the nursing education, but as a leader, it is in our hand. What are the strategies which you can work on, and then we can treat analysis and voice of nurses. To hear the voice of nurses is very important. Just to add up, what we have done it in our we have actually QR code has been placed at every nursing station. So now if they face any issues, they can just log into QR code and they can write their operational issues or website issues, which comes directly to the chief nursing officer. And if they don't resolve it, it comes to the chief nursing officer. And all this will be present in our quarterly town halls. They feel their work, and we have a stop life report. Which we can resolve, which we cannot resolve, which is in progress. And I can tell you, we have really worked on our nursing retention, and I can say that our nursing attrition was 23%, and we have got down to 18%. That's right. Working with various strategies. Yes, there's a lot of things which comes locally in your own hospital when we implement those strategies. We can prevent a lot of attrition things. Thank you so much for this wonderful presentation. Thank you very much. And actually,
our hospital, we have, well, our chief nursing officer has started a completely different shift in culture. So he has placed notes all over the waiting areas for patients, and all the nurses in our hospital has the mobile phone of the really, really brilliant.
Thank you for this wonderful presentation. I'm from Germany and we are recruiting and I have a cultural question. So in recent years, we recruited a lot from Brazil and from the Asian countries, from Africa. And the long-term integration, cultural integration is a open topic for us. Yeah, I mean, not just in the short run, but also over the years. What I use was on the intercultural aspects, different cultures, different ethnic groups, integrate them. What's your solutions or what's your thought about that?
I can comment related to our research. Our research says that the reason why some nurses are not being they stay is because of relationships they have. So the way I see it, very way to tackle that is creating opportunities for nurses inside the hospitals to be able to meet, creating the space inside the hospital. Because the nurses, when they arrive into a new country, they will not be inviting their colleagues to go out, they don't even know where to go. So the hospital needs to create clubs and activities. The nurses can meet each other and create those relationships. Because actually, we just human beings, we want to have friends, we want to be able to have good relationships. And research proves that if we have healthy relationships at work, actually the outcome is much better for the patient. Absolutely. That's good.
Thank you for that. Working with nurses for the past 18 years, I usually interview. I had nurses that worked with me for the past 12 years, 10 years, and I would love to keep them and retire, keep the retention very high. But you tackled a very important point. Whenever I sit with a nurse, the only thing is the financial part that keeps them, and of course the environment. So whenever I have a nurse that stays with me for more than 6 years, that's a good indication for me that she's working in a healthy environment and she's satisfied with what she has been given. But in this study, you've mentioned about the financial. Have you asked the nurses exactly what are the financials they're looking for? Because sometimes when you go deep in the questions, it's not only the salary, but maybe other benefits. This is what I recognize from my experience. So in Saudi, because I would love to share knowledge between different markets. Over here in the UAE, usually nurses look more for benefits because some nurses, not all of them, are paid satisfactorily, but they're starting looking for other benefits that is considered to them. Is that also what's happening in Saudi Arabia? Are they looking for salary or for other benefits? Because nowadays other benefits is money also.
Thank you. That's a very good question. Yes, so our research looked into salary, but also looked into benefits such as housing and childcare. So I think our interest is to understand and really know our nurses. So what do they need? Because also we know that economically it's very hard to keep up. We can have the same salary for many years, so it's hard to keep up with the rising cost of living. But our nurses, what they said is that even if they didn't have high salaries, a healthy work environment, and if they had access to childcare and housing, they would stay. So it was a percentage of them, a high percentage that would stay. So that was our answer to that question. Anyone else has any questions? Thank you very much.
Thanks. Thank you.
Yes.
Thank
you.
Thank you.
Okay, and now our next speaker. Let's make sure everyone. Yes, okay. Our next distinguished speaker is Ms. Christina Omars Hudson from Saudi Arabia, serving as Director of Nursing. She has been at the forefront of patient-centered care, focused on redesigning nursing workflow to enhance the patient experience and streamline healthcare delivery. Her presentation is titled, The Patient Experience Reimagined, Nurse-Led Triage Redesign
and flow optimization. Do I look happy? I like to scare. Okay, so y'all know I'm emergency. So for her to be working on triage and front end flow tells me she knows exactly what she's talking about, and I'm excited to hear this presentation. Please help me welcome Miss Christina Morris Hudson to the stage.
I'm starting to feel like I'm standing between you and lunch, so I'm going to do my very best to stay on track. My name is Krista Morris Hudson, and I've had the privilege of actually working in the Middle East for the last 11 years, originally from Canada. I took part in a fantastic project in Qatar. I was there for 5 years to help open Sidra Women's and Children's Hospital. Then I had the opportunity to come to the UAE. I was both in Dubai and Abu Dhabi, and have just spent the last 2 years in Riyadh. And I feel really privileged to be here and to be part of the global health community, to be honest. So, how many of you have been patients in the emergency department? Yeah, pretty much everybody, right? So, I'm sorry. So I think what's really important is that what I want you to be thinking about today, regardless of whether you're a dentist, you're a nurse, you're some healthcare profession, I want you to actually be thinking about yourself as a patient in the emergency department, because today I'm actually going to take you on a bit of a journey. And so if you can imagine yourself as a patient, this experience is actually going to feel very relevant to you. Help if I put my glasses on. Okay. So this is actually a culmination of a lot of work that I have done in several emergency departments. I actually have been nursing for more than 30 years. And I've been in leadership positions for 21 years. I've spent probably 75% of my career strictly in the emergency department. And so this is a project that is very near and dear to my heart, and it's not the only place where I have done work like this, but this is the first time that we were actually able to engage a very large group of frontline nurses and nursing leaders, along with our physician colleagues, in this kind of project. So what we were facing is absolutely massive. We were seeing 500 plus patients a day in a level 1 emergency department. So trauma, recess, urgent care, you name it. Huge overcrowding. And as you have been a patient, you've said, I'm sure you've experienced that regardless of where you come from in the world. Very long wait times, and are left without being seen rates, which are actually higher than 15%. Astronomical. That is an astronomical statistic. And of course, what does that lead to? Poor patient satisfaction. So that was a huge driver for us. And in the midst of all that, most importantly, was the incredible burnout and the stress, the violence, everything that our frontline nurses were being exposed to. So it's a no-brainer. Why reimagine triage? Well, it's because it's about patient safety first and foremost, because we want to keep the patients at the center of everything that we do. It's about providing enhanced patient flow, which keeps us more efficient and more effective. And it's about patient experience and staff experience, because as a colleague of mine was just talking about, was that the importance of retention. So our drivers for change, patient experience scores, #1. We were being benchmarked against hospitals in the MENA region. And unfortunately, and not proud to say, we were experiencing scores that were less than 60%. That is not where anybody wants to be. We had a need for nursing-led innovation because we wanted to find a way to engage and empower our nursing staff and engage the workforce. We wanted to drive patient-centered care as a benchmark for quality. We wanted to be that hospital. We wanted to become that hospital in the region that people did want to come to. And because we were facing increasing patient volume, like many EDs around the world, not just here, but we have that seasonal growth when we face flu season, or, for us in Saudi, half the country leaves because of the heat in the summer. And so then everybody comes back around the middle of August, towards the end of August. So we have these huge influx of volumes that come through the emergency departments. So when you look at that population growth, what comes with that naturally is also some of that trauma burden. And most importantly, we needed to be responsible and make sure that we were aligned with the Saudi Vision 2030. There's a huge component in that for healthcare transformation. So where do you begin? And the most important place, I'm a huge proponent for lean methodology. I have been using lean methodology. I'm a yellow belt, green belt. I'm just working on my black belt. You have to start at the beginning. You've got to take yourself right back to the roots and look at what was happening. So what I did was with this team, I actually said, meet me at the front of the emergency department today. So I had nurses, I had managers, I had assistant managers, and I had 2 physicians with me. And I said, this is how we're going to start. We're actually going to walk our patient journey today. And they all looked at me like I was a little bit crazy, but I want to tell you what came from that exercise was absolutely incredible. So we started with that, establishing the patient flow, really looking at what our current state was. Then we looked at the nurse-led assessment that was being done at triage. Absolutely horrible, not in line with CTAS. We use the Canadian Triage Acuity Scale, not in line with proper CTAS standards. We had multiple points of entry for patient flow, and nobody, until we actually walked the journey together, had any idea that that's what was happening in our department. So it's no wonder that we felt frantic and chaotic every day. We had batching of patients happening. Nobody wants that. If you know anything about lean methodology and keeping your processes clean, you don't want to batch patients because you're automatically creating inefficiencies within your system, which means you're impacting your patient experience. We had multi-directional patient flow. We had patients moving in this forward in the process, backward in the process, and we were moving our patients so many times instead of maintaining this philosophy of let's bring the care to you. And we had no identified space for ambulance triage. And when you look at the need for cultural sensitivity, for us, that was extremely important because we would have, for example, female patients come in on a stretcher and they would just rock up to the triage desk in the middle of this massive ER waiting area. It was not a good experience at all. Some of the limitations that became very evident, we had bottlenecks at entry points, poor design for the triage assessment space. So if you can just imagine for a moment, for those of you who understand or have, because you've all visited emergency departments, when you come into the emergency department, you come up to triage, you expect that that nurse is going to be sitting at a, maybe a desk, a table, and they're going to be able to see you and they're going to be able to reach across and touch you. That was not the case in our emergency department. We had triage desks that were probably up to my chest height, and our nurses were reaching across, doing a pulse oximetry to test your oxygen level and whatever basic assessment they could do in a split second, and then determine your CTAS, determine your triage scale and where they were going to put you. So that was limiting the capacity of our nursing staff to provide a proper assessment and to determine what is the best place for that patient to go. And we had no controlled access into the ED. So literally we had people on people on people everywhere. And we had no defined waiting space. So I had personally never experienced this before, but we had no defined waiting area in any of our emergency department. So you can imagine as the patients and their families were coming in, there was this perception of first come, first serve, and it was a bit of a free-for-all. So where do we start? So I mentioned that I'm a lover of lean methodology and value stream mapping. So this is literally where we started. So once we walked the journey, I said to the team, okay, we're actually going to now put this on paper. And I'm going to tell you, I have been doing value stream mapping, flow mapping for probably at least 15 years, minimum 15 years. This particular exercise took me 6 hours to do value stream mapping for one small area in our department. It was probably one of the most challenging exercises I've ever had to do. And not just for me, but remember, I was working with a team of nurses who had never done anything like this before. Not my managers, not my assistant managers, not nursing, not my educators, not even my chairman or my physician colleagues. So when you're driving something like this, it is really important that you help them understand why this is so important and the value of the work that comes from this. So we started with that so that we could have a visual, because when you can show people just how bad your patient flow actually is, you engage them, because then people want to fix it. Then they can understand this is why we're doing what we're doing. So we looked at a redesign framework, and of course you need some guiding principles. So we decided that as a team, our language was going to become flow before wait. Keep it simple, but make it catchy so people, your team really understand it. And I'm talking about your frontline clinical staff, because I needed everybody to be engaged in this. We had 500 plus nurses on the team. So flow before wait, and you want to move those patients forward. We broke it down into sections. I said, I want you to think about the front of your house, right? How do you get your people, your guests from the front of your house into the right room? So we added this mantra of right care, right place, right time. And I think for those of you who've been in healthcare for some time, you've heard that before, but that became extremely, extremely important, because what was happening is that people on this team wanted to keep going back into our old processes because it was comfortable. We knew it. We felt good about it. We understood that. But when you're moving a patient 6 times, do you think that that is what's best for the patient or what makes sense in terms of efficiency and care? No, it's not. So the next step was extremely important, and this was a big culture change. We needed to empower our nurses as decision makers. So I made sure that the chairman, the head of our department, was completely on board, because pretty much if you've worked in an emergency department, or if you've worked in a good, or even visited a really good emergency department, the nurses are the ones who need to drive patient flow. Nurses need to drive the flow because they see the patients, they assess the patients, they do the interventions, they know when that patient is ready for discharge. Out you go, grab the physician, this patient's ready for reassessment, can you see them? And let's get the next patient into the bed. Nurses drive patient flow. If we don't empower them to get them to own that, to build their confidence, then this is never going to work, right? So, and then finally, how do we embed technology and data analytics? And I'm going to get into that in just a little bit more, because we do have a big opportunity with this. So in terms of how we started with this redesign, we actually first basically blew up our triage area. And I mean overnight, like I literally overnight. It was like the renovation, the construction guys ascended the next day, and we did a complete physical redesign of the triage area. And that was so that we could support an appropriate, complete triage assessment. Because how can you put a patient in the right bed the first time if you haven't done that? So we did that. And the goal was because we want to enhance patient-centered care. We want the patient to really feel, we've heard you, this is what we're going to do, here's where we're going to put you, because now we have defined patient flow pathways. So that physical redesign of the space was extremely important. And I will tell you that my nursing staff were very nervous about this because they felt very exposed. But it didn't take long for them to finally realize this feels good. Our first weekend, it was just remarkable. You could see the difference in how they were owning the flow and their patients, and the difference it was making in the patients themselves, because they actually really felt, wow, he's taken a full set of vital signs, asked me where my pain is, really done a full assessment. So that was the first thing we did. And then, even though it pained me, as a nursing team, we really had to own our practice. And this was hard because we had physicians, you know, they would say, Chris, you know, your nurses, they're not doing proper CTAS assessments. They're not assigning, you know, the right codes the first time, and we're having to upgrade all the time. Nobody wants to hear that. And I hate when people say we have to upgrade their triage. You never upgrade a triage. So you never want to hear that. So I know that we had gaps in our nursing practice, so immediately implemented it. I created a triage audit tool, and we actually had a core team of champions. And I said, we're going to apply this tool in a standardized way so that we, you know, have inter-rater reliability. We're all getting the same results. And we started auditing. And what we discovered is 100%, we were all over the map. So we needed to close the gap on that first, and we needed to do it quickly. So it was about teaching the staff like a crash course in proper CTAS application, because that also dramatically affects patient flow, right? Because, you know, they wanted to triage everything at a level 3, which is a higher sense of urgency. And that is not the case. We did not need that. And we certainly don't have the capacity to always be accommodating that, when in fact, we could be accommodating those patients into more of a fast track area, getting them faster care. So this was a big, big piece of work for us. So getting the CTAS, the right, again, patient, the right care in the right place at the right time. And we wanted to support rapid decision-making because the department was such a high volume ED, and initiating redevelopment, sorry, of the existing patient tracking boards. And this is where we got into some of that, the technology piece of it, because the particular system in this hospital, we'll just call it the electronic health record, you know, their boards were not actually designed. So we were losing patients, if you can imagine. And that is a huge, huge risk, right? So immediately we pulled together our informatics team, our nursing informatics team. We pulled together people from IT. We redesigned our boards, and we actually did two really important things, which I'm going to get into in a second and talk about. But we wanted to increase that visibility because we wanted to make it safer for our patients. So in terms of this model, what did that look like? We did a split flow. So what we decided was we were going to make this two possible entry points into the department. And we were going to create a rapid assessment. We had a rapid assessment area, but it was definitely not being used as a rapid assessment zone. So we wanted to do rapid assessment and the streamlining of care pathways from all points. So when you break that down, you're basically looking at 3 levels of acuity. We have a 5-level, CTAS is 5 levels, but I'm going to make it simple today. So high acuity, that's a no-brainer. Those patients just need to go directly into a recessed trauma bay, high acuity point immediately. There's no waiting for those patients. Everybody got that? Yes, they did. So that was good with our team. Moderate acuity, this is where the challenge came through, because this is your middle patient population that can either go one of 2 ways, right? You can have a basic abdominal pain, just as an example, and they could, or chest pain. Chest pain's a really good one, because some people will over triage and say, oh, no, that patient's a CTAS level 2, I need to get them in here immediately. When in fact, we're talking about a 25-year-old female patient. It's probably just having some anxiety and does not meet any of the criteria for a level 2, but would be appropriate, stable level 3 and could safely wait in the waiting room until we got the bed. So we had a lot of conversations around this piece. So we talked about nurse-initiated protocols and established some patient care pathways, nurse-led protocols, whatever you want to call them, but we actually established them as nurse-initiated protocols, NIPS. And then they were transferred into the correct zone where they needed to get the right care. And then those low acuity patients, we created something the hospital didn't have. And we built a fast track area. And within that, again, nurse initiated orders. So we could do labs, we could start IVs if they needed a little infusion, all based on these pathways. And then we introduced a dedicated phlebotomy team, practically had to give up a kidney to get some staff from other areas. But we needed that because this was about enhancing rapid patient care, right? Assessment to care. So we were able to get a phlebotomist dedicated to the ED. We were able to get ECG technicians dedicated to the ED so that nurses could do what nurses needed to do and physicians could do what they needed to do. So it was a very well-rounded model. And then on top of that, we introduced 5 chair spaces into the fast track area so that if you were somebody who came in with your sprained ankle and you needed to be seen quickly and you had your x-ray and now they wanted to give you something for pain and just hold you for reassessment, we could move you out of that stretcher space into one of our chair spaces. So you'd still be taken care of by a nurse. You wouldn't be lost in the system, but we could put another patient in that stretcher that needed to be there. So we had a rapid turnover model. And then we also talked about phase 2. I don't have enough time to talk about that today. However, bedside, the phase 2 for us is actually bringing registration to the bedside, which we don't currently have. So that is a part of a technology change. Then we looked at flow optimization strategies, and that's where we looked at team-based nursing. We looked at point of care testing for rapid decision-making. Again, real-time dashboards for tracking waiting times inside and outside of the ED. We talked about nursing-led patient flow, and this is a big one. Pull to full model. We use that language everywhere across the department, and that was huge. That is because that's the nurse's role again in driving patient flow, keep the beds occupied, reduce any idle time, get your physicians reassessing, and enhance the patient experience. And this was a big thing too. We created a disposition waiting room, which I alluded to earlier, so that we could get patients out of the bed and waiting, where they'd still be monitored and assessed by nursing staff. I'm running out of time and I'm talking fast, so you know there's a problem when. Okay, so what was the role of the emergency nurses in this case? They needed to be the gatekeepers of flow and safety. They needed to be using more advanced assessment skills, which they had not previously been doing, so they were empowered to do that. Critical thinking, absolutely massive with this team. Adhering to standardized practices of triage, leading rapid interventions because we needed to decompress areas. We had to build in our capacity for that. Advocating for patient experience, and of course, collaborating with our physicians. So I will end here just by telling you, these were some of the most incredible outcomes that we saw in a 30-day period. We actually decreased our door to triage to first nursing assessment, and time to ED physician first assessment by about 15% overall, which was a massive change. We decreased our length of stay. So fast track patients were now being seen in and out in about 2.5 hours. Previously, it was 6+ hours. Are left without being seen in the first 30 days, we decreased by 11.3%. Our patient satisfaction scores, I can tell you preliminary, we only have seen so far in, I only got the data for a very quick snapshot, was about 10%. But a win is a win. Most importantly, the biggest, most important change that came from this was the overall nurse and physician satisfaction. I could walk around that department every morning and I was getting positive feedback, because one of the things I did was I left clipboards at every station and I said, I want you to tell me what were your challenges today and what were the things that went well. And after the first 5 to 7 days, we stopped having challenges on the clipboard and we actually started having things we needed to celebrate. And that was actually critically important to this change and changing the culture within the environment. So I will, I'm going to end there. Our key takeaways: nurse-led triage redesign. I'm going to tell you it's transformative. My nursing team feel very empowered, very engaged, and they're looking forward to the second phase instead of being afraid. Nurses as leaders in healthcare redesign, absolutely essential. And engaging your frontline staff when you're doing changes like this is imperative, because they are the ones who work it and they need to own it in order for this to be sustainable. And I think the last thing I just want to say is never give up, never ever let up with this kind of change, because even good change feels hard. But if you let up even for a moment, you will lose your momentum and you risk that sustainability, right? So that's about all I have to say for that. I did rush through a few slides, but if you have any questions, I would be happy to take them for you now.
Any questions? Any questions at this time?
Thank you, Stephen. Thank you so much. This is really, really important. I really felt that we are in our hospital. Yeah, because what you have said and what you have done, almost everything they just they left without being seen in the emergency department. It gets a reduction with all of what you have said, but what we have recently implemented is the same like what you said, but we added something called referral of category 4 and 5 to the outpatients. At some time, you really needed the bed, you really needed the space, you really needed the hands of emergency department team, doctors and nurses in those category 2 and 3. That really helped a lot. And the data driven really, you can see the extreme drop down of the numbers of the left without being seen after we implemented the referral to category 4 and 5. And this was also nursing driven.
Yeah, I think that's a great point. We actually had that in place already. So which was a very foreign concept to me, because in Canada, we don't like to send our patients away because that's always a risk. There's a risk liability there. But for us, we were triaging level 5s away almost consistently all the time. So primary health clinics, the outpatient department, where we could, other more appropriate centers, like women's or children's, things like that. I agree with you 100%. That's essential.
So, Christina, thank you very much. And I love your tagline of right care at right time and right place. With that, I would like to add here that
because every emergency faces such issues. So for right care and right time, we have added in sitas, like pediatric sitas as well as obstetric sitas. Because these are the things which is, because when usually if you see many of the hospital, they use a generic sitas for all the kind of populations. So if you have pediatric sitas, it will help you for the pediatric.
built in OTAS.
Yeah, OTAS, yeah.
that.
But we have two hospitals being for those patients. Students will leave relatively take peace. They get diverted to the children's hospital and also with women, so we have a standalone women's. But you're absolutely
Exceed us for the navigating the conditions at right place. Thank you so much.
Thank you.
Well, let me get oh.
I thank you for the presentation. I just had a curiosity actually. When we look at the change management theory, did you find that the sense of urgency was already there when you started this change? And the second question is, in terms of difficulties and challenges, what was the biggest challenge when you implemented this change?
Oh,
Positions, could have been a position?
or like how many positions are in our room? Like okay. Sorry, the first part of your question was about the sense of urgency. What was really interesting is that this team, nurses and physicians, have worked in this model for so many years, literally just trying to hold it together and do everything they could, that I don't think that they could see beyond that. So they didn't share the same sense of urgency as the CEO and everybody else. It's like, you have to fix this now. And I came in as the fifth director of nursing in 8 years. So nobody had been able to tackle that challenge. So I did feel like that was probably a very big challenge for me because I needed to create a sense of urgency. To your second point though, yes, I had probably the biggest pushback was from the physicians because they are actually very understaffed. And with this patient flow transformation, we changed our flow so much and we opened 2 new care areas that they struggled to staff that and they were really feeling the stress. And so what did they want to do is naturally go back to what was already working in their minds. And we had to keep showing them, no, this is going to work. Just hold on a little bit longer. And I found 2 physician champions. That's vital. You have to find people who will believe in it. So I had 2 physician champions and I had some really good nursing champions.
Perfect, that was the key. Perfect, great, Brian. All right. Let's take. The great job. Everything. I don't have any questions. She said everything I would have said, right? So that was some good stuff, and I'm excited about it. All right. Okay. Hearing someone else speak that language is everything to me, so I truly appreciate it. All right, so I'm gonna introduce the next speaker, okay? It'll probably be helpful if I get my glasses. That's what was hurt me the last time. All right, welcome our next keynote speaker, Dr. Mahita Shrivastava. Mohita, okay, from United Arab Emirates, neuroscientist and neuropsychologist. Today, she will deliver her talk on, is your hospital cognitively equipped and mindfully aware? The Cognitone program, next frontier in cognitive training and rehabilitation for patient care, safety, and compliance. She is affiliated with the leading institutions in neuroscience and psychology, contributing extensively to the cognitive training, rehabilitation, and patient safety. Please extend a warm welcome and help me welcome Dr. Mahita.
Um, Good noon, everyone. I've been listening since morning, all the beautiful presentations from all of you. Specifically, a few of the presentations were focusing on the burnout and stress that the frontline healthcare professionals are going through, especially the nurses. So, I think this is a very untouched topic that people don't often talk about and think on the matter that no, I mean, for a shift of 12 hours, morning shift, night shift for the nurses, it is actually putting a toll on their mental health. Now, before jumping into this presentation, I would actually like all of you to understand the difference between mental health and cognitive health. Yeah. So, to me, I would rather say that as we all know that, we are all here united by a single powerful mission to heal, to provide safety, to deliver excellence in healthcare. But I want you to ask yourselves a question that goes to the very heart of everybody who's involved in this mission. A question we as an industry, as a healthcare professional, as a healthcare provider, have not asked loudly enough. And what is it? That is your hospital, is your practice cognitively equipped and mindfully aware? Now, let me ask a question to all of you. What is the difference between mental health and cognitive health? Because when we talk about this, we only think about emotions, mental health, burnout, stress, and all that things, right? So, what's the difference? What is cognitive health we are talking about here? And why is it so important for the frontline healthcare workers? Well, so we'll be dwelling in this, what is cognitive health, and how we will have this presentation go forward with first understanding the difference between cognitive health and mental health, and importance of cognitive health in hospital care and patient safety. And it is, trust me, it is a very crucial and important topic, and very crucial for patient safety. Cognitive challenges in healthcare and the cognitive program and its pillars, future of healthcare, the SEMA model, and of course the key takeaways. So, we spend millions on the latest MRI machines and on the state of art robotic surgery facilities, on digital patient records, CRM management, and all those stuff. We equip our facilities with the best physical technology available. And that is, of course, vital for any state of art facility to have. But what about the most complex and sophisticated and the crucial technology we all have in between two ears? On your head. That's the brain. That's your brain. That is very important. Mind you all, I'm not talking about mind here. I'm talking about your brain. And there is the basic difference it will come, and we will understand that what is mental health and what is cognitive health. So, for too long, we have taken the human brain, the engine of clinical decision making, the seat of empathy, the source of skilled motor action for granted. We assume that because someone is trained, their cognitive faculties are automatically optimized for the immense multitasking, high stress demands of the modern healthcare. And guess what? Neuroscience tells us that is a dangerous assumption because our brains are not designed for multitasking. In the corporate, if you ask in the leadership, multitasking, if you're a multitasker, oh my God, you will get so many appraisals and promotions and all that stuff. But to you, all of your surprise, neuroscience tells us that our brains are not designed for multitasking. Okay, now, stress, fatigue, and cognitive overload actually are not just the HR issues. They are neurological events. So what do they do actually to us, to the healthcare professionals? They shrink our perceptual window. impair our working memory, focus, and attention, and degrade the executive functions, the higher order executive functions, like your decision making abilities and strategic planning, impulse control, reactivity. These are all higher order executive functions, and it is very, very, very important. So, I think that are the bedrock of the patient safety, and that is the gap that brought me here today. And this is why I actually founded the Cognitome program. Think of Cognitome as a tool of complete immense cognitive training and rehabilitation, which is just not confined to the app based or digital exercises to train your focus, memory, and attention, but it's in totality a complete holistic neuroscientific evidence based program, which includes your neurokinetic exercises, neuroaesthetic training, celebration techniques, which we call as neuroscientific mindfulness techniques, which is not just focus on your breathing or look at a candle or a flame. It is completely not only rewiring your brain, but also channelizing your HPA axis, your hypothalamic pituitary adrenal axis. It targets your complete neuroendocrine system. That is why we call it as evidence-based neuroscientific celebration techniques, which are the mindfulness techniques. So now, understanding what is cognitive health. So as we all know that cognition is the mental process of acquiring knowledge and understanding. It is a set of core brain functions we use to think, learn, and remember. Cognitive health is the foundation of robust cognition. Whatever you do, whatever you are, I'm speaking to you, you're comprehending, you're listening, you're understanding. It's all your cognition. These are all your cognitive abilities, your intact brain function. It has nothing to do with your mind at the moment. It has nothing to do with your mental awareness or your mental health or your emotional tones. You are here present and listening and paying attention to what I am talking, and your brain is processing that information, and you're understanding and comprehending it very well what I am talking. It's all about your brain. And so, do you think, you all being the healthcare professionals, do you think it is important for you while you're working in a hospital setting or a clinical setting, or whether you're a dentist or a nurse or a doctor, clinician, physician, a surgeon, do you think it is important for you to comprehend, to understand, to have that precise precision motor skills while performing a surgery? It's all cognition. It's not about mental health and emotionally aware and burnout. So, a cognitive healthy brain can effectively learn new things, remember what is important, solve problems efficiently, maintain focus and attention, adapt to new situations and challenges. By the way, if you would like to understand more about cognition and your cognitive health, you can refer to the articles published in Khalij Times. I do used to write a column in Khalij Times on brain and behavior. So, and we do have a magazine which is Cognizine. You can subscribe to it and you will find weekly articles on your cognition and cognitive health. So cognition is basically, brain is like a hardware and mind is like a software. All the thoughts that are generated are because your brain is processing the information from your environment, and your thoughts are being getting generated out of that information. Your five senses are involved, right? And the stimulus that you're getting out of from the environment is being processed inside your brain. That is called as information processing. Okay, so your memory, focus, attention, decision making skill, understanding what I'm speaking right away, or for that matter, anybody else, and talking to each other, paying attention, impulse control, your strategic planning. What do you plan for a surgery? How do you plan a day? How do you plan a treatment approach for your patient? Is all cognition. And mental health is simply a state of well-being that encompasses or our emotional, I mean, like for example, your stress, sadness, anger, happiness, all your emotions, psychological self-esteem, resilience, and outlook on life, and of course, building and maintaining healthy relationship within the society. So it's a social well-being also. So it has nothing to do with cognition. So now, why cognitive health matter in the hospital? What do you think? Why cognitive health matters in the hospitals? Because of improvement of cognitive healthcare professionals, patient challenges with cognitive impairments. The role of cognitive health and patient safety is addressing your cognitive essential to improving outcomes and reducing risk in hospital settings. Because enhanced cognitive functions or cognitive abilities, which we call as overall cognitive health, can minimize errors and foster a safer environment not only for patients but also for yourself. So, what are the patient challenges with the cognitive impairment? Patients often face cognitive impairment from illnesses or medication, long term chronic use of medications, and reducing their ability to engage effectively with the care plans. This limitation can hinder communication and adherence to the treatment protocols and affecting recovery and outcomes. Hospitals, as we say, hospitals are intense environments where cognitive overload, decision fatigue, and chronic stress heavily impact healthcare professionals. These factors contribute to attentional lapses and emotional exhaustion, leading to preventable errors and compromised patient safety. And next is the stress and its effect on decision making, because decision making is a very important part of all the frontline healthcare workers. Chronic stress in hospitals, excessive decision fatigue among healthcare professionals. This can lead to a compromised judgment and increased likelihood of mistakes in critical situations. It's all about burnout, which we call in a layman term stress and burnout. But it's actually your neurological perturbations, which your brain is not able to tackle anymore. And in general terms, we say it's a burnout, it's stress. And how do we see that stress? We see that stress in the form of behavior. We are getting irritable, angry, not able to comprehend things, not able to understand, you know. So that stress and its decision making, that is actually and eventually hampering your entire decision making abilities. And importance of cognitive engagement in care plans, because effective cognitive engagements is very crucial for the patients understand and follow their care plans. It's not only for you, it's for the patients as well. Improving cognitive patients to take an active role in the recovery process, and that is why our cognitive program has a very unique thing that we always have a, I mean, whosoever is coming, whether it's a patient or any corporates or any school or any university that is the people are coming to us. We give a class, we give an awareness session about cognitive health and why it is important to you, and understand how your brain is important. And please understand the difference between your brain and mind. We are not talking about mind here. We are focusing on the cognitive health because that is more important. And stress and burnout are the byproducts. Actually, your mental health, your emotional tolls or anxiety and depression are the byproduct of the impaired cognitive health. So the cognitive challenges in healthcare professionals, as I discussed, overloaded with cognitive demands, decision fatigue, as I mentioned, decision making and the strategic planning are higher order cognitive functions. Second is attentional lapses because of the multitasking. And as I mentioned, our brain is not designed for multitasking. And for that, we have different techniques. And one most common is the Pomodoro's method. And then emotional exhaustion. For the patients, we can see that cognitive deficits from illnesses, trauma-related impairment, medication effect, prolonged use of chronic medications, and reduced engagement with care plans. So now introducing the cognitive program, it has been awarded, globally many awards, and it's running globally. And what is it? It's already users informed mind-based cognitive training and rehabilitation framework. Now, when I say mindfulness has become a fad nowadays. Every Tom, Dick, and Harry, you go there, and everybody is having meditation and asking you to focus on your breathing or focus on a flame, and then forget about your stress and everything, and then everything will be okay. I mean, think very, very consciously about this thing. If you're really under stress, if you're really under burnout, or emotional stress, or relationship issues, or financial issues, do you really think just focusing on your breath and focusing on a candle will take it away? No, it will not happen. And I mean, if you ask me, if you really ask me, if I'm under stress or something happened to me, I definitely don't do this breath work for sure. Though this is very important because it actually channelizes your autonomic nervous system, your parasympathetic and sympathetic mode, and your vagal tone. It is very important, but there is a way to do it. Just not if anybody is saying, and a big studio of meditation with so much of light and sound healing and everything, and then you do it and it will be done. No, it will not be done. I'm saying this with full responsibility, being a neuroscientist. My background in neurosciences for the past 15 years. So that is designed specifically for the clients to enhance their cognitive capabilities. And why I focus on cognitive capabilities? Because your mental health is the byproduct. Anxiety, depression comes. If you have a sound cognitive health, trust me, I'm not saying that you won't feel anxious, or you will not have depression. You will have it. But then the way to deal with it will be, I'm 100% sure that you are not going to take any medication or anxiolytics or antideps or SNRIs or something like that for that. So, in fact, few of my clients were taking these medications since grade 10 are out of the medications for anxiety and depression. So, first of all, why I'm saying to focus on your cognition and understand what is cognitive health, because this is what is cognition, your information processing and understanding. If you understand what is happening inside your brain, inside your body, you are able to control your mind and you are able to control emotions. I'm not saying that you won't have anxiety, because these are the relationship, financial, social. Of course, it's very common to have it. We have a neuroendocrine axis. I'm not saying that hormone will not play a role, neurotransmitter will not play a role. They will play their role, but you will understand your brain will challenge and deal with the situation very effectively. And I'm talking about brain. So mind is just the byproduct. Okay, so enhanced healthcare innovation by combining neuroscience and mindfulness. And this program aims to prepare institutions to become cognitively equipped and mindfully aware. This initiative integrates cognitive neuroscience tools and mindfulness practices. Now, I'll be coming to my next slide, and I'll be telling you what are the few modalities I'll be discussing here, what we use. So you will be able to understand the difference between the mindfulness practices better. So cognitive program is actually, of course, there is cognitive training, which are structured exercises targeting executive function, working memory, focus, clinical decision making under pressure. And I'm under pressure at the moment because I'm getting a signal from there that you're just left with 5 minutes. But I think that this is a very, very good topic to discuss and to make everybody aware about. And I'm in dearth of time, so I'll speed up a little. And another one is mindfulness based approaches, which are cerebration techniques. And why the word cerebration here? Because of the cerebral hemisphere, cerebral cortex, or prefrontal cortex. So we induce neuroplastic changes, both functional and structural. Structural takes time, functional is a little faster. Now, cognitive rehabilitation, which is like tailored pathways for patients coming from neurological events, chronic illnesses, or long-term hospitalization. And it is always, rehabilitation is exclusively for the patient. Training is for all of us. So the first pillar is immersive stimulations, VR assisted challenges, and for the clinical decision making, manual and digital cognitive training. I focus mostly on the manual task. Why is that so? Because when you're doing certain tasks, or even, for example, just writing something, not typing on a keypad, just writing with a pen and paper, all of your senses are involved. I give you a if I give you a cognitive task to do for certain cognitive function, I prefer to do it manually rather than doing it digitally. But since digital is quite automated and you get the scores instantly, so that is also a part of the program. And then team-based cognitive drills. Second pillar is basically mindfulness-based stress, resilience, and awareness. So, chronic stress, burnout significantly impair clinical judgment, attention, and decision quality. And we do have around 13 to 14 neuroscientific mindfulness based protocols at the moment. And cognitive rehabilitation for the patients, which is tailored rehabilitation pathways. So, the cognitive rehabilitation for patients and for all of us includes neurokinetic method, neuroaesthetic training, and immersive cognitive stimulation. So neurokinetic is your finger gymnastics and your hemispheric lateralization exercises. Aesthetic training is music and art based, and rest of them are, of course, general cognitive training and rehabilitation protocols. So the future of hospital care, becoming cognitively equipped and mindfully aware. And within cognitive and mindfulness practices, the same model integrates cognitive capacity and mindfulness at every organizational level. This ensures a human-centered approach to healthcare. For resilience and awareness, this model emphasizes cultivating resilience, situational awareness, and mindful presence. This benefits both staff and the patients in the hospital in proactive error prevention and transforming healthcare. SEMA positions hospitals to deliver safer, more effective, and compassionate care. And when I say, please don't misunderstand me when I say when that your cognitive health will improve, it doesn't mean you will lose on empathetic side, because cognitive health also includes emotional intelligence and creative intelligence apart from IQ. You will be able to, rather, your emotional intelligence will increase because you become cognitively aware. You're consciously aware. You're not dwelling on the subconscious part of your mind, which is actually pushing you without having a conscious thought over it. So, this is the upcoming potential of healthcare hospitals that embrace the cognitive program, and SEMA model will be resilient, aware, and optimized, cognitively prepared for excellence in care. This integration holds transformative potential for hospital management, patient experience, and systemic safety performance. The urgent need for cognitive approaches, because 40% of the hospital errors stem from cognitive factors, including memory lapses, inattention, and decision fatigue. Less than 5% of the institutions have formal cognitive rehabilitation programs for patients, and none of them is for the healthcare professionals. Fewer hospitals integrate evidence based mindfulness training for the staff. So, I would just come to an end. The key takeaways: cognitive functioning is a critical yet overlooked determinant of the healthcare quality and safety. The program provides a practical neuroscience-based framework to enhance clinician performance and patient rehabilitation. Mindfulness and cognitive training are essential for reducing errors, enhancing focus, and promoting well-being. Embedding cognitive rehabilitation in patient care increases adherence, participation, and recovery. SEMA hospitals represent the future, resilient, aware, and cognitively optimized for excellence in care. And that's why I say the brain you train is the mind you sustain. Clarity of the mind. And so perform keeps mental stress at bay. So things now live happy as many harmony. You can contact us. These are our contact details. You can follow us on LinkedIn, Twitter, and the floor is open for the questions. Thank you so much.
Any questions? Do we have any questions from the audience at this time? Question. There's an interesting fact you brought up, which has changed my mind since you're a neuroscientist. I was surprised to know that our minds are not multitasking.
Oh, ladies are not multitasking.
But although females are well known, sorry for all males in the room, are multitasking, and maybe nurses are one of them. We are multitasking. We can talk on the phone, cook, take care of a baby, and even wash something that is dirty on the floor. So can you please explain how our minds, especially females, are not multitasking?
See, what I said is about brains. I'm not saying about mind. Brain is not designed for multitasking. Meaning, brain is allowed to do only one task at a time. But just to increase your efficiency, your performance, decision making skill, and to keep your emotional thought at a bay. Now, what is happening in this era, in this year? First, everybody is symptomatic customer self. I mean, preaching here is something different, but telling you the neuroscience is something different. We call the multitasking. But what is happening? The long-term effect of the multitasking. We should understand. And specifically, this is a very question about feelings, about the mothers, about the wives. You know, we are actually. I mean, I'm not saying men are not multitasking. Of course, they are. But comparatively, yes, they are. Of course, they are the fathers.
They are also the husbands. And they are also very much active. But happens is a long time. Why it happens? Because the brain has certain regions. Like for example, very simple example, very clinical advice. Here we have all lobes, right? Four lobes. Each lobe is designed to do certain tasks, right? And in each lobe we have some vertical structure and everything else. It's designed to do which is the work has been assigned that you will be doing this, like a cardiologist will take care of your heart, a neurologist will take care of your brain, right? Same thing happens. So what happens? Of course, the brain is working in a network. Everything is happening in that way, but the long-term effect is that, for example, if I overload a cardiologist and I say a neurologist is not here, but because you have an MBBS degree and you are a doctor, can take care of you. So, not really. Exactly, not really. Because the neuronal network is there, and so there is a phenomenon called as compensated hypertrophy. So, or cortical reorganization, because we keep on giving that stimulus to the brain that we have to do this also, we have to do. So, this is neuroplastic change. That automatically happens and our brain actually forgets its original task or it gets a little diminished. So, efficiency, work efficiency get stability. Your peak performance is perturbed, impaired. Ideally, we should know what is the what we can do is there is a Pomodoro method, which is a while you're doing multitasking, everyone is working. So assign 25 minutes, put an alarm, 25 minutes, put an alarm on your cell phones, do one work at a time. For example, you're working on an Excel sheet at the moment, finish it off, and then because Excel sheet is all mathematical, analytical, logical, entering data. But if you're supposed to write an email to your boss or some of the clients, that's entirely different. That's entirely different region of the brain that will come into picture. But at the same time, one thing is you're doing Excel sheet, and then you're supposed to have to write an email to somebody. Then you should allow 25 minutes. I will finish my Excel sheet. Next, after that, put an alarm and just go for a 5 minutes break. Do anything you want. You want to smoke, smoke. You want to chat to your family member or do whatever. You want to have green tea, coffee, whatever. Just take 5 minutes break and then come back and then do the other one. Okay, that will save your brain and efficiency. That's what. That's the only.
Eat the frog first. That's the methodology. I think that's also helps in time management.
Time management.
Yeah. Because prioritize. Yeah.
Task here is we are not with two tasks at one time. I mean, I am not saying that if I am a doctor, I am a professor, I am only teach. I have to do research, I have to check the notebooks, and I have other things to do at home as well, right? What I am trying to say is, you have to assign time to one single task on a frame of window, and which will not become monotonous for you. Also, and then you can change your task, but a gap in between is essential. To switch over the regions of the brain because they need time to get settled and to get activated.
I have a question. Sure, this one person. So I'm a multitasker, and then I try to do this one time thing, right? Like do work on one thing. But if I'm on, if my internet going slow, I'm doing some research, my internet's going slow. I have to do something. I pick up something else and I start working on that until that answer comes. Like, is that not okay? Am I doing like is something wrong that I can't sit there that long time without picking up another project?
Like working in that manner. You just channelize
I'm
and
ER.
practice.
I'm ER. So that's okay. All right. Thank you.
One task at a time, and then show the other task after 5 minutes of break. Just to break certain time to.
Any more questions? Real questions, not like mine. Any more questions? All right. Thank you. Thank you. Thank you.
Thank you.
Speed it up, y'all, so we can get to lunch. We have two more speakers before lunch. Before though, we go to lunch. When we break for lunch, we need everybody to meet in the back
of this room so we can take a group picture and then we'll break, okay? Two more. No pressure on the next two speakers. All right, so our next speaker, Dr. Ahmed from Iraq, an expert in orthodontics. His contributions to advancing imaging techniques has provided new dimensions in orthodontic diagnosis and treatment planning. He will present on the topic CBCT in orthodontics. Please join me in welcoming Dr. Ahmed.
I think. I am Dr. Ahmed Shiraida from Iraq, Basra City, and a master degree from Duisburg Essen University in Germany. Today, our lecture and my presentation is about CBCT in orthodontic. It's working. Okay.
Yeah, it will work now. Let me put in presentation mode. Try this.
Which one? Yes, this one. All right. In orthodontic treatment, we always, in the past until this day, we depend on, my voice I think is good. I will not need this. Okay. In our orthodontic treatment, we always depend on two radiograph image. They are 2D. These radiograph image are the OPG and the lateral cephalometric. This is in the past, and nowadays we use these radiographs. While these techniques have provided valuable information, but these two techniques in radiograph nowadays have a lot of limitation. These limitations are superimposition of the structure, geometric distortion, and lack of volumetric information, limited assessment of the TM joint and airways, and subjectivity of cephalometric analysis. The emergence after that, in 2000s, the emergence of the CBCT in dentistry. In 2000s, CBCT revolution dental and orthodontic diagnosis by offering. Now we have a revolution in diagnosis of orthodontic treatment, because the CBCT gave us a true 3D imaging and gave us a very high resolution image and no overlapping. We can see each subject individual. And accurate measurements, ability to perform linear, angular, and volumetric measurement with high accuracy up to 0.1 to 0.2 millimeter, and relatively low radiation exposure. What is CBCT? CBCT is a device consists of a source, X-ray source, that hit to the face, especially the jaw and the teeth, and there is a sensor that converts the X-ray into a 3D image in computer. There are three types of field of view in CBCT. The first type is the local small type. It is 5 by 5 centimeter. In this type, we can see only 1 to 3 teeth, and we can diagnose the TM joint problems. And there is the maxillary medium, which is 10 by 10 centimeter. We can diagnose one jaw only, either the upper or the lower. And craniofacial, the large one, it is 15 by 15 centimeter. We can diagnose both jaw at the same time, vertebral disc prolapse, and the sinuses. Important, the smallest one is the low radiation one. This is an example for the local small one, and this is example for the medium one, and this one example for the large one. What's the uses of CBC in orthodontic nowadays in my branch? First, and it is the most important thing, is the evaluation of impacted, transposed, supernumerary, and ankylosed teeth. Always the impacted teeth, which is the most famous impacted teeth, is the upper canine, which may be impacted horizontally, maybe buccally and palatally, may be close to the root of the lateral incisors, and also other teeth may be impacted, especially the upper central incisor, the lower cusp and bicusp, also the wisdom teeth, and maybe we found ankylosed teeth. Tough impacted. Every tough impacted, we need three things. First of these things is 3D accurate diagnosis. We must have accurate diagnosis in our 3D image. I mean the CBCT, and we must do a proper surgery design and precise mechanic to make extraction for this impacted tooth. I will start with my cases. I do these cases in my clinic. Lower right impacted canine due to odontome. We have this lower impacted canine, and there is a small odontome that prevents the emergence of this canine. We can see this is the small odontome, and this is the very deep impacted canine, and it's very difficult to traction it without removing this odontome. After we reaching our treatments in orthodontic treatment to rigid arch wire, we use excisional approach for the canine exposure, and I use a double wire technique to start obstruction of the canine. At the same time, we do removal of this bone and removal of this odontome that prevent the canine from its emergence. After that, we can see this is the primary canine, and there is odontome removed. After that, we start to traction this canine. We reach this result. We have the permanent canine start to erupt in its place. Case number 2, horizontally buccally impacted canine. This is a horizontal buccal impacted canine, which located buccally and with very close proximity to the root of the lateral incisor. We can see here. We start with first extraction of the C. After that, we do internal approach to the canine, and we put a gold chain inside the canine, and we start to pull the canine in a horizontal direction to correct its direction. We use a tab between the 6 and the 5, and we start our traction. After it becomes little straight, we start with another force, which is a vertical force, to pull the canine into place. After that, we have this result, and I use a torque coil to correct its torque. We have these results. The canine now in its place, and it's beautiful. Case number 3, we have this deep impacted canine, and there is a supernumerary tooth that prevents its emergence. We can see it's a very small tooth, but it prevents the canine from its emergence. Okay. After we removing the supernumerary tooth, we do a surgical exposure of the canine by open technique, excisional approach. After we reaching a rigid arch wire, we use a gold chain. We put it on the rigid arch wire. After that, we use a double wire technique by a double wire. After that, we do up bend and start to traction of the canine. How many orthodontists here in the room? General bend. After that, we start to traction of the canine with a very little force, because this traction have no friction. If there is no friction, there will be a very high force, so that we must choose a very light force to prevent the destruction or the ligaments of the canine. After that, we have the canine in its place. After that, we have the canine in a very good place, but need little root torque. Case number 4, we have upper horizontal impacted canine, but it locates palatally, not buccally now, it's palatally behind the teeth. We can see it, it is in the palate. Here, we do also excisional approach, open technique. We put lights on the canine and use a lever arm, which consists of 1825 TMA wire. After that, we use a double force, but with ballista. We have the canine now get slightly from its place out. After that, we have the canine in good position and start to traction it in a horizontal direction to get it in its place. After that, we use double wire technique. Now the canine siblings. I speak this thing very easily, but it is not easy. It take from me 3 years to put this canine in its place. Yes, take a lot. Slightly horizontal impacted upper right canine. This is a slight horizontal upper impacted, and we have a primary canine here. We make extraction for this primary canine. You can see here. When I make extraction for the primary canines, the canine gets slightly in its place, and I use a ballista, start to traction of it. Here, after 1 month, we can see the canine get in its place. After that, I use a down bend and pre-friction force. We get the canine in its place. Now the canine in its place. Now we have also horizontal palatal impacted canine with very close proximity to the root of the lateral incisor. We start with putting of tag in between 4 and 5, extraction of the C, lever arm, and gold chain, and we start to pull the canine vertically from its place. Another force to assist me in pulling it. Now we have the canine in this position. We start to traction it horizontally. Now it's in its place, but it is rotated. We try to correct it by put another force in this direction, and now the canine is in its place. Now we have another tooth. We speak about impacted canine. Now we speak about the upper central incisor, which is a horizontally impacted. We can see here, we start with excisional approach and use a gold chain and down bends I make in the wire. After that, double wire technique. We start to see the canine now. After that, 1 wire. After that, we see the central in good position. And here we use torque coil to correct the root torque. We can see here in its place and in a good root position. Now, this case is very difficult. We have 2 supernumerary tooth above the canine, and it's horizontal. We remove this supernumerary, and after that start traction. We didn't remove the upper supernumerary because we see it in CBST, no need for remove it. After that, we start traction. We can see from this to this. Here we remove the supernumerary that above to it. And here you can see the central siblings. We speak in the first part about impacted canine, impacted teeth. Now, the second used for CBST assessment of the periodontium and the alveolar bone. We can from it diagnose the alveolar bone, the periodontium. Third use is assessment of the proper site of temporary anchorage device. CBST will give us where is the proper site to place the TADS, because TADS is very dangerous, especially the infrazygomatic TAD and the buccal shelf TAD need special technique so that we don't do a root injury or sinus perforation. This is the infrazygomatic mini-TAD, and this is the site of origin, site of insertion of it. How we insert the stats? We start in a vertical direction. After that, we change our hands to a 55 to 70 and we insert it. What's the difference between infrazygomatic and radicular and interradicular type? We can see it's out. This is out of the roots. This is the infrazygomatic type. Here, this is the normal type, interradicular type. It is between the roots. This is out of the roots. What's the benefit for the CBST in insertion? We can make a 3D design and surgical guide for placing of them so that we prevent the injury for the roots. This is the surgical guide that we do in a 3D design so that we can use it to put the tat in a correct place. What's the benefit for infrazygomatic tat? Maxillary distalization, molar intrusion, molar mesialization, and impaction or transposition. This is the site where we put the buccal shelf tab. Also, we do surgical guide for replacing these tabs. Now, clinical cases. This is an example for this tab. We put it interradicular between lower canine and fore, and we use elastic that the patient will be changed every 2 days. For correction of jaw count, we can see here the angulation of the jaw is not correct. It must be straight like this. It's jaw counting. After that, we have this result from this one to this one result. And this is an example for infrazygomatic tab. We use here double force, one horizontal force, so that we can traction off the teeth and with them we do a distalization of full arch, and another force is vertical, so that we can make intrusion for posterior, so that the anterior will get extrusion to close this open bite. We can see the result. This case also, it is little class 3 with open bite. We use both tats, infrazygomatic and palatal interradicular tats, and we use a power chain for intrusion. After that, we get this result. We can see the open bite being closed. This is another case. The patient is class 3, open bite. We use infrazygomatic. We do intrusion for posterior, extrusion for anterior, but here we do mesialization of the upper arch. We can see, we put here power chain. This power chain will make mesialization for the upper arch. Now, the use for CBST is temporomandible joint analysis. It gave us where is the condyle head in the fossa. We can see here in anterior and superior and posterior. Always the articular fissure in anterior articular space, in anterior area, the articular space must be 1.3 plus minus 2. In superior articular space, it must be 2.5 plus minus 5. And posterior articular space must be 2.1 plus minus 3. Now, also the CBCT is used in upper respiratory tract assessment. The black and red and orange color gave us that there is a narrowing of the respiratory tract. We can see here the position of the tongue must be very close to the, must cover all the palate. If there is space between the tongue and the palate, this is an indication for maybe have the tongue is incorrect function, and which lead to narrowing of the airway at the oropharyngeal level. Also, the CBST gave us a craniomandibular disorder. We can diagnose this diseases like elongated stylioid process. We can see here elongated. Okay, and the another is ossification of oblique atlanto-occipital ligament, which here the cerebral artery is bus. It will make a compression on it. These findings may indicate craniofacial disorders. This is very important for orthodontists. Bin analysis, we do it also in CBCT. We can measure the width of the lower arch and the upper arch, and we calculate the upper arch must be more by 5 millimeter from the lower arch. Here we see the lower arch is less than the upper arch by 5 millimeters, so that we need expansion for the upper arch, surgical expansion. We do it by Marby or other devices. Also, the CBCT gave us evaluation of the symmetry. We can evaluation the symmetry, left and right side of the face. Key feature of 3D cephalometry also, the CBCT gave us more information than lateral cephalometric and OBG in diagnosis. Also, in a cleft lip and palate patient, novel method, it gave us how much alveolar bridge we have. Here, there is no alveolar bridge. This is called a novel method. Here, the alveolar bridge is less than the width of the root of central incisor, and here is less or equal to the width of the root of central incisor. Here, the bridge is more than the width of the root of the central incisor. The AI and CBCT, nowadays there is a DiagnoCard. It's a program that we use to make diagnosis for the CBCT. Okay, this is the program. It will make, we put STL file on it, and it gave us a diagnosis for everything. Also, it do diagnosis for 2D radiographs, the OBG, we can see here. Thank you for attention.
Any questions? You have questions, sir? Okay.
Sure.
Thank you for your presentation. As you about annual impact book time.
Yes.
Yeah. When it was more than 25%, we can orthodontic treatments or we should extract. I see your slide. If it was horizontally, you can.
Yes, no.
Okay.
No limited. No limited. Only the things that limited in our work as orthodontists for traction of canine is if it is enclosed or not. Any direction we can tract it. First, we correct the orientation of it. After that, start to pull it in its place. Yes, it gave us accurate diagnosis for ankylosing. Before I didn't use CBCT really. In 2017, I didn't use it, but I depend only on OBG, and I start to track the canine. After 1 year, I see it's not moving from its place. After that, the patient in shock, I am in shock, and I am in a very difficult situation. So that nowadays, I didn't put my hands on impacted canine. Yes. We must not deal with any impacted tooth only if we have CBCT. We must not deal with OBG and lateral cephalometry. No. For age, in orthodontic treatment nowadays, there is no limit for age. We can do for. I have children patient in my clinic, and I have a very big, about 75 years old. I do for him nowadays orthodontic treatments. Thank you, everyone.
Thank you very much.
We're going to take a picture.
Yes.
Stay careful.
Okay.
Here we go.
Yes. Thank you.
I'd like to thank Mr. Anna for a wonderful chairperson hosting this morning. So I'll be taking over the afternoon now, and we have one more lecture, lunch. So sorry about Akansha. We'll try and make it as quickly as possible because I know you're all ready for lunch. I just want to say at the end of the last presentation for lunch, they do just want to take group photos. But if you'd all just like to make your way to the back of the room, they're just going to take a group photo and then we can go for lunch. So just like to welcome Ms. Akanshka Dukola from the UAE. She's the Group Chief Nursing Officer at Medcare Hospital and Medcare Centres. She's been at the forefront of driving nursing excellence and innovative care delivery. You're going to present on next-gen nursing, redesigning care by eradicating non-value added tasks. Please join me in welcoming Ms. Akanshka.
Thank you. Thank you so much. And as the responsibility is given to me, only 15-20 minutes. So I'm going on my presentation directly. So before, I'm not wasting my time in introducing myself, but before I go to my presentation, I want to ask the audience here, how many of you, especially nurses, nursing leaders who are here, how many of you have not experienced nursing shortage? Okay, I'll change my question. How many of you have faced the nursing shortage? Okay. You will say, Akansha, we know it's nursing shortage is the global issue. Our colleague just before me, Fabiana has already said that how important it is, well articulated that how important is the retention of nurses. So what new into this? So before I dwell into my presentation, here we go. There is no sound. The sound is not there. Sorry guys, there is no sound. Why is there no sound for this? I think my sound is. It's okay. Now my presentation is going to, my video is going to get.
But did you know that almost 30 to 40% of your staff's time is wasted in doing non-core jobs? And untracked operations often result in confusion and delays. Result: chaos, low productivity, demotivated teams, and poor patient experience.
So I think many a time we must have experienced this chaos. Especially, I can tell you when I was staff nurse, definitely I've experienced this chaos. So many people calling me, and so much of work. As doctor said, multitasking becomes difficult. Yes, though we women are known well for multitasking, but there is a limitation, and it becomes difficult and it's quite overwhelming. So when it's quite overwhelming, we have to redesign nursing workflow. So as I said that we had a key performance indicator that we need to reduce our nursing attrition rate from 23% to 19%. And I said before that, yes, we know that it's a global issue, but we have to see how locally, how we can address this issue. So when we had this KPI, what we have done we have done a burnout assessment test on nurses. And after that, the nurses who were in a zone of burnout, we had a focus group discussion. In focus group discussion, there are a lot of issues have come. And one issue definitely many of nurses have added into non-core activities. And when we are going into the non-core activities, one areas where we have come across is our call lines. So when so I'll just go into this.
So our call lines were the major issues. And in a hospital, when patient needs something, patient has to press a call line, and there's expectations from the patients. And I think it's a due respect. Yes, it is a quite reasonable expectations that they want a nurse to arrive in front of them within a seconds because they need something. But when they need something, nurses are not free because they have to attend many more patients. And this call bells, when we have seen that the videos, like almost 30 percentage or 30 to 40 percentage of the activities are core activities. Patients have been calling nurses by 30 to 40 percentage for non-core activities. So in a hospital setting, so we thought, okay, fine, let's study this. So what we have seen, the objective of this study was that, nursing call, because there are some positive calls and there are some negative calls, and now we need to redirect these calls. How do we redirect these calls? We can't have a separate call bill for housekeeping, separate call bill for F&B, separate call bills for engineering. So then we thought, okay, fine, let's study first what are the issues. So this study actually focuses on what are the different strategies which we can utilize, especially on this area where we can reduce the nurses' core activities. So the objective of study was streamlining workflow. So by developing or implementing the strategies which can actually streamline the workflows where we can reduce the call lines, because yes, patients needs it, but how we can reduce those call lines where nurses will have, we can prevent frequent interruptions, because when they are doing some, especially some important, the critical activities, and you can say a lot of studies shows that when there is frequent interruption for the nurses, this is a major cause of nursing clinical errors. So we wanted to focus on that. Increasing direct patient care, yes. We have a shortage of nurses, and I think all of us, the leaders who are sitting here, we need to see how we can redesign our workflows where we will able to use our nurses for direct patient care. And then comes up definitely with that, we will able to deliver a quality patient care, a safe care, and we will able to optimize the nursing efficiencies. So what did we do? We have collected a data for call bills for 15 days. On-ground data was collected. So categorizing the call bills or the call lights into clinical and non-clinical in nature. Then we have analyzed the data of attending call bills more than delays, especially more than 5 minutes. We have set this internal benchmark that if any call bill with delay in attending the patients for more than 5 minutes, we can take that as a delays in attending call bills. Then count of call categorized by the specifying in clinical and non-clinical nature shift-wise, and determine the time spent for closing those calls, especially clinical and non-clinical. And then comes analyzing the factors contributing for nursing call bill activations. So we collected 2,561 total call studies. In that, 1,641 were clinical in nature and 947 of non-clinical. So 36.9% call bills were non-clinical in nature. Now, from that, you can see we have the more than 5 minutes, total 56 calls were there. And from that, 2.2% were clinical calls. Quite alarming. When there are clinical calls are delayed, definitely there's a clinical needs for the patients is getting delayed. So that was quite alarming for us. And delayed calls, when we have studied the reason for delayed call was 62% were because the nurse was attending another patients. Okay, and other factors like 12% of attending doctors and 8% of medication preparation, shift handover, and so on. So shift specific calls. In morning, we had more clinical calls compared to the night because we have 12-hour shifts. So night were non-clinical calls in nature. And reason for clinical calls were IV medications, ADLS, activity of daily livings, pain management, clinical doubts, and procedure shift. And reason for non-clinical calls. quite alarming. Housekeeping needs were 35%, engineering issues, operational issues, 25%, F&B died 26%, and 1% call bill press accidentally. So average time for taking to complete the call bill was for clinical, it was just 8 minutes, and non-clinical was 12 minutes. Because non-clinical calls closure, it's not in nursing health. They have a lot of dependency on others. So that's the reason it's taking more time. And if you can see that 1.2 hours per shift by per nurse was spent in morning for closing non-clinical calls, and in the night 1.48 hours. So key strategies. Now we have done the analysis, because if you do the analysis and if you don't act on it, it's a reason for paralysis. So we thought, okay, fine, do the analysis. So first on clinical processes, because that's in our hand. I said clinical processes. So what we did it, as you said, as you have seen that a lot of calls were delayed because of the IV nurse was busy in attending the IVs, or there was delays related to the IVs. So we thought, okay, fine, revise the drug dilution policy, because various time in hospital it happens when we have a committee. Lot of drugs have been, including some antibiotics which can be given bolus, or some painkiller which can be bolus, but usually they dilute in 100 ml or 50 ml, and the nurse has to start IVs, and then they have to redirect, or they have to keep observing those IVs. And if the nurse, they will inform the patients that whenever it's about to finish, press a call bell. So there were a lot of calls related to that. So what we did, we have revised our drug dilution policy. Reminders for IV infusions, because once you put the IV, you know it's okay, fine, you're going to start a syringe for my infusion pump, you know it's going to finish within this time. So use your phone meticulously for giving you reminders. Then we have view board. Now, what is a view board? It's an acronym. Next presentation, which definitely I'll show you what is a view board. And then comes for the ADLS, it's an acuity-based assignment. Different acuity tools are there in the hospitals. You have tests that is therapeutic intervention scoring for ICU patients, and NHS has their acuity tool. But what we have used is a time task matrix, because time task matrix is the acuity tool is basically designed for the Asian hospital, and which it's not only calculate the acuity of the patients, but it calculate what is the time required for each task. Because what happens, like I'll give you example, you have a patient who is a normal delivery, and you have a LSCS patient. So you will say, oh, LSCS patient post-surgery might be acuity high. But normal delivery patients, where patients need assistance for breastfeeding, nurse is going to spend more time with the patient. So that's the reason this time task matrix actually calculate the time required for the patients for direct patient care, which will help us to actually do a proper assignments, where we can reallocate the work or the workload based on the available of the staff. But when it comes to the non-clinical process, as I said, that there was a lot of calls related to housekeeping, F&B, and engineering, and so on. So it was difficult to have so many calls. So we wanted some help, because as I said, that we have, as a nursing leader, it's our responsibility to redesign the workflow. So when we have to redesign a workflow, we actually had a team, multidisciplinary team, because it's a responsibility of the not only the nursing leaders, but entire hospital managers, managements. All of us, we came thought together how we can resolve this issue. So we have come up with the technological solutions, which I'm going to talk about here: pillow menu and diet menu. So this is a view board, which I was saying. View is the acronym, that's vital information, important activities, expectations from patients, worries from the patient. So this has helped us to reduce a lot of clinical doubts from the patient. It's displayed in every patient's room. So patient becomes a part of the care. So usually whatever the questions are there, patients have been written here and they have been answered by the nurse. So they are aware and they are the part of the care. So the heart of healthcare means the heart is a spend the pulse of technology system, which can help us to redirect this call. So we have come up with this technology, which is called as so what happens with that? This is the system, this is the app which can work on your Android or iOS app, the nursing station of your home. So this is been kept in every patient's door. And what we have done it, all the frequent needs what are there of the patient have been listed down. Like in housekeeping, what are the different needs patient has it? Or in F&B, what are the different? Or in MEP, like whether they need a TV remote, whether they need a different channel on TV, on their TV. So we have listed all those frequent needs of the patients. What patient can do it here? When the patient or patient's relatives, when the patients get admitted, nurses spend some time in actually sensitizing the patients how to use this. And once it's done, so what happens? Yeah. So patient can put the needs in this, whatever they need. If suppose patient need a linen, patient can please that, or patient relatives can write that needs. It gets directed to the housekeeping. If housekeeping has not answered, so what we have done is we have tagged every patient's need, and if it doesn't, and we have proper SLAs with all the team members, and if it doesn't get resolved, it gets escalated to their supervisor. And if it doesn't get resolved, the next day it comes to us. And I can tell you this system has helped us so well. It's not only for redesigning the nursing workflow or reducing the nurses' non-value or non-core activities. In fact, it has helped us in a lot of streamlining operational issues, such as, I'll give you an example, like there was always delay from the housekeeping for replenishing the linen. When we have gone into the detail, because it was always getting escalated, when we have gone in detail, it was the stock which we need to replenish, or we need to increase our stock. Or MEP, TV remote was again another issue. So when we have gone through that MEP, the spares were missing. So we were able to add the spares. So it is not only help to the nursing, but entire operational team. So you can see that request for the year, which was raised, this many calls were redirected, or the load from the nursing was taken off by this using the system. Then pillow, because a lot of patients have the issues on their pillows, so we need to when we get to know, okay, they have the issues because of the neck issues or this, and nowadays you can see it has become a common issue. So we have developed the luxury pillow menu where patient can, which is with housekeeping, so they can just ask it and we can give it to them, which can again, when they are comfortable, nurses are comfortable. Patients and attendant menu. So the success story of this was sustainability. A lot of noise pollution we were able to prevent because call lights have reduced. Operational efficiency, which I gave you example, like redesigning or having lot of operational issues we were able to resolve because of this. Job satisfaction, efficiency, and ultimately reduction in the voice of customers, where we had a call bell delay. This was almost is to range between 50 to 60 per month, had reduced to 3 to 4 per month. And this is just want to tell you that we were able to save 12 FTE per month with this solution. So thank you so much. I think I have done a justice to my presentation. And all of you can enjoy your lunch. Thanks so much. Hope I finished in time.
Thank you so much. That was absolutely brilliant and really, really informative and lovely. Thank you very much. Certificate.
It's the back of the room, you take a group photo, and then you can exit. And left. Straight on this level at the bottom is the 360 restaurant, which we'll be having lunch. And if we could please make it back to 2 o'clock to start the afternoon, because I'm sure you guys want to see as much as possible, also go home early, so we're on time. Thank you very much. Thank you so much.
Yes.
Bring it. Bring it up there.
Oh, okay, so let's move to the back. I think we're gonna go back and take a picture. Thank you so much. I think this makes you look better.
Please give me going to the back of the room, that would be absolutely lovely, thank you.
Tomorrow, but. Thank you. So,
Thank you, Banks.
Yeah. Where you at? I went down to the plant reach. I got the plant reach. Did you have? Oh, just did the thing again. I did. And I stayed. Yeah.
What happens? No, this is the.
I'm wondering sometimes if it hangs, like it just needs support, if it's
Is
just
it-
pulling.
Is it? Because we kept Bluetooth.
Maybe put it over here,
Hold on.
there, just to kind of support it a bit more. There we go. Yeah.
Well done.
You here? You know the period. Come on.
Insert gathering to start. We'll begin because we do have a lot of extras to get through. And it's my absolute pleasure to introduce our keynote speaker for the afternoon, Mr. Ahmad Ali, all the way from the UK, my second home country. So very warm welcome to you. Mr. Ali is a former government advisor for NICE. He's played a pivotal role in shaping healthcare policy and driving affordable innovations in medicine. So we are very excited to welcome him today, and his talk, Can We Afford a Cure? Paying for Innovation with New Medicine. So it's going to be very exciting, and thank you very much.
Thank you for a wonderful introduction, from the chair lady. And I think he's going to find today's presentation quite interesting, whether or not you're from a healthcare perspective or even from a patient perspective. Because a lot of my work has to do with medicines access, and we know that healthcare bills are rising, and we know that access to medicines are posing a problem not just for governments globally, but even also for patients and insurance models. There's probably not some day in the news we don't see something about some new medicine, some new innovation, and maybe what it's going to cost. So my background, I've been a pharmacist. I spent my whole life really working healthcare hospitals within the UK in the NHS. I then spent about 10 years working as a government advisor to NICE. So NICE are like a HTA appraisal for medicines, and the UK are one of the markets where we have quite strong negotiations with drug companies. So they don't really get away with a lot of high pricing. We're quite known to be aggressive, and the reason for that is a public healthcare system. So, of course, patients don't pay for anything in the UK. They don't pay for the hospital care. They don't pay for the medicines. They don't pay anything for blood tests. There's no insurance system. There's no private, really. It's just everything is free. And because everything is free, you can see the government wants to negotiate very tough because they are paying the bill for everybody. That makes sense. So before I start the tale, I'm going to pause this bit and I'm going to ask like a question, right? This is really what started my interest and my PhD now. If you purchase something, let's say like an iPhone like this, most people have, and if it's expensive, like an iPhone is, if it goes wrong, tell me, what do you want to do? If it's broken, if it doesn't work, what do you want to do? Okay, how are you going to fix it? Okay, what if it's brand new? What if it's warranty? So if you buy a brand new car and it doesn't work, what do you do? Go back to manufacturing. Either fix it or get your money back. Let's say you go to the doctor and they prescribe you medicine, it doesn't work. You get your money back? Everyone's saying no. This is my PhD.
Yeah.
This is my PhD. There are now models where drug companies are negotiating with governments and payers the model that if the drug doesn't work, they give the money back. It is in some ways mind-blowing, but in many ways quite intuitive because we do it every day. Just we've never done it with medicines. The truth is the contractual agreement with medicines is if it works, great. If it doesn't work, you're tough. You still pay. That's not really intuitive. That's just the way it's always been. Now, the caveat to this is, why on earth would a drug company take this risk share? We call it risk sharing, right? Because they are sharing some risk. It's because the drugs have become so expensive. This is what has happened. If you buy something for $1 and it breaks, khalas. If you buy something for $1 million and it doesn't work, you want the money. This is the issue. This is, if I did my PhD in one sentence, this is what it is. Global contracting on value-based procurement for medicines. I pulled this out, and it was a Gulf Business News, to show this is not just a problem facing Europe. Trump every day is talking about drug pricing and tariffs. Even in the rich market nations of GCC, we are seeing healthcare costs going up. We are seeing the cost of medicines going up. And it means there's issues for access to patients. Did anyone hear about this drug? It's not new. It's not new. $8 million for one dose, one injection vial. You administer it, you get a bill for $8 million, and you walk out. Who can afford this? Interesting question, right? So we can have a big debate. Who sets the drug price? Who negotiates? I have a question. Is that a fair price? Yes? What is a fair price? Like, what is the framework you use to assess a medicine and say, this is good value for money? Do you understand? Who asked that question? And who's going to answer it? Or does the company set the price based on profit and we have to just take it or leave it? A more depressing question is like this. Imagine you have a child with SMA in the ventilator from birth. This drug is now a cure, is available, but nobody can afford it. This is probably the most catastrophic outcome. That's what drives my PhD work day by day. How do different countries around the world pay for this medicine? How do we make it a fair price? How do we keep the world turning? We have global instability. This means many countries do not have a lot of money. There's probably at least 2 wars going on continuously. And there is a back impact on everyone, really. It is a global effect. It's not just 2 countries versus 2 countries. Every country has got some interest, right? These are the 3 drivers I've seen countries do. They try and look at cost effectiveness of a medicine. They try and look at affordability of a medicine. And they will also look at what I call uncertainty. What I mean by uncertainty, how many people will get success? How many people will get failure? When you launch a drug? Interesting question. In many markets, they are using quality of life and health economic modeling, HTA. And what this means is they can have a framework to negotiate a fair price. Doesn't always work because the drug companies want to make a big profit. Some countries are saying we can't afford it. I looked at the top 10 medicines in the world. In the world. This one launched at 1.2 million. This is to treat one patient. You understand? The next one, 1.26. This one, 2.2. 2.8. The last one that launched, this is for rare and orphan disease, $4 million to treat one person. What's that? $20 million. Yeah. I think we have an unsustainable situation. And how will this situation continue? And I asked this question, I'm doing some presentation in the US later this year. I'm asked the question, will the bubble burst? Like, what's going to happen? Because these prices are keep increasing. And this is interesting, you might see sometimes on LinkedIn, each dot is a drug that's coming to launch that costs more than $1 million in the next 5 years. So it's big business. And who's paying for the big business, right? Well, you and me paying. Our governments will be paying. The final one of uncertainty is a little bit more, you know, when you see clinical trials, what is happening now, and I think it's not a bad thing. Patients want the drugs more quickly. We know that. You know, there's regulatory, fast track, quick approval. We're trying to accelerate from the test tube to the patient. Clinical trials getting shorter and shorter. Well, this means the data is immature. And this means that no one really knows always the full safety, and no one really knows the full efficacy. Try and price the medicine in this environment is increasingly challenging. And the argument is, if you're a patient with disease, you don't want to hear that the trial will be 10 years. You want the medicine now. You don't want to wait 10 years. You don't want to wait 5 years. So to try and balance getting medicines quickly but safely is very difficult. How did I start this PhD? I have to tell you the story when I was in government. And this was how I fell in love with this contracting that I now do every day. I was in the government at the time, and there was a cancer drug, a myeloma that came, and they proposed a high price. They were very innovative, and they said, we want the first line population to treat everybody. In the government, they said no. They said your price is too high, and they said if you look for your clinical trial, the patient population was somewhat heterogeneous. There was some first line, there was some second line, there was some salvage. They said it's a very mixed population. We cannot draw conclusion on the first line data. It's not powered to show us. So we had this negotiation, but there was a stalemate. Do you understand? Both sides could not get agreement. Well, in a stalemate, who is suffering is the patient. Because the government cannot agree, the drug company cannot agree, but there are patients dying every day saying, I can just see the medicine just here. I can't reach. Why don't you just pay for it? Why don't you just pay? Like, what is the price of a human life? How can you say I'm not worth it? So it's a pressure from the public on the government to pay whatever the price. You understand? Because it's emotive, right? It's not about the government is trying to fund the population, but individuals want to treat their loved one. That's what it is. My career, the company said, do you know the saying? Is there a saying in GCC, have your cake and eat it? very much. And then some. Thank you, Jim. Oh, yes, of course. Thank you. Thank you very much. Thank you, session.
So next we've got Ms. Mariam Omidi from Iran. Very excited to see her today. Dr. Mariam has a laser fellowship in dentistry. She brings expertise in the management of the TMJ, temporomandibular disorders, and the integration of digital dentistry. Very exciting field. She's going to present today on the topic management of temporomandibular joints using laser therapy and digital dentistry. Please join me in welcoming Dr. Williams.
Good afternoon, everyone. We are going to discuss about TM joint. You all know what is TM joint, a bilateral cartilage which has a thick tissue around it, and it is connecting the mandible to the skull. I'm showing, you all know, but I'm showing to you the movement. And here, TM joint and the lateral cartilage is damaged. What are TMD problems? They cause jaw pain, joint sounds, muscle stiffness, and headaches. What are the symptoms? Patient is tender and the stiffness or locking the jaw, they cannot open their jaw, they cannot close it. And we can hear clicking or popping sound at the TMJ when we are examining, and it can cause malocclusion too. What causes this disease? Some birth diseases, right, like rheumatoid arthritis, and clenching and bruxisms, and problem related to jaw structures from birth. The erosion of the condyle happens in these situations, and the misalignment of the discs causes pain. In these videos, I'm showing you how to check your patients. First, sounds in maximum opening and closing the mouth, and we are checking the lateral pterygoid. You put your finger in the depths are your second molar vestibule, and you put the patient has pain and tender, the lateral pterygoid is damaged. The gold standard for recognizing this disease is MRI and CBCTs, but MRIs are more gold standards. And in MRIs, we shouldn't see the head of the condyle erosion. We should see it all round and intact. What are the treatments and non-surgical treatments which we can give the patients to do at home? Rest the jaw, avoid chewing hard things and gums, and have a warm compress, and getting some anti-inflammatory, giving some anti-inflammatory and pain-relieving medicines like naproxen and ibuprofen to the patient. And for sure, sending the patient to a psychological, for psychological treatment, because most of the clenching and bruxisms are caused by mental problems and psychological problems. Other TMD treatments, other ways, you can use tense electricity, you can use laser therapy, which I'm going to discuss about, and ultrasound therapy and jaw exercises. And we can have dental treatments too. If we have malocclusion and it is mild and misalignment is mild, we can have orthodontic treatments. In difficult cases, we can give the patient night guards or a splint bites. What's the difference between a splint bite and a night guard? The night guard has cusps, but the splint bite has a flat surface. And we are using the split bites for rehabilitation and adjusting the jaw or increasing the VD of the patients. In advanced treatment, when the TM joint is in severe situation, we can use Botox to release the muscles around, and we can inject corticosteroid to the condyle. And in rare cases, we go to jaw surgeries. Laser treatment. What is a laser? It is a light. And what is low-level laser? Every laser, we can turn the power below 500 milliwatts. We can call this laser low-level laser. And what low-level lasers do? They affect the cells, just the damaged cells, not the intact cells. And it increases the oxygen and the cell regeneration. Medium level laser therapy is the power is around 500 milliwatts to 2 watts, and the effect is a little thermal effect. And we use medium laser therapies for deep pain in muscles, like rheumatoid arthritis, tendonitis. And high intensity laser therapy, it is for other medical uses. In this scale, you can see from 600 to 800, the wavelength, it is for low-level laser therapy, and 800 to 1000 or 1020, it is medium-level laser therapy. The therapeutic effects of the laser. It increases the blood circulation, and it has anti-inflammatory effect. Analgesic effect, immediately the patient feels relief. And muscle relaxation. Which muscles would be damaged in TM joint diseases? Masseters, temporals, lateral pterygoid, medial pterygoid. Yeah, anyone knows how we can check the medial pterygoid? It's lateral pterygoid. The medial pterygoid, where we are injecting, and we are injecting the anesthesia. The suggestion protocol for us is 635 nanometers wavelength, and we use it for 6 to 9 seconds, and we radiate the area points, and we don't move our hands. In 980 nanometer wavelengths, which is the medium level laser therapies, we should sweep our hands. I will show you the video in the next slide. And 1 or 2 millimeters spacing, we should sweep our hands, and we shouldn't point in some specific area. We should move. And number of the sessions, 6 to 10 is enough. If the patient is really tender, you can do it every day. And it is not invasive and painless, and adjusting for a medium level, the blue points laser therapy, which are muscles. You can take a picture from this slide. It's really important. In this case, I'm trying to get my patient from the severe to mild pain, and after that, curing. We can give, I told you, we can give patients vital splints and night guards. And I told you that vital splints has a flat surface. This flat surface, we should scan the patient with digital scanner. Full arcs and all the movements of the jaw, we can record it. And after that, we have to get the patient to CR, centric relation. We use leaf gauges. It's the best way for digital. The point that first posterior teeth contact each other is the CR for us. After that, we adjust the way we like. Want to have rehabilitation, we have to have a thickness for increasing the VD. We give it to patients, give it to patients for about 3 months. And this is the material we use is resins, and the best is Keystone because it is soft in body temperature and it is clear. The chair side of these patients is really hard because you shouldn't have any interferences in non-working side. I'm using different colors as my patient chew and move the mandible to the right and left. We all check all the movements, and in the non-working, we shouldn't have any lines when we use these troll foils. So, after we gave the bite splint to the patient for 3 months, we call the patient, and if the pain all released, we can use some temporary fillings like or crowns to the patient for increasing the VD. Finished. Any question?
Thank you so much, Dr. Mariam. That's brilliant. Any questions for Dr. Mariam? That very interesting lecture on human laser therapy. Anybody doing laser therapy? I think you're very advanced and innovative using that, so absolutely fantastic. Thank you so much for checking for us.
You're in the right position. Oh.
Our next speaker is Ms. Samira Abbas. English as well.
I'll introduce you.
Ms. Samira Abbas from the UK is an independent registered clinical hygienist, very important our hygienist. She's dedicated her career to highlighting an essential
Do you know? Really?
Yeah, I'm really looking forward to hear your next. She'll speak on the hidden power of hygiene equipment. Where do they have some hidden power? So, please put your hands together. Most
Or do I just click here? Okay, I could just do that. How do I go back? Hi guys.
guys. Can you hear me? Yeah, okay. So the power of a hygienist visit is far more than you think. I began my journey as a dental hygienist 15 years ago, working in East London, one of the UK's most deprived communities within the public health system. Back then, many of the patients came from backgrounds where oral health wasn't a priority. Fast forward today, I now work in some of the world's most exclusive clinics, Harley Street, Harrods, Rue Dental, and Najati Clinic. My patients include international clients, celebrities, Premier League footballers, and even royalty flying in just for their cleans. So you might expect me to stand here and talk about teeth, but I'm not. Because most people think hygiene appointment is just a quick clean, bit of scraping, bit of polishing, and you're done. But what if I told you it was far more than that? A hygiene visit is the most important touch points in healthcare, is where trust is built and where life-changing conversations happen, where patients begin their journey and can transform not just their smile, but their overall well-being. And it doesn't stop there. For practices, hygiene appointments are one of the most strongest drivers of growth. They build loyalty, increase treatment acceptance, and boost referrals. So when we talk about the power of hygiene, it works in two ways. It elevates patients' health and fuels the practice growth. And that's exactly what I'll be talking to you through this in two parts. The impact of patient well-being, and the second is the practice growth, because the true power of hygiene visit transforms both. So the traditional view is hygiene has been seen as an extra nice add-on dentistry, something to support the real work of the dentist. The problem with the old view, it reduces hygiene to a task: clean teeth, remove plaque, and send them off. This thinking is outdated. It limits both patients' practices from realizing the true value of hygiene. The new reality is quite different. Hygiene visits are not just supplementary, they're integral, they're a gateway that connects patients to the full spectrum of dentistry. Why? Because hygienists are clinicians, patients that see them most often. We spend time with them, we listen, we explain, we build that rapport. And that trust allows patients to say yes to prevention, yes to treatment, yes to investing in their health. So while the old view reduces hygiene to a chore, the reality is that one of the most powerful drives of patient well-being and practice growth. The new reality is that the hygiene visit is one of the most powerful opportunities in dentistry. Think about obstacles that stop patients from saying yes to treatment. Fear, lack of trust, lack of knowledge. Now look what happens when you see a hygiene appointment. It's cheaper, it's less intimidating, and it's quicker with no big commitments. And in that safe space, patients start to relax. Their barriers fall, they share their concerns, they open up their insecurities. We have time to listen, to explain, build that rapport. And once the trust is there, everything changes. That's when opportunities appear: whitening, restorative, orthodontic treatments. Hygiene is the bridge between fear and trust, between uncertainty, commitment, between one-off visits and lifelong relationship with the practice. So what happens in that chair? Bear with me. Ask most people, they say the hygiene visit is scraping, polishing, and maybe a lecture about flossing, and then you leave. But it's so much more. In that 30 to 40 minutes, a hygiene visit becomes about reassurance. Patients often arrive nervous, unsure, and even embarrassed. My job is to put them at ease, then is about listening to them. I don't just look at their teeth, but I listen to their story, their habits, their goals. Next comes education, gently, simply, without jargon. For many, it's the first time they really understand what's happening in their own mouths. And that builds trust. Once the trust is there, it opens up opportunities. So 2 goals, 1 appointment. So as I said before, the patient well-being and practice growth. So one of the ways I bring patients to the practice is by encouraging them to post things on Instagram for me. So if they've had a good experience, they'll maybe mention something, or they'll like write a little Google review. And that's what brings the patients to the practice, because that little review that they put up has a ripple effect to basically encouraging their friends and family for recommendations. So case study that I had, I saw a patient. She once came in for what she thought was a routine hygiene visit. During that appointment, I noticed a lesion that didn't look right. I referred her immediately. It turned out to be cancer, unfortunately. She went through treatment, she survived, and she was ready to come back to me. Because I was the one who first seen it, I was the one who she trusted. But survival left scars. The treatment had damaged her mouth functionally, aesthetically, and emotionally. She wasn't just struggling with eating or speaking, she was struggling with confidence and her identity. That's when my role shifted and I became her guide. I mapped out pathways, referrals to the restorative dentist, aesthetic care restored her smile, and ongoing hygiene support so she felt safe and in control. And here's why she followed that pathway. It's because my advice was impartial. I wasn't selling her treatment. I wasn't pushing procedure. She knew my role was to protect her health, point her in the right direction. And that impartial gave her complete confidence to say yes. So for her, it wasn't just about teeth. It was about regaining dignity, confidence after her cancer. For that practice, the impact was also clear. That 100-pound hygiene visit grew into a 12,000 pounds treatment, plus loyalty, multiple referrals. Yes, there is a financial value, but the real value was priceless, which is her life, her trust, and her confidence. That's why the hidden power of hygiene is impartial advice that builds trust, creates pathways, and transforms both patient and practice. Thank you. Any questions?
Well, thank you. That was absolutely brilliant. Yeah, the hygienist has always been very much the center of my practice and our clinic also. And hygiene play an absolute pivotal role. Actually, I think the American model is very much based on hygiene, so it's something I think we should definitely adopt, and it's really, really helpful. Any questions? Thank you very much. Good afternoon. Next up, we have Mrs. Frelaine Marie Elise Ibanez from the United Arab Emirates. Ms. Frelaine is a clinical resource nurse and nurse educator at NMC Provita. She's committed to empowering future nursing leaders through education and innovation. Today, she's going to present on empowering the future, advancing nursing workforce excellence through nursing education. Please put your hands together, Ms. Frelaine.
Good afternoon, everyone. I know it's a holy hour right now, but I'm gonna make sure it'll be short and sweet. Yeah. So, good afternoon again. My name is Frelaine Marie Elisa Banez. I'm a clinical resource nurse or a nurse educator in NMC Provita International Medical Center. So I do hope that you know NMC Healthcare. So we are from there. We are a long-term care facility from NMC. So I'm going to present now Empowering the Future, Advancing Nursing Workforce Excellence through our nursing education. So here my goals today, or my objectives today, is for you to recognize the importance of nursing education in the advancing workforce excellence and our patient-centered care. I'm going to describe our vision and commitment in NMC Provita International Medical Center, fostering our continuous nursing education. We're going to identify our different educational programs in NMC Provita International Medical Center, together with the certifications and other professional developments that we have. We're going to explore the innovative learning strategies that we have, including our simulation-based training, our mentorship programs, and e-learning platforms. I'm going also to present or analyze one of the success stories that we have being in the nursing education. And I'm going to discuss what our future directions for advancing nursing workforce in our facility. So first things first, why nursing education matters? Anyone wants to share? Why do you think nursing education matters? I know some nurses here. I have seen there are nursing directors here a while ago. So anyone you want to share? Why is it nursing education matters? Why is it not medical? Because I'm a nurse?
Treating the human response.
Yeah, I do agree. I do agree. Yeah, we treat in the human response. We deal with lives. Okay, we ensure that our staff in the nursing have a safe and high quality and evidence-based practice. Take note of that. It should be evidence-based practice. Not only that we have this one in our home country, not because we have this one in our practice. No, it should be evidence-based practice. Agree? Yeah. So we equip the nurses with critical thinking and clinical decision-making skills. Why? Because again, we are dealing with lives. We are not just simply deciding for our patients just because we want to, right? That's why it should be evidence-based practice. We promote continuous professional growth. Okay, we do not just stay at the bedside taking care of the patients. We should be promoting and encouraging and innovating ourselves when it comes to our profession. That's how nurses are. That's how nurse educators empower the nurses. Yeah, we enhance adaptability to our new healthcare. We have a lot of innovations. We have AIs right now. We have a lot of technologies. So we as a nurse educators, we need to empower them. That's why nursing education matters. And we build a culture of excellence, compassion, and lifelong learning. That's how we perceive in NMC Provita nursing education. So going back, so I just have separated going back 50 years ago and up to present, how our nursing education right now. So number one, the teaching methods. Way before, 50 years ago, it's more on lectures. Yeah, we go deal with the patients and go with the bedside with the lectures, right? We do memorize. I remember before my clinical instructor, we need to memorize everything first before we're going to deal with the patient. At the present, it's a blended learning already. We have simulation labs, we have e-learning platforms, we have virtual learning platforms, and we have interactive case studies right now, which we have in our research-based studies. And we have a greater focus on interdisciplinary or multidisciplinary education. Specifically what? Not only for specific for the nurses, we collaborate with each and every multidisciplinary team just to make sure that we are giving a proper care to the patient. That's the present. For the technology-wise, way back 50 years ago, what do we have? We only have books, chalkboards, although the books are evidence-based practice or evidence-based references, and also direct patient care. Right now, we have a lot of simulation mannequins already. We have simulation labs. We have a lot of journals. We have a lot of online platforms. Okay, already have a lot of references online that we can have or accessible for all the trainings that we have. In the clinical training, usually 50 years ago, we directly go to the hospitals, okay? We often been unpaid. Way back, I remembered we have what we call in our home country, a volunteer nurse, which we volunteer. We take care of the patients, we don't get any pay, but we still give our care. That's how, because we need to have an experience, that's how we can get our experience before. But on the present, it's more structured. Right? In the clinical setup right now, we have what we call affiliations already. Okay, just to make sure that those nurses will be fully equipped by not being what we call exploited. That's the best word that we have right now. For the professional role, way before, let's admit it, we are being the assistant of a physician. Assistant of the physician. We don't have the autonomy to decide for our patient, right? Though we have our nursing intervention, why not, right? So we have a few opportunities as well for leadership because again, we are being labeled as only physician's assistant, right? But what are we now in the present? There's a lot of nursing professionals that right now who are independently being recognized. Why? Because now we know how to empower ourselves. We know we speak up. We speak up or we advocate for our patients. Why? Because one of the reasons is that because we have a proper nursing education right now. Agree? Nurses? Yes. We also have a lot of opportunities for specialization. We have already a wound care nurse right now. We have a nurse practitioners right now. We have nurse informatics right now. So we have a lot of specializations. That's how we empowered ourselves. And lastly, we have expanded our scope. As I have mentioned, we have a lot of specialists right now. And one of those is me, one of the nurse educators. So that's how we empower ourselves in our professional role. The next slide that I will show to you is what is our vision in NMC Provita when it comes to nursing education? So our mission is to deliver a highest quality of education and training by aligning in the international guidelines or standards. So we want to align it in international, in evidence-based reference. Our vision is to be one, this is only our vision. There's no any harm to visualize this, to be one of the leading provider of clinical education in the Middle East. And lastly, our strategies is to produce a proficient onto expert workforce that will function according to the evidence-based practice with the values that we have, being resilient, having the integrity, having the passion, and being excellent in the healthcare facility. By continuing it, these are the nursing education programs that we have. In the picture itself, it will speak all that we have, but I have to go it one by one. We have facility orientation program. So once the new joiner comes along with us, we will be having the induction process. We have to introduce our facility by orienting them, just to make sure that they feel welcome to our facility. And then next, we will welcome them according to their department. So if it's a nursing department, they will have a nursing department orientation, which is a supernumerary or shadowing program. What do I mean by that? There's one preceptor or two preceptors maximum who will be accompanying the new joiner during their transition process, just to make sure that those practices that we have in Provita will be absorbed by the new staff. Because let's agree by this. In each and every facility, there's a specific policy and standards that we have. So we need to make sure that they will follow what we have, just to make sure that we are delivering safe patient care. Next is we also conduct annual training needs analysis. This is an assessment of what training do they have or do they need. Okay, so yearly we are making sure we empower our nurses. And they speak up what do they by how? By sending them a survey. A survey that they will tell us, hey, I need this training, even because I think I need more to be fully equipped with this kind of training. So that's how we empower them as well. Apart from that, we will create a structured education plan just to make sure that on this year, nurses will see this is our plan for you. We are here to make sure that your education in nursing is fully structured and equipped. So we have FastFacts, which is evidence-based references. We have PINKS program. PINKS program is proficiency in nursing knowledge and skills. So I have mentioned that the new staff is being supervised by a preceptor. So a preceptor should undergo our proficiency in nursing knowledge and skills. We need to teach them how to coach, how to precept the new staff. So whatever the nurse educators is teaching, they will be aligned to what we are teaching as well to the new joiners. Because we believe that equipping them with this knowledge and skills will be boosting the self-confidence to perceive a new joiner. Next one is our learning methods and platforms. In our facility, we are offering an in-house CME accredited workshop. So one example is ventilator workshop, wound workshop, essentials of rehabilitation workshop, and we have future workshops for hemodialysis and stroke rehab workshop. Our facility has also competency-based training. When you say competency-based training, it's knowledge, skills, and attitude. And we have bedside conferences that we have. This one is to assess the staff bed at the bedside. We nurse educators, we go to the bedside, we assess them, and we let them know that we support you in the bedside by coaching as well them. We have of course, we are also empowering them to have a link groups, okay? So education and research link groups. Our technology integration, we are using Elsevier, Oracle, UpToDate, and EC Generator for evidence-based learning. Right now, we are also admitting newly graduate nurse, especially Emirati newly graduate nurse. So our NMC Healthcare have created a transition into practice program scheme. So on this one, the newly graduate nurse will undergo a 6 months program just to make sure that their transition will be smooth, because we know that they have a limited experiences. They're only newly graduate nurse. Apart from that, our professional development, we have the CLAPS program. Right now, we are ongoing for ANCC Pathway to Excellence accreditation. So we created this CLAPS program for succession planning. I will just show to you what is this. CLAPS program is to make sure those nurses who wants to have a position, for example, she wants to be a wound care nurse, she wants to be a nurse educator, they will undergo on this program. That's why we call it CLAPS, because we will clap for them after the graduation. Yeah? And because I know that I don't have any time yet, this is the last slide. I'll just showcase to you one success story. My education manager. My education manager is one of the success story being a nurse educator. This is his journey. He started in NMC Provita during the time it was a pioneer facility. So way back 2011 until now he is here. So the transition, it's one of example of a succession plan. He undergone a succession planning until he was right now an education manager. That's it. I think I don't have any time. Yeah. Thank you so much.
Thank you. You talk so passionately. I think you must be an amazing lead and trainer. Thank you so much. NMC Provita, very lucky to have you. And I think we can say we all enjoyed it. It's wonderful to have people in the industry who are educating and leading and inspiring and training people. It's absolutely wonderful. Thank you so much. Any questions at all? Also, NMC Provita, we have Mrs. Daniel Sukumara, who is also from Iranian, and as a nurse educator, Ms. Daniel is a wound care nurse at NMC Provita. She specializes in enhancing tissue viability and outcomes, both geriatric and pediatric patients in the long term. Her topic today is optimizing tissue viability in long-term care settings. NMC Provita's strategies for effective NASD management in geriatric and pediatric patients. Please welcome
With this, get this one off, and this one, and this one.
Good afternoon, all.
It's a great pleasure that and humility. It's a great pleasure and humility that I stand before you today to present my MSD poster. I am truly grateful for this opportunity to share my findings with you all. I am myself Dalu. I'm working as a wound care nurse specialist in NMC Provita, Abu Dhabi. So we have done a quality improvement project in our facility, optimizing tissue viability in long-term care settings, strategies for effective MASD management, and in geriatric and pediatric patients. Sorry. It's not moving. So background of our project, moisture association. Sorry for this. Sorry, let me bring. Moisture-associated skin damage is characterized by skin inflammation with or without erosion due to prolonged exposure to moisture sources such as urine, stool, perspiration, or wound exudate or mucus. This condition is a significant care settings. Give it a try. Let's try now. Which button am I pressing? This one, right? Yes. Moisture-associated skin damage is a significant challenge in long-term care facilities, particularly among old age people and pediatric patients with fragile skin integrity. We have done a prevalence study before starting our project. State literature review highlights that the prevalence of MASD with studies reporting a 5.4% incidence in 448 nursing homes across 28 US states and a 45.7% of prevalence of incontinence-associated dermatitis in individuals with incontinence. Case studies say that 1,140 cases are present in our 2,492 patients. Problem statement of our project. The raising of cases of moisture-associated skin damage and frequent misdiagnosis in our facility, raising a case incidence of reached 3.008 in Q4 2023, prompted NMC Provita to initiate a targeted quality improvement project focus PDCA framework, strengthen and identification, prevention and management practice. As we show the graph, we are done a study of quarter-wise cases, number of cases reported in our facility and ratio of cases. As you can see in the graph, the fourth quarter we have a huge number of cases reported in our facility. That is make us to think about a quality improvement project initiation. The objectives of our study is to reduce incidence of moisture-associated skin damage, enhance patient outcome, achieve a 25% of case reduction at the end of December 2025, and we expect a target rate of 1.62, and standardized documentation and reporting ensure timely use of protective products. Methodology we use applied focus PDCA model. Find the cause by identifying I and ASD cases in Q4 2023 and organize by form a multidisciplinarity, clarify the issue by mark current practices and product use, understand the cause by analyze use of variations, select standardized protocol, and PDCA cycle used for planning, implementation, and evaluation.
We done the project by act, plan, do, check cycle. We created a team, organized a team and stakeholders containing a project leader, wound care nurse, and the facilitator is our nurse director. Team members including wound link members. We have a wound care link team in our facility. We are managing our all other patients or the preventive measures, education through our clinic nurses. They will not work as a first direct responsible person when the patients or other patients develop any other skin integrity problem. They will be the first direct contact person. And the other team members are quality department, physician and dietitian, education team, and nurse team, procurement team. The current practice consisted of documentation not standardized, escalation to the wound nurses is not consistent, product selection varies and lack of availability, various products used inconsistently, and limited staff training on MASD prevention measures. So we have done a root cause analysis, a multidisciplinary team including wound care specialist, wound care nurse, and conducted a fishbone analysis to identify the contributing cause of moisture-associated dermatitis. And we done the analysis material and product, environmental factors, education factors, and manpower factors, residents or patient-related factors, and we concluded the main factors like staff factors, limited knowledge, inconsistent assessment, and process factor related to no standardized protocol. We don't have that during the project initiation time. Product factors like limited protective barrier availability, patient factors like incontinence and immobility and other comorbidities are the leading factors which is leading to the increased number of MASD cases in our facility. So intervention and action plan, we have done a education need analysis in our facility, total of 123 staff participated in that, and we have a result of 86.2% staff identified need for MASD education. And staff training on MASD recognition and use of Globite tool, we adapted a international classification tool which says Globite tool for moisture-associated dermatitis and introduced standardized MASD prevention protocol. Protective barriers and creams are introduced for the high-risk patients. We have updated our wound notification template and reviewed our cross audit tool. And we prepared a fast-track preparation for MASD identification and classification to improve the knowledge of the staff. And this implementation process do phase, we have started with our education and training with multiple variants, and these are the groups we are doing it. We have done the competency assessment checklist for the staff. The second one, villa meeting and training, because we are working as a villa setting, not a good hospital setting. We are providing the care for the patient like home environment. So we are set up is like a villa. We are conducting every month villa meeting. So we train the staff in the villa meeting with small training session and demonstration session. And other one, we have a CME accredited workshop for UK. It's conducting every month. And this other picture is IMWCC, International Wound Care Conference. We submitted and presented our poster, and we recognized our poster presentation in the Wound Care Conference in Mumbai, which conducted in March 2025. Our team represented the poster there. And product training, we have done product training in facility by the vendors. They will come and train the staff with how to use the product, effective use of product, and our wound care link team members will do the small sessions in our wound villa to continue the effectiveness of product and actual use of product to ensure. And we have done the posters in our JCI presentations and staff training. We have continued the training with a small session with a huddle time with our booking team to ensure the continuity.
And last year, we have done a respiratory prevention day program to enhance the preventive measures to continue and escalate the awareness of the preventive measures and importance of preventive measures to the older facility. And we encourage all the team, and we have successfully done a preventive measure program. And implementation two phase, we have done the room passport. This is a model of the room passport we prepared, and we assigned this in the LMS learning system for the education with the questionnaire. And all staff will go through the questionnaire and education topic, and we can track the education record by the LMS training session. And we have done many product evaluation in our facility. We have do the product evaluation. We have a product evaluation committee in our facility. So we will go through the product evaluation committee approval. After approval, only we are implementing the product in our facility. And we have implemented all the product. Like first photo is having barrier cream, this clear diabetic bone content barrier cream, and filling, Cavalon filling we have. And this other typo second option is zinc barrier cream. We have implemented that one after product evaluation. The third one is cleaning foam, which is water-based, waterless white foam. We can apply over the stool or vertical panel and just wipe it off, which will maintain the pH of the skin. So moisture associated skin damage is mostly will affect the skin pH. If the pH is alkaline, it will damage more. So we avoid maximum less use of soap and water, and we maintain the use of pH balanced cleanser foam, which will help the staff to reduce the time saving and easy to use. And other thing, we updated our non-adherent foams. We updated with all silicone material, which is very skin friendly and easy to handle. And our population is age and pediatric patients, so very fragile skin and difficult to manage. The anatomy of the skin is very to age and comorbidity. So we using every product with very skin friendly and pH based. So these are the products we implemented after the product project. So standardization of the documentation and process, we started using a global tool, which is international tool we adapted, and we circulated flashcards for preventive measures of skin integrity maintenance. And we have done a form, which is all NMC is using a standardized product evaluation form. We done the product evaluation through the facility-wise the government and approval of product evaluation committee. After that, we implemented. So the result, the initiative lead to significant reduction of MISC incidence rate decreasing from 3.08 in quarter 2023 to 0.77 in 2024, with the case dropping from 98 to 30 cases annually. Additional improvement include faster healing of MASD in 1 to 3 weeks and early notification of MASD cases and reduce infection and improve patient outcome. As I show in the graph, which is showing annual rate of last 2023, we have 2.9 cases and we kept the target of 1.62, which is 25% reduced, and we achieved a score of 0.77 by end of 2024 December. And we have conducted many staff education, and the high staff participation, we have achieved 93% staff education by end of 2024 December. And we started a monitoring of preventive monitoring for complaints of preventive measures, and we have achieved 92% of complaints of preventive measures. And this is a case study of 70-year female patient with multiple comorbidities and developed moisture-associated skin damage. It shows that it's like fungal infection. And we treated her with a fungal cream and topical barrier cream. Within 2 weeks, she completely healed, and till now, she is not developed any further recurrence of the MASD. We are continuing with the barrier cream. We stopped the medication after we resolved the problem, but we continue the barrier cream and nursing quality of care maintained. And this photo is taken by photographer. In conclusion, this project highlights the importance of systematic evidence-based approach in managing moisture-associated skin damage, particularly incontinence-associated dermatitis in both geriatric and pediatric patients. Through a structured education prevention strategies and focused PDCA quality improvement framework, we successfully achieved enhanced clinical care standards, empower early identification and then the identification and differentiation of the NPSD, achieve better patient outcome in long-term care settings. So next step of our project, we have achieved our target level. We will still expand our protective product uses, and we have implemented all the patients which is identified risk for developing pressure injury according to the Braden scale. We will start implementing all the barrier cream to initiate and preventive as a preventive measures and conduct a quarterly audits. We will continue the audits and integrate MASD prevention protocol in our policy. Thank you for having me here. This is a reference we are used. And this is our very successful story. And we have achieved a very good improvement in our long-term care visits, which is very difficult to maintain with long-term care patients. Thank you.
Much, Mrs. Bello, that's absolutely fantastic. Wonderful to have amazing members of the team like yourself, a wound nurse, to help prevent reinfection and great wound healing and reduce scar tissue. Absolutely fantastic. Thank you for that. And do we have any questions, please, from Ms. Bello? No? If there won't be any questions, we're going to take a short coffee break, 10 minutes. So if we can all be back for 4 p.m. And please make sure you are bang on time because you won't want to miss Miss Sharanda talk this afternoon. We're really looking forward to that. So we'll take a short 10-minute break for a quick coffee, and I'll see you back here at 4 p.m. Thank you very much.
I am the espresso. I'm really gonna try.
Yes, so I will finish my cancel. For the short thing. Yeah. Did you get married in there? What about you? And so we probably have everyone, you just put me close to that. And it's not speaking too much. Just before I came, yeah, so I can make sure that my dog, I was like, okay, we'll just get on the second place here. And then, I'm gonna go to class. Yeah, I think I really want to, and we do. Why we said. It's how which is how I can. Yeah. No, it is not. Which kind of. Yeah. And for. Don't use it. Let's see. You're just saying for your mom to be a problem this year. Congratulations. Here. Look back my name, it's all lady. I found track on your. She. Yeah. That's what Rachel. Sorry. Oh, but now he won't. You can change it. Yeah, but it's so hard. Which one was that? But that. Vacation. Maybe with that. So I never seen it, but we have to try to go to. Anyway. No, I can't.
I was really like my people in that. And then I have again, it's like, I'm sure I'm pretty there from because you meant that you have that. I have money. How many interests? Yeah. I don't, and hygiene. You don't believe in them. No, it's okay. Maybe. This is the person. I think the parents made it up. Yeah. Yeah, but now I can't. I call her because she can't. But I can have her act. Yeah. Laura, you married it. And I Jordan, I made my husband. Yeah. Oh. She said, she's so. Oh, yeah. I was not. She said, they start so yeah. Oh, yeah, we have like we will do that. You have to have that just. And then new project clients. Sure. Please, yeah, because it's because we should talk standards. Yeah. Let's take a look. Action. How about okay? There's one thing is my French in prior to yeah. And it was made by something practice, but has to be. Have another place, yes. Yes, it's terrible. So like that. How much is first again? Say in the yeah. Carry out to what? I'm actually not going to speak that. So the invasion, not the new stuff. It's not that feeling. It is. Yeah. لا على فكرة أربعة اللي هو foundation yeah. With three stuff, two nurses in our section. 1 year anniversary. We celebrate this anniversary. 2 years we celebrate. I know I said great. So much more that. I'm born I didn't worry about she's no one has to do right if people are children. Checker. Yeah. No, I. I'm staying. Oh, there's a class. But it's not as I told you, son. Okay, it's okay. I can't have to. I don't know. Doesn't need to affect me. the UK, for both sides. And here in regards to making
Let's get it up.
Yeah. Because
Right, ladies and gentlemen, our next keynote speaker, very proud to present keynote speaker, Mrs. Sharonda Brown-Spence. I hope I can do her justice in matching her wonderful energy as the operator. Sharonda is from the United States. She is CEO and executive nurse leader. Her groundbreaking framework has transformed emergency department outcomes by reshaping people, processes, and communication. She will deliver her speech on the culture renovation framework, transforming emergency department outcomes through people, processes, and communication. Please give a warm welcome to Ms. Sharonda.
Come on, y'all can do better than that. It's not enough left in the room. Now, thank you guys for allowing me to moderate earlier. Thank you for allowing me to pour my energy all on you, right? But now it's time for me to talk about who I am and my company, and then what we do over in the United States. I'm excited because we rebranded. We are X-Consultants. And now what I want you guys to do for me today is to solve for X. And that's what we'll do together. Like solve for X. That's what I said. All right. The culture renovation project. That's what this is. Someone said to me earlier, I think it was Dr. Omar said to me earlier, what will culture do to strategy? What will culture do for strategy? It will eat it for breakfast. Per, what's his name? Peter Drucker. I've listened to you guys all day. You got the stuff, right? You got all the things. I've seen it. But if your team and your culture is not right, then they will eat your strategy, all that research, all that work for breakfast. Peter Drucker. I can't take that credit. Transforming emergency department outcomes through people, processes, and communication. I like to substitute communication for paperwork. I always talk about pivotal P's. I call them the pivotal P's, the people, the processes, and the paperwork. But I transformed that to communication because we all know that documentation is communication. And in our world, just like in real estate, it's location, 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 right? You understand what I mean by that? When you're buying property, location is everything. In our business, in everything that we do, especially with us coming from different backgrounds, different walks of life, different communication techniques and styles, learning different things differently, right? We all have to be on the same page. But how do we do that? It's my experience that in emergency departments, when I go in, the number one reason for breakdown in anything was a communication failure. What we had was a failure to communicate. Code blue, ER waiting room, code blue, ER waiting room. Does everybody know what code blue means? Code blue, does that mean the same in your country? I'm not sure on that. It's universal everywhere? I did find some hospital that I worked with and they called it Dr. 99. And they named it after a doctor. And I talked to them about it. But here's why I'm here. Because we had a code blue situation. My personal story, my why. Pardon my passion. My passion is in the emergency department. My mom has a twin sister who was in the emergency department. They did an EKG on her and they placed her back out in the lobby. About an hour and 20 minutes later, she coded. Code blue in the ER, my mom's twin sister. So please pardon my passion, because ever since then, I've been working with the emergency departments all over the United States to make sure that we get this right. With that being said, I have tons of shared practices. There's no reason that no one should be recreating the wheel. If you're starting from scratch at this point in healthcare, we got a problem, right? There are shared practices and we need to adopt. Some people might call it stealing. So she arrived with chest pain, shortness of breath, and coded in a lie. Emergency departments nationwide are just overcrowded, right? And it's just causing bad outcomes. And so metrics matter. When running emergency departments, when I go into the organization, first of all, when they call me, they're in trouble. I wish they would call me before they got in trouble, but I have to call and get everybody out the hot water. But it's metrics that I want when I arrive. We'll talk more about metrics in a minute, but what am I looking for? My focus is door to doctor. How long does it, when people come to the hospital, most of the time when people come to the ER, they're coming to see a doctor. They're not coming to get a bed. They're coming to get a doctor. Some of them want a bed. Everybody doesn't have a home. That's fair. Okay. But for the most part, they need to see a doctor. And we need to determine if they're sick or not, or if you're sick or dying, right? Which way are you going? Do you need to see a mid-level provider or do you really need to see the doctor? Does that make sense, y'all? Because that's how we separate our patients in the ER. Do you guys have mid-level providers in your emergency department, nurse practitioners? And when I say mid-levels, I'm talking nurse practitioners and what's the PAs, physician assistants. And those people help with the lower acuity patients. Those lower acuity patients don't need a bed. A lot of hospitals believe that every patient need a bed. That's a problem, causes a bottleneck and delay in care, delay treatment, bad outcomes. So from arrival to medical screening exam is what we're looking at. National average, 30 minutes. I put 20 up there because I'm trying to force it. We do have some people that have about 20 minutes doctor times, but you better believe they have the doctor up in triage. And that's called provider is triage. Some people adopt that process, some people don't. And I can talk to you about why later, not today. The goal here though is times when you go to the ER, you want to be seen. I had tooth pain. I wanted to be seen, right? They put me in the lobby longer. My ESI acuity or what my acuity level, they made me a 5, like I wasn't in the right place, right? That was horrible. So thank you again to the dentistry people. I appreciate all you do. But we want me in front of the patient in 20 minutes. Why does metrics matter? Because time is muscle, time is tissue, time is brain, right? Time is everything, right? A lot of people don't, my nurses will get upset about time. Oh my God, you're just trying to meet these times. Time is quality in the emergency department. For every hour we delay for treating septic patients, we're increasing their mortality rate by 10%. That's insane. You better move fast. Pardon my passion. You with me? Time is of the essence in the emergency department because it delays and impact lives, right? So time is everything. So don't let people tell you time is not. Now, when you're in a different environment, I see you and you have that time, critical care department, then you definitely do that, right? Okay. This does not mean take away from the care that you're providing to your patient or that you're providing less care. What it means is that you're addressing things like strokes, heart attacks, strokes, heart attacks, sepsis, those things that are time sensitive, that if we delay y'all, we're gonna have some bad outcomes. So why does metrics matter? I heard most of you talk about your metrics. My question is, did you validate it? Where did the numbers come from? Who's the auditor? Did you audit the auditor? What about the input? Garbage in, garbage out. So you got to look at the input. What did they really put in? Does that make sense? I want to tell you something. So I told you they only call me when things are almost over. And so they called me and the nurses getting ready to go on strike. Do they strike? Do y'all nurses strike? Do y'all know what strike is? Oh my God, in the United States, our nurses strike. That means they just go off the job. They walk off the job. They plan it. They organize it. And so when I came into this organization, they called me because the nurse is walking out in 2 weeks, Sharonda. So I had to talk to the team. And I'm going to remind me to, no, I'm going to tell you now. same story though. But what I want you guys to know with those metrics is that the nurses were saying we're short staffed. Administration was saying they're seeing 130 patients a day. I'm not giving them 15 nurses at the 7 o'clock hour. The staff is saying we're seeing way more patients than that. I look at the stats, but the CEO is making moves off of what the data says. So now I'm observing. So when I go in, I observe. I follow the nurses, I follow the team, I pay attention. Guess what administration was missing? Administration is not boots on the ground, but they're dependent on this data, just like the rest of you. What was happening when patients were arriving to the emergency department? If they didn't make it to the triage nurse, they never got in the system. Oh, okay, so what does that mean, Sharon? That means they might be seeing 150 to 180 patients a day. They're not getting in the system. So then I clocked how many patients were walking out on an average. So on an average day, we had about 15 patients walking out of that department that never hit the system. So your leaders, no, we're not giving you no staffing. The nurses, you are insane. We striking. 2 weeks later, strike. But what caused that problem? Miscommunication, didn't it? We talked about communication. So I want you to see communication more as an oral thing. It's a documentation. It's a paper trail thing. Communication is because people make decisions, big decisions, how we're going to staff based on this, right? So that's important. I'm going to tell you about this one. I wanted to give you, I don't know why I put this here, but an example of the black button near the station. Inspect what you expect. You said you guys are doing all these things. I saw all the plays. You say they doing all these things? Go check it out. So I go to the nurses station and we're doing code grays. Code gray was a violent situation. They're getting beat up all the time, getting hit by a patient, whatever it may be. So I'm looking at the policy and procedure. I read it, walk it through. Walking through, I'm the nurse. I either act as the nurse or the patient so I can see both sides, what's going on. When it came time for me to hit that black button to call for help, there was no button. There was no button. How the nurse is gonna call for help? The button didn't exist. So before y'all managers, leaders, put things in place, walk it out, talk it out. All right, now let's, and safety. That's how I empower the team. Everybody has a safety statement. Everybody's empowered, all the way down to the housekeepers. They can see things that we can't. Everybody is empowered to speak up, and they need to know what that looks like. I have a safety statement. If anyone has any concerns at any time, I expect you to speak up. That's how I start meetings. Because they don't say something about staffing. So, hey, you have concerns, speak up. So we could talk about gonna do it. And so with my culture renovation project, guys, you know, they say it takes years to change culture. I know that I can change the culture in your department between 90 and 120 days if you follow the plan. And what do I mean? I try to give you things that you can remember. So don't forget, I want you to solve, we're gonna solve for X, and I am X consultants, right? So the 3 Ps is gonna be your priority. You gotta focus on the people, the processes, and back to that paperwork, which is communication. People, processes, and paperwork. And guys, you gotta double down on it. That's got to be your priority. Now, I've seen other things that you guys are doing, but how do we execute? How do we get things moving? Like, how do we prioritize? I just told you, you need to prioritize. I call them pivotal P's because pivotal is crucial. So how do we prioritize the people, the processes, and the paperwork? Let's start with the people. You have to ask, but you have to do an independent assessment. And that's why I strongly recommend a SWOT analysis. And what I usually do is get the nurses, the doctors, an interdisciplinary team in a room that work with the emergency department, or especially my team. What do you think our strengths are? Independently, because what I saw is they'll get together. What you do, give each one of them a sticky note. Don't let them talk, and have them answer these questions. Then you look to see how many, if everybody's talking about staffing, then come on, look at your staffing. As if they say it's a 3, right? If everybody says that majority, prioritize what your team is saying. And then you have to give them feedback. You have to tell them what they prioritize. Does that make sense? That's how you get them involved. That's the boots on the ground. That's the frontline team. Got to carry your mission and have to carry your goal. That's the next thing. Share your goals. If they don't know what your goals are and what test they taking, how they gonna pass the test? If ESI triage time is supposed to be 3 to 5 minutes and you haven't told them that, how are they gonna accomplish that? But make sure you start with why when communicating. Start with the why. Make sure that they understand the goals, right? They have to be SMART goals. Do we all know what SMART goals are? Anybody want to tell me, or you just want me to read them off the time? Yes, measurable, and how you gather the data. Don't forget to make sure that it's legit, relevant, and a target date. Very important. SMART goals. Break it down to this level and explaining it to them. And if they don't understand that, we'll do it again. Did I say something wrong? What didn't make sense? Tell me what you got from this. How did this translate to you? We all speak the same language, but we hear something different. And so we have to have somebody, just like you have to ask your patient, tell me what you heard me say, right? We have to, now when we get to the processes, I'm on the processes. We just talked about how to prioritize the people, right? You definitely need to be able to have a shared mental model. I think a lot of you said something similar. You have to have a shared mental model. That's what's going to change the culture, right? So because it's the values. What is culture? It's those values that somebody's taking in. It's those behaviors that they're putting out. And so in order for us to have that shared mental model, you got to have pre-brief checklists. That put them ahead of the game to get to think about what they're doing before they do it. In a chaotic environment, everything's happening in the emergency department. So they have to be able, our goal as leaders in the ER is to remove non-value added steps in your processes. Our goal in the emergency department is for you to commit things to muscle memory that you can commit to muscle memory. So you can think about critical care while you're taking care of your patient. You shouldn't be thinking about things that can be grabbing this, grabbing that, what goes with this. No, those things should be committed to muscle memory. And we'll talk about how to get that there. Standardized processes, ensuring that it's all what standardized across the team. Everybody understand it. You have to come together and talk about it to make sure we all on the same page. I told you, documentation is communication. If you're in the ICU and I'm in the ER, don't you want to know the story of what happened to that patient when that patient came to the emergency department? You have to document. That's communication. It's not about you when you're documenting. It's not just about you. Every other interdisciplinary team has to read that document and they need to understand it. Why? Because we're diagnosing and treating based on what somebody else said. Tell me, doctors, you're treating. I know you do your own assessment, but I hope you still read the nursing assessment. You still read whatever else you needed to read, and that it was accurate, and that it wasn't missing, because if it wasn't documented, it wasn't done, was it? So please make sure you understand the importance of communication, because that's a matter of life and death. So I always like to talk about starting with the why. People don't care about the what and the how. You can tell them later. If you don't tell them the why, I think they ignore you. But anyway, AIDED is what I like in the emergency department because it allows you walk in. AIDED means acknowledge, introduce, duration, explanation, and thank you. So I walk in, I acknowledge the patient, right? Acknowledge, I introduce myself. I give them the duration of the stay. I give them the explanation of what we're doing. Then I tell them thank you for being with us. Because you could have went anywhere. You could have went to another hospital. But you came here and allowed us to take care of you. So I love AIDED. Bar. So frameworks, guys, that's the game, right? Frameworks. Just make sure you have a framework. Don't have to be this framework, but make sure your team is on the same page and know what your framework is. Speaking with your doctor, tell me, go ahead. Assessment and recommendation. So you talk to the doctor, what's going on with the patient? You give them the background, what was your assessment, and what's the recommendation based on what y'all generally do or protocols. Because you know the doctor don't want to be told what to do. Be careful there, but just make sure you say, hey, here's what I'm thinking. Because you matter. You're the one with the patient. The patient has the most information. Don't forget that. And when we talk about the people, The people is the patient as well. Respect the patient wishes. Stoplight reporting is another communication piece I love because you do that with your team. I throw up a stoplight. You guys ask for something, they ask for IV poles. Okay, we'll get them. I put that in the yellow because we're going to get them on December the 10th. You guys ask for it in September, they'll be here in December. Yeah. CFO said no. Oops. IVs for December in red. Not this time with explanation. Right? You understand? And then green is to go. IV poles on the unit. But that's how you know how your team act like you don't do nothing, or you didn't think about them, or they just forget all the things. That stoplight report will remind them. All you gotta do is pull it out your desk. They won't. They come in late because they got that stoplight report. And if y'all want any of those, I can be sure to share those with you. So moral of the story: input, pivotal, crucial. People, processes, and paperwork. If you take care of the people, the processes, and the paperwork, the patient care and the profits gonna follow. Period. And if you document, you captured it all, so you're definitely in the United States are gonna get your money. I know other institutions, it's not all about finances, but I know in our country, if you earn the money, you get better technology, you get better things that make us take care of the patients better. That's just how I'm gonna say it. So the ER factor. I'm finna wrap it up because I only got 2 minutes left. So ER factor, that's important to me because this is it. About work. This is the engine. Teach our team how to recognize emergencies. Everything is an emergency, but how do you recognize a true emergency? So we have to teach them that. Then we have to teach them how to respond rapidly. Remember I talked about time is tissue, time is muscle, time. You gotta respond rapidly. Everybody needs to understand their role and responsibility. Everybody needs to understand their roles and responsibilities. A cold situation where people don't know what they're doing, bad outcomes. Each and every team member must be respected. Each role must be respected. I've seen cold situations where the EKG tech run in and the phlebotomist run in and they choosing who get priority over the patient, right? And try to take anyway, demands respect. And it goes back to that safety statement. That's why I say housekeepers in my emergency department. Speak up. What do you see? That's important to the life. Review every last one of your successes and failures. Review them, guys. Make sure you review it and make sure you reward success and make sure you rehearse the failures. Rehearsal time. It's time to mock codes, mock transports, mock it up. Practice. Downtime. Tell the CEO, no, we're not flexing and sending staff home. We're going to practice a code with EMS, right? And then you refine your processes. Your staff's going to give you some information. That's that staff engagement. Staff going to give you more information, and you're going to refine and revise that process. So 3P squared times ER factor equals what? Who knows? The patient, positive outcomes, profits, high reliability in healthcare. When I go into these emergency departments, I look at their ESI. We have ESI triage, ESI 1 through 5, ESI 1 through 5. Very important. You have to compartmentalize your department. Everybody has to know all the turnover times, how long a patient should be in this room, what is this room used for, those type things. You have to draw that out. I didn't bring that with me, but I have examples of that. But what do? We decreased left without being seen by 61%. Patients are no longer walking out the hospital now. Patients are satisfied. It went up by 20%. It's hard to move our patient satisfaction scores with the survey company we use. Length of stay for our discharge patients were reduced by almost 20%. And then we had a door-to-door reduction, which was the main goal, right? This was the byproduct, but the main goal by 65%. And that was just one institution. I do this in a lot of hospitals that I go into. This is important to the CEO. Ambulance, somebody in the United States, they're charging the hospitals if the EMS providers stay there too long. Yeah, so that's a problem. So we had to drop that drastically. And when the young lady spoke earlier and talked about redesigning her triage process, that's the front end, and we worked on the front end process, what she was talking about. And then we no longer went on diversion. If y'all diversion is closing the hospital, basically closing the ER. We can't take no more ambulance patients because we oversaturated. We can't do that. I dropped that by 72%. We're hurting the community if we do that. And then 58% reduction in wall time. That means the ambulance people came and just stayed on the wall. The goal, the key is execute. Execution of that ER factor, right? Prioritize to build the P's, build a SWOT analysis, execute elements of the ER factor. Make sure you reinforce communication. Scan the code here, and you guys give me feedback. Let me know how I did with this presentation. That'll be very great for me, right? And then this is how you contact me. Thank you for having me again at the 16th International Healthcare Hospital Management.
Amazing. Thank you so much, Ms. Sharonda. I think we can all agree that was extremely invigorating and innovative. After lunch, especially, got us all energized. Thank you so much. Absolutely wonderful.
Right quick, hey, if you scan me, what you'll do is I'll get your contact information. If y'all want any of those templates, any of those examples that I told you about, I will send that your way. I have all kind of goodies. If you could think of anything else, I probably got it in my bag of tricks. So just give me a call, okay? Thank y'all so much.
Is this all? Thank you so much. Absolute pleasure. Lovely hearing you.
Thank y'all for listening. Oh, that was my set. Okay. Thank you.
Yes.
I have a question.
Oh, we didn't do
Yes. That's a very interesting presentation. Thanks very much. There was one thing that I want to bring up over here. Is that how do you deal with, because you're talking about culture, how do you implement a no blame culture?
So I think that was a good question. I honestly believe it's built inside of that process, right? If you notice what I didn't go in and blame any nurses as an outsider, because I come in as an outsider, so I can see a whole lot of different things. When you standardize process, when you show everybody what change look like, when you identify your informal leaders who work not intentionally, but because they've been here longer than you, those type of things, pay attention to that type of stuff. Checklists, like we talked about, that's how you get your no blame culture. Always, and then your leader. Your leader, how do you deal with things that are horrible and things that go wrong? Does the leader place fund? Does the CEO place fund? Right? So we have to start from the top, and we have to make sure we have accountability and standardized process. That's the only thing I can think of. Build it. You have to, it's really built into everything that you're doing. No blame. No fault. Somebody died, no blame. Come in together. What happened? All gloves off. Do you guys have meetings where there's no rank? I had one hospital where we wanted to talk about some things, and we pulled a badge off. When I pull my badge off of my department, they know we free to talk. And building trust, building those relationships, and making sure those standardized process.
And I want just to highlight one thing. In the US, because I know from my cousin, she's a nurse. In the US, you just mentioned about jobs and responsibilities. You have layers. We don't have that. We don't have something called nursing, a prescribing nurse. Nurses are not allowed to prescribe.
Okay, nurse practitioner. So you don't have the nurse practitioner.
No, we don't have nurse practitioners.
Okay.
And we don't have physical assistants.
In the ER?
In the ER.
Is physicians? In everybody's department, everybody, does everybody?
Oh. Can you pass down?
Okay, okay. So you guys don't use no levels. How is your level?
Oh, just we have nurses and doctors.
Okay.
No, but this is very good. First like to know what you have.
Okay, she said that's good.
Yeah.
Recent, but yeah, but this wasn't, they started to change in the whole system, but recent. The market since 2006, we didn't have that.
Yeah, as you said, it's just a couple of years back.
Couple of years.
I think it's, to your point, it's very infancy stage.
Yeah, infant, yeah. Can I?
So here's the good news, we all have been through this, and so if that's a way that you wanna take your team, then we can send you whatever you need, and it's share practices or whatever, if that's something that you're interested in presenting.
Can I just go back to your point about blame cultures? I think it's also key. I just want to add a point there because I think any organization needs to understand that failures will happen because that's life. And instead of shifting from blame, shifting to failure, and also making sure that your team understands that failure is a chance to grow and to learn. Failure, you need to sometimes fail in order to succeed. Sometimes you have to even watch somebody failing, knowing that they're going to do it just for them to learn. And then encouraging that team member to then say, okay, how can we prevent that failure? What systems and processes can we put into place and utilize that as an opportunity for training? So it's an opportunity for everybody to learn, an opportunity for training, and an opportunity for accountability. Because I think there's a point where it's not blame, but accountability. Let's own this mistake and let's work to improve it, put in systems. I often joke with my manager, I'm like, right, what system do we need to put in for this human error? Because human error will happen, but many systems we can put into place to avoid that.
One more
Safe failure.
I was there, so it was in San Francisco. What they did was make sure that they were fair across the board, period. So before anything went out, they had a team of nursing director, you didn't just have a clinical team that went through like safe workforce, safe how we being fair. And then before they moved forward with any disciplinary action, I thought it was a lot. That was a fair treatment process.
Thank you. Look, as always, stimulating great conversation and chit chat. Thank you very much. So next is my pleasure to welcome Mr. Dina Naidu from UAE also, Group Chief Nursing Officer at ASTA. He's a strong advocate for AI-driven which is what we want. AI is the future. It enhances safety, resilience, and operational excellence. He'll present on the topic AI-driven nursing transformation for safer, smarter care, artificial intelligence in nursing, enhancing patient safety, workforce resilience, and operational excellence. So we look forward to hearing. Please put your hands together for Mr. Yeah. And CEO Sam Almond.
Okay. If I were 22 right now and graduating college, I would feel like the luckiest kid in all history. Because there's never been a more amazing time to go create something totally new.
The long-term future that you described is super intelligence. What does that actually mean?
A kid born today will never yeah, this is like a crazy amount of power for one piece of technology. And it's happened so fast. This thing is remarkable.
If you need to know more, watch our full interview with Sam.
So from a culture revolution. So while watching Cleo's podcast with Seth, who, if you haven't already associated yourself, very intellectual guy in AI, something stopped me cold, and I wish I was 22 again. A child born today will never be smarter than AI. All right, so that's the CEO of OpenAI. And if you thought the American guys weren't smart enough, look at the latest research that's coming out. 50 of the richest country in the world, 7 from Europe and the rest of the world, 9. And of those 33 countries, it's about
a lot of investment into tech. Why did Apple diversify? Oh, you can't hear. Oh, sorry, you can't hear me? Is it better now? Yeah. So, AI is a fascinating process. So, I'm actually a part-time in UAE, but I mean, my national country is South Africa. And way back in 2010, when I designed the first quality scorecard, people thought it was crazy 10 years later when we had 128 different matrices covering the full landscape of clinical care. But we built in predictive analysis within that period. So, AI was around for a long time. So this whole process wasn't a headline. This wasn't a hype. This was the architect of modern AI, calmly stating a future that's already unfolding before us. Oops. Ladies and gentlemen, it wasn't science fiction what you just saw. It was the quiet truth. And it doesn't force us to reimagine the very foundations of healthcare. Sorry, this. And the more I sat, the more surreal it became because, yes, this is a ripple effect in healthcare. No one seems to be talking about it, but we're going to talk about it today. So let's have a look at some of these concepts. A nurse starting today may never again be the most knowledgeable person in the room, and you must be thinking I'm crazy. Not because they lack skill, but because intelligence is no longer bound by human restrictions and just by the evolution of what happens. Yeah. Trust me, guys. Currently I'm sitting with two of the most really smart guys in AI, and they both medical doctors, and they're working with a team of nurses. And I'll tell you why that's the changes in AI come out better and that engagement around it. So you might find that the care team may find the most trusted colleague that you've ever had. Because this colleague doesn't need breaks. And you don't need to sleep. It just carries on working. Tell it to the CAs, they'll love it. Now, when we look at the Stone Age of healthcare, this is not the medieval surgery time, guys. Often we see these poor clinicians and these nurses clicking 18 times. They're clicking and clicking and clicking and clicking, and this patient's journey is happening. This isn't a tech problem, guys. Let's face it, it's a leadership problem. Are we designing care for the past or for the future? Are we empowering nurses to lead in an AI first world? Are we brave enough to rebuild and not just upgrade? The thing about upgrading legacies, we are too. There's something that are pretending that there's AI in it. No, they're just upgrading legacy systems. So be very careful of the systems you choose and you buy. Sorry. God. Yeah. My late great friend Steve, phenomenal man. It's not about the faith that we have in technology. It's the faith that we have in people. He had a vision there. And a guy like Bill Gates says that doctors are replaceable, but he never mentioned anything. Sorry about the doctors. He never mentioned anything about us replace. Yeah. So this paradigm shift that's happening, colleagues. So what does clinical decision making look like? Think about that. How do we train for judgment, ethics, and empathy? And what tech do we keep building and trusting? What do we keep building and trusting? See that? And that's not me. If we need to stop thinking as AI is a trend, even for some of us that are above 65, stop fearing that will be replaced. Start designing with it. Nurses and doctors co-create. Don't let the techies do it for us. Build tools that let nurses do what they can. Am I right? That's about the compassion that we have, the judgment, the courage. All those things AI is never going to replace. Trust me, guys. So, what will the future of healthcare belong to? The ones that will AI. The ones that design the systems. The ones that protected the human and the heart care. So the future will belong to those of us who have faith in the profession. And Steve mentioned a few of those things. We died quite a few years. The faith in our people and those that helped design the AI. AI didn't start yesterday. It started a long time ago when we started analysis. So as I researched a whole lot of things, I come up to understand that this is about a care intelligence process. And we'll unpack some of the stuff. What does it really mean for nursing? We have to step away from the buzzwords. AI is not a gadget, so it's not like a little gadget, that I'm going to go out and I'm a gadget guy as well. So it's different. It is a paradigm shift and a big paradigm shift. So there are 3 pillars when we look at patient safety, workforce resilience, and operational excellence. So let's look at, I'm just going to highlight a few things. Now, if we look at the silent revolution that's taking place, AI-powered monitoring now picks up these physiological changes in real time. Everything's about real time. It's not about this is processed in real time. And our decision supporting tools, and we've done a lot of work around falls, infections, and complications before they happen. So therefore, near misses, alert reporting, and non-blame culture, all those things are important. You don't need AI. And AI manages the paperwork, guys. There's just too many tasks that are being driven. So this can manage the people and not these screens. And that often happens. This is safety design. We're not reactive, but it's about being predictive. And that's not the reality in the back of it. So many few of these points. When you look at the nursing, it's not meetings. Not because of shortages, not because of an aging population, 51%. 44.1 million nurses will be needed. There's a shortage in 2030. But because nursing is the backbone of care. And we need to lead this transformation. One nursing. We know this global demands for AI is reshaping our leadership is evolving. There's nurse-led innovation. There's also augmented care, compassion-driven systems. So the 3 things we look at here with AI, we look at what can help us with predictive scheduling, even in your ED, how we balance that workload, how we balance the skills, and how we reduce the stress actually before it goes up and prevent burnout. AI-driven training is very important. In a simulation environment, that's a lot of work on that, clinical judgment as well. And I think not to forget the emotional resilience part of it, but how we automate. And we've done a lot of work around virtual coaching that takes care of the repetitive and the mental load. So we need to have nurses be nurses and let the tech take care of the rest. So have a look at this point on top. That must really go doing. They just work. Trust me, it was. So a lot of other work that we've done around automated documentation, predictive analysis, AI, enabling logistics and robotics. A lot of good work has been done around robotics with patients that are currently hanging around. They feel the sensation of the paraplegics actually walking with the robotics and the sensation. The future of hospitals is not about having your smart building. You can have best building in the world. You can have a 5-star a menu. But it's about having that intelligent ecosystem, we believe. I'm just going to skip that last one. So delivering an intelligent ecosystem is what we need to realize. And really, this is going to blow you away. It's not really about tech as well. It's about trust, empathy, and then the design. Stop fearing AI. We need to be co-creating. We need to start designing with it, the nurses and the doctors in this room. So when we look at care intelligence, it's a compassion-led design and intelligence-enabled care. But the beauty part, and not taking you to what we see, care intelligence equals empathy and trust. So the smartest thing in the room doesn't have to be you, but the most compassion. That will be ours to keep. There are brilliant clinicians and nurses working out there to know people by legacy systems. Unfortunately, chartered accountants, guys in information technology and digital transformation are making decisions for nurses and doctors. Guys, we need to stop that. We as clinicians have to make the decisions. They need to write the checks. Thank you.
Really brilliant. What a mic drop moment that was, wasn't it? Mr. Dina, thank you so much. Absolutely wonderful. I think absolutely stop fearing AI. I mean, if you're fearing AI, you're fearing the very future that you're living in. And I think, as you say, we need to embrace it and work with it. So thank you very much. Amazing, amazing lecture. Any questions, please? None at all? Okay, please join me in thanking
This year, because obviously I don't.
You did though use AI to generate the PowerPoint, didn't you? Those pictures in the background.
You gotta use smart AI because remember if you do the generation around it, you can always change the color scheme. There's no way of it. You just punch it in, tell it what it does. It can get you very deep into space, like the key intelligence slide. You have to be a smart guy. I have a low IQ and I did that.
It's good.
One question. You didn't mention anything about security, confidentiality,
Yes.
and the privacy.
Yeah. So I think all AIs that what they're trying to do now is put that patient information to your hands, close to you.
How?
It doesn't belong to the hospital. So for instance, if you have an AI system in your hospital,
notes when the data does not happen. The consent has to be given by the patient to release any blood results and returning it around.
I've been, yeah, I went a lot of AI training and it's mind blowing when I look at it. It's amazing. Really, really, it will help the healthcare sector.
Do you know what guys do?
But when it comes to the data and where is it going, a big question comes into my mind because every patient owns his own data. So whenever you talk to tell them this point, they just go, we're working on it.
So just to remember this day was the 9th of September 2020. It's named half a name. That's all I can. It's the space in the next 12 to 18 months. Patients' data belongs to patients, and they will be getting money for that.
They went to us or to the patients of
People are using patients' data for research and all those kind of things, which is not true. You guys are patient, that information belongs to you, so you make some dollars. Yeah, we don't know whether the power system between US dollars or British pounds yet.
So it's interesting how you train. We implement a lot of AI training for our dental nurses actually, and it works amazingly well because, as you all know, nursing, staff retention, staff turnover, operations, we got to a point where really, if we do have anyone leave, we bring somebody in, and within 2 weeks, our new nurse started and trained with plug and play, and
that's
completely led by him. Well, yeah.
If you go to the UK, there is a guy that's going to be released the first gateway. There is going to be accreditation of as being a medical device. So there's a lot of accreditation and legislation and privacy controls behind it. Red flag is not if it's not registered as a UK design, then we take that.
So much, yeah. Right, so a bit of a change of schedule. We do have one more speaker. Oh.
Late in the afternoon. Oh, let me put my glove. Yeah. Okay. You want the sponsor's name on it? Yeah, thank you, thank you.
So it gives me great pleasure, last but not least, to introduce Mr. Abdullah Hanura. He is part of NMC Healthcare, and today he's going to be giving a talk on titled Advancing the Care of the Deteriorating Patient Using EWS and RRT at NMC Healthcare. Please, could you welcome Mr. Abdullah?
For you. Yeah. Okay. Please help us out to Mike. Thank you.
How are you? I think it's a very, very challenging one to stay on the stage at 5 p.m. And I still have eye contact. Not everyone looking at his phone. Okay, so Dr. Marwa, right? Dr. Rana has introduced me. I'm not gonna repeat myself. Thank you so much for having me in this forum. I think the topics that I have seen from the morning till now, it's really evolving topics. And it needs a very, very bigger forum than this. Well done. Very well done to each and every speaker. And every one of you has a vision. Every one of you really added to me, to everyone, or even the people online. Talking about patient safety, which is I think one of the theme in this conference, and taking the stress management that was being taken in the morning to discuss about the situation that has the highest stress, which is the cardiac arrests and the deteriorating patients in terms of the high stress for the family, and taking to Sharonda. I think she just made it very, very difficult for me to convince you on my presentation after her nice presentation. Very well done. Also, the AI, I'm very happy for what I've said, of what I've heard today. It's really, really good, and the future is coming. But I feel, because I'm a clinical person, the clinical judgment is irreplaceable. That's why we all are here. Your clinical judgment as a nurse or as a doctor, I think the robot may find it difficult to make the clinical judgment on a patient who's on SOP or shortness of breath, and you need to just run to do the stuff and save this life. So, as Mr. Dina said, don't worry, we are still here. All right, so taking you to our hospital or our organization. We are from NMC Healthcare, which is having around 12,000 employees, and we've got around 10 hospitals, tertiary hospitals in UAE, and even we have a branch in Barcelona, and some branches are in Egypt. So it's one of the largest private sector here in UAE. We provide state-of-the-art services. We have a lot of services, except some services that is being given to the organization. And I'm proudly says that I'm with NMC for 10 years now. Is going to, okay, how the critical care is going to respond to those deteriorating patients. Is there any problem?
Just don't turn it off. Just, we can minimize it.
Okay.
You just don't need to be turned.
Oh.
We'll just minimize it. I think it's cool.
Okay. This is working. This is working?
Yes.
Sorry. Okay, thank you. So this is the disclosure. I don't have any financial things to disclose, except if you're giving me 1 million dirhams today. But I don't have any. So the content, I'm not gonna go for it. We will go for the slides. So this is our team, the people who respond to those who are deteriorating in the wards and in some of the areas as well. Part of them is from the emergency department, and the majority is from the critical care. And my topic is so talking to AI, do you think that the RRT, you know what's RRT? Rapid Response Team, the team who respond to the critically ill patient. So our future or our current situation in terms of response is this one. All right. So do you think the future is going to be this one? Do you think they can respond to those patients and do some action? They may do CPR, but they may not go to the reversible cause. That's why the clinical judgment is there. Okay, so introduction to my topic. So I'm going to talk about the systems that we implemented to just take and identify those patients who are sick and they really need help. So it starts with a system called EWS, and it's an international one. It's Early Warning Sign Scoring System. And this system, it talked about the early recognition is critical. Identify patient deterioration early, integrate EWS and RRT together, timely escalation. So EWS, RRT, code blue. There's another things called code purple for maternal emergencies. So EWS is the key of the start of us to identify those patients who are sick in the inpatient wards. And then from there, that EWS takes me to do some action. So based on a score, I do some action. And if I reach to the highest score or the higher score, it is based on an evidence-based algorithm. And I then need to activate RR. So if you look here, golden rule is to identify, mitigate, escalate, and do it all sooner. Sooner. All right? My focus here is on the nurses. So when we want to understand early warning score, so it's a clinical tool for frontline staff. It's an evidence-based one. It's not dependent on patient acuity. It's a system. It's not just a score. It supports clinical decision making. It is not a substitute for clinical judgment. Do you agree? It's not a substitute for clinical judgment. Do you agree? Healthcare providers, nurses, doctors. All right. So the process is we admit the patients in the general ward. We measure vitals. We plot the vitals in the form. We calculate the score. We take actions based on the score, and we document the action. What are the benefits of the EWS? What we are looking for here. I want to identify those patients who are sick. I want to reduce the ICU admission. Do you think it's an international goal? Yes. If you have the best practice in your facility, you aim to hit this target. You aim to hit this KPI. It's a KPI to reduce ICU admission by using EWS, identify beforehand, and then the doctors and the nurses goes to this score of 1 or 2 or 3, and then do some actions to just reduce this deterioration. So we empower the nurses, which is our main focus here. The EWS starts with the nurse. Prevent cardiac arrest outside critical care areas. This is one of our second target, and you're going to see this in the data we have. We reduce ICU admission, as I said, culture of safety, of course. If you've got these kind of systems to respond to those critically ill patients or deteriorating patients, that means there is no patient left behind if you have those systems implemented in your facility. Of course, teamwork. Responsibilities starts with the nurse. We need to assess, calculate, and escalate. Physician, they need to respond immediately for the call of the nurse. Doctor, the score here is 2, and the patient's having 1, 2, 3. I need to do some actions. He needs to come and check and do the action based on. Unit in charge has a role. They need to make sure that everything is available, criteria. Code Blue Committee. So we've got a counseling team. They are the one to chair these kind of systems in the hospital. And talking back to Sharon, when she said, do you have auditor? Do you have auditor? Are there any auditors? Audit the auditors? Yes. The Code Blue Committee in the facility, they are the one who do the audits. And this is one facility. And if you're talking about the group, there is another committee for the whole group. It's called Critical Care Steering Committee. They do audit the auditors of the facility. So this is there. And it really gives a lot of and big value to this. Applicability, it applies to the inpatient wards, labor and delivery, dialysis. This is optional. We made pediatric OPD optional. Why? Because the flow in the pediatric OPD is very, very high. A lot of patients, a lot of child comes in, and we just put it optional. Why we put it optional? Because sometimes you may receive a baby who's blue in the pediatric OPD, and he needs a response, a very fast response. So we put it there. But it is an option. It does not apply to the outpatients. It applies to the inpatient, right? It does not apply to critical care because eventually we are the one who respond to that EWS deterioration. Score of 0 every 4 hours. So if the score is 0, you will check it every 4 hours. So this is an example of the tool that we use, and we have a tool for each and every age. So for the newborn, there is a tool with a criteria. For the children, 29 days to 12 months, tool for that age. 2 years, different criteria. 4 to 5, different criteria. 12 to 18, different criteria. Adult, another criteria. OB/GYN patients, different criteria. LTCU patients, different criteria. Type or category has its own criteria. So regardless of EWS, always escalate if you are concerned about patient selection. And I'm here to just focus on this. I want all the nurses to speak up. It starts with you in your place. If you speak up, if you see a patient is deteriorating in front of you and the AWS tells you wait for the doctors until he arrives, do not wait. If the score is telling you activate RRT, do not wait. So please activate RRT, get those systems in your place. If you don't have, if you have it, raise the awareness about these systems, make sure that they know what time and they are not going to be punished. There will be no blame culture if you activate because you're saving life. So one of these escalation systems is, as I said, RRT, and it's an international thing. Some facilities are using something called MedCall, which is like also a medical emergency team response. It's an Australian standard, but this is American and European both are agreed. So what's RRT? It's a multidisciplinary team. The response to patients is that we run like this to those patients. So it's outside critical care areas. It does not replace the usual communication. So equipment that you need: emergency trolley, crash cart. Do you have crash cart? Of course, yes. But the most important thing in the crash cart, because I have done a lot of investment in this crash cart. You go to one crash cart and you see everything is upside down. It's better to just streamline it and make the top 3 of things. It has only the defibrillators. The other equipment you should be figuring out and finding out the way how you equip your car to make it easily accessed during those emergency times. What are the emergency times that you use the crash cart on? RRT situation and code blue situation. So it should be very well suited to be utilized, and the staff who are there, doctors and nurses, they should be very well trained on. Vital signs monitor, pulse oximeter, syringe, infusion pump. The team responds based on this criteria. It's a sample for criteria for adult one. So let's say respiratory rate is less than 8 centimeters. Do you need to wait? No, don't do it. All right. And based on this, there is a lot of criteria based on the age group and so EWS starts the process and it starts with the nurse. So my focus is on the nurse, and once it scores high, we need to check with the team leader, activate RRT. If you don't have time to consult the team leader from the room, activate RRT and nobody's gonna blame you. You better get the team in until you wait and the team take time and then something happens. And I'm gonna share with you this. I'm feeling shame if I share. It's better to share the wrong practice. So for us to learn, for you to learn, because everyone is standing here and everyone is sharing the best practice. I will share with you one example that happens 3 or 4 years back. It was a children, 2 years old. The children, yes, we know. But he had a situation, he was extensively crying in the ward. And the nurse was standing there, doesn't know what to do. And she was calling the GP based on her EWS score. And GP said, okay, well, I'm coming. And he took 15 minutes. And then this child just get into, was constantly crying. And then he started to cry a little bit, slowly. Activity goes down. Until he had. I'm so sorry to say that after 36 of CPR in this child, I know there was congenital anomalies, he couldn't make it. I know there are contributing factors that he couldn't make it. But the learning lesson from this, it was a simple and of course, and we have done a lot of discussions on, do not blame the nurse, but we blame the system that she was not fully, completely empowered to activate RRT and not to wait for this doctor for 3 minutes. So from here we say awareness is very, very. So we say in the announcement, once I hear or once I find the patient deteriorating, then I will go. RRT, adult child donated based on the category, floor name, ward area or area name, and room. And that is very, very important to tell the correct age, because if you say it wrongly, the team may respond wrongly and everything is upside down and the patient is being left behind. So every piece in this presentation is really important. First responder, if you are there, do not leave the patient alone. Wait for the second person to get the crash cart and start. Everyone should happen. Right? So once the team arrive, they take the leads, they know what's happening, and then they start. The team leader has to stand. RRT situation or is exactly like the code blue situation. So the team has to make sure that his team is there, assigned roles. Closed loop communication is very, very important, and everyone should know what he does. Recording should be there, and everybody starting the interventions. After 5 minutes, they do the evaluate, and they do the evaluate, that they do the things, and then, as I said, closed loop communication. So you've got to reach some outcomes, right? So once you in the evaluation time, you've got a couple of three, either one of those three. Either the patient is improving, or the patient is not improving, same, or deteriorating. If improving, then it is your clinical judgment as a team leader to say, okay, I'm going to keep you in the ward and I'll put monitoring based on database criteria. Or if he still feels that he needs to go to critical care, it will be discussed, of course, with the team leader. If the patient is not improving or deteriorating, also transfer to ICU. If deteriorating and you reach to the situation that the pulse is no more pulse, patient lost his consciousness, then these signs is absence of life. So converted, upgraded to code. Are they the same team member will be responding? What is the point of activating code? Sorry, no. So RRT, RRT is mainly from the ICUs and the doctors from the ICU comes in because it's inpatient. But code blue, you get more people. You get the ER physician, you get the other nursing supervisor, you get one more nurse, and you get more people. All right, this is the documentation. It's very simple, very easy. We're working on making it on the system as everyone now is having electronic system, but this is still hard copy because we need the signature and fast quick documenting, but we're working to put it on the system and it's very, very easy. You put the facility name and the date of the case and the patient label, who responded, reason for RRT, what was the action taken, vitals every 5 minutes, our signatures form. It has everything. All right, nursing notes, you should make a RRT note and physician notes. So, and guess what? Both systems has been standardized and implemented across the world. So firstly, we have done this in NMC Royal Khalifa, and we have taken it through the Critical Care Steering Committee for NMC Group. And it was our first focus as it was not available in majority of the hospitals in NMC. So we have driven this project to all of the hospitals in UAE, and I had the honor to lead this project in all hospitals, and I'm proudly saying that we are standing now, it's very, very successful, and we've got a lot of patient safety, patient that we prevented cardiac arrests, and it's really, really important. So the steps of standardization, we launched the Critical Care Steering Committee, and these people are the group, the subject matter expert, the group CNO, and everyone, Dr. Kapana Krishna Reddy, she is our chair for Critical Care Steering Committee across the group, and from there we go. So we formulated the team, points of contact, and we've done online meeting. We made WhatsApp group. We made policy reviews based on the evidence-based practice, mostly in NHS. And we went to each and every hospital and we trained the trainers. Before that, there was a challenge and to make the policies accommodate three different authorities, because here in UAE, we have DOH, DHA, and MOH. Yes. And now some differences are there, but we managed to collaborate all together and we made one policy. So these are the training tools for all facilities in UAE. I don't want to mention all hospitals. Implementation, we made a memo from the CCO, Chief Executive Officer. We went live on November 24. We monitored the facility level and we get feedback from the company. So some experience or some numbers. Since we started the RRT in our facility, we've got very low numbers in the initial years. However, after the awareness and couple of instances we looked at and we increased awareness, numbers really increased. And here is the comparison between the RRT. So if you see the RRT curve is rising and the code below is really going down. So this is really very, very important slides. And this is the number of the non-compliance to activation of RR. The initial years, awareness was really less. That's why this number was really 15 per year, 18, 15. Once we really increase the awareness, this number is really reduced. How we monitor this with the audits, and we get these numbers. And of course, each case we do mortality and morbidity meeting, and from there we take the results. This is the effect of the RRT, as I said. This is our target to reduce ICU admission. So if you look at the gray number, this is 96. So if you look at 2024, we have 96 RRT managed in the ward. 52 went to the ICU. Which one is bigger? Of course, the 96, which is our target. We want to manage in the ward and reduce ICU admission. So this is in percentage. We are in 65 percentage, 25, 57 so far. This is also, we monitor the response for RRT within 5 minutes. Code blue 3 minutes, response within 5 minutes. It gets a bit problems, but we manage it to reduce the non-compliance rate. This is the last slide, and it's close to my heart, which is the number of cardiac arrests outside critical care areas. So initial years, we had 21 cases cardiac arrest outside critical care areas before the RRT and the AWS. After we implement those systems, I can probably tell you every year we get 1 case, 2 cases, and every case is just to prevent, these cases we monitor case by case. I can tell you one of them, just last year case, is just sudden cardiac arrest. Patient was going home. He was just waiting for the doctor and he got it. So it was really not based on, not much. So take home message, plus EWS, identify patients who are at risk. Clinical judgment is important to consider. EWS criteria is met. Do not wait. Activate RRT. Activating RRT will save lives. RRT reduce ICU admission, reduce cardiac arrest outside critical care areas, and our future is integration into the system. And this is my last message. And ومن أحياها فكأنما أحيا الناس جميعا. And this means who says it or who saves one, that means it's the one who can save all. And healthcare providers are here in this life for a purpose, which is to save life. So be loyal to this principle and save life and shout out loud for patient safety. Thank you.
You so much, Abdullah. I know it's not easy finishing off the lecture, but you kept us all engaged and the room full, and we're all here listening to a lovely lecture. And what a beautiful ending! And I'm into that. So thank you so much.
The sweetest is the beautiful end.
Yeah. We say the best to last.
Any question? I know that we said always interesting.
We're not in this. This is it. This was so I love this. I loved everything about it. One thing I wanted to ask about is I saw your team.
What I didn't see was the med surge nurse or the floor nurse on your team. Now, not the actual rapid response team, you know, the ones that's running off and everywhere.
Yeah.
But the nurse that's actually caring for the patient, is she a part of the team?
She is.
Is she?
Yes, the first responder and the second responder is always part of the team.
Okay, so the first and the second responder are floor nurses,
All the floor nurses.
and then your ICU, your team. So we have 3 nurses on.
Yes, we've got 3 nurses on, but in the scene, in the ground, you get more. Because
Okay.
the first nurse and the second nurse responsible for.
See what I'm looking for. So when I started, I did RT. I want to tell my age, really long time ago. It was like when it first came out, right? And so the main point though was to get, if I'm saying this correctly, I could be wrong. If I am, I'm sorry. But here's how I recall it. We were to educate the med surge nurses from a critical care and or ER perspective. Because some RTs that have ER part of it as well. I didn't see ER was a part of the team. But with that being said, the point was to educate the bedside nurses so that we can prevent bad outcomes. You guys got some, exceptional things. The only thing I would recommend or ask for is to make sure we're educating the med-surg nurse on whatever was happening. Education was key to prevent. You guys did phenomenal, obviously, by your results. Thank you so much. I loved it.
Thank you. Actually, the main target for this presentation and for this project, for the 2 projects, the med-surg nurse, the maternity nurse, the VIP nurse, the pediatric nurse, all the inpatient wards are our target. And the training plan went through each before we publish it to the whole group. We made sure that this training reached to each and every nurse to know.
Nice, okay.
And that will be your trainer. And we make sure those trainers train all nurses. Around 5,000 nurses, let's say, we train them in like 2 or 3 years.
And your rapid response team has patient assignment. They're not full-time
Yes. They have a patient assignment and they clearly know from the first morning in the morning and when you put your assignment. Yes, this is your hour each day. And he is your body or she is your body. You look after your patients if you respond or if you run out.
I have seen the rapid response teams, that's all they do, which your hospital have to have the affordability. But I've seen that.
Well, it's important.
Yes, gotcha.
Okay, any more questions? Thank you and welcome to all of the team who comes from around the globe, especially from our Riyadh. And for this picture, forget about the previous presentation. For this picture, I can tell this is your team. You are the okay.
Thank you so much, everybody. Well, that concludes our conference for today. Thank you so much for all staying. And, it just gives credit to all the wonderful speakers that you guys are all still here, still smiling, still enjoying it. Time-wise, we finished well. So thank you so much. And we'll see you all tomorrow for day 2. Thank you.
Yeah, are you gonna do it on your phone? Is it okay I can take a picture? Can you both take it?
Oh, okay.
Wait, hold on. How do I get it to full screen? I'm just gonna pretend if I tell you to do it. No, like just gonna pretend. I'm gonna change the slide a bit. Like this. Tell me what to do. Change. It's just coming together. Wait. You can't go. You don't know how to treat. Talk to me. Speak. Just for the, we're gonna do this with you, by the way. Yeah, okay.
You come in out. The next.
Are we done? No, that's it. I'm only doing this.
Boring.
Oh. I know what this.
Yeah, that's what
Yeah. Thing. Just chit chat. That's how. Eventually, you know what? I honestly spend more time talking to them than actually doing the hygiene because it's like therapy for them. It is. They love it. That. Yeah, I'll adjust it. Okay, should we start?
Wait, no. Yeah, man, you're getting your pictures in there. All right, number 4.
Thank you. Right. Swap Rana, we're gonna take some of you.
No, not me. No. No, but here. But you too. Yeah. Down there. Oh,
Yeah. Station.
Right, okay. No shoes. I know. No, you were.
Put a nice slide up. Everything. Well, in the clinic we do everything. Let's do a nice one of that. Fully private. Sorry, actually, do you know what? I'm sorry. I'm gonna just pick a nice slide.
Very.
Like maybe this one or this one. That one. Which one? The dental chair. Oh, the dental chair. Yeah, yeah. That one. Yeah, oh my God.
Let's go make sure.
Right. Sorry.
I was thinking it's gonna be
The bliss part.
Acting of a patient, making sure you're understanding his needs. What are you looking for? And they're asking, spend that time. It's just phenomenal. The connection you can build, the trust, and they